and Dr. Pankaj Gupta to preside over the session. Thank you very much. I would like to invite Dr. LSM to the stage. Yes. Now stage is yours, sir.
Good morning, everybody. First of all, hearty congratulations to Team IDCM. A very nice organization. The first lecture is by Dr. SVM, I would say. Yeah. And without wasting much of our time, as the Master of Ceremony has said that we are short of time. So you can see his introduction, a very glorious person. And he has achieved so many prestigious awards. And I would request Dr. SVM to proceed with his lecture.
Thank you, sir, and good morning all. It's a privilege to be here, and again, after 15 days, I'm back in Vadodara. I acknowledge the presence of Virmani sir and Vijay, my good friend here, and thank you, sir, for being here. कुछ और है स्क्रीन में? Okay. It's not changing. दोनों काम नहीं कर रहे हैं, ये भी नहीं कर रहा है, ये भी नहीं कर रहा है. So my topic is hyperglycemia in pregnancy, diagnosis and management. Basically, we know the burden of GDM in our country, and we definitely lack in every field the data available with the prevalence and incidence of any disease, any chronic diseases. And it is true for, I can operate here. Yeah. Yeah. So this is going to be my agenda. I think my timeline is cut short by 5 more minutes. So I'll try to rush through. We know the diabetes, which affects 3.6% of the 4.1 million births in US, and this is the burden in US, and these are the complications of GDM and diabetes related to pregnancy, and that is why we need to worry about. You can look at the maternal, fetal, and neonatal complications. Now, the definition of GDM is diabetes diagnosed in the second or third trimester of pregnancy that was not clearly overt prior to the gestation. And of course, it's been steadily increasing with the rise of obesity and our lifestyle in our country. And recent estimates suggest that the GDM affects up to 15% of the pregnant women worldwide. And that's the burden. And I call it as a tsunami in slow motion, because we're not recognizing this tsunami, which is coming in a slow motion. And you can see here, 16% are due to diabetes in pregnancy, 84% is due to gestational diabetes, and 1 in 6 live births are to women with some form of hyperglycemia in pregnancy. So the occurrence of GDM parallels to that of IGT or pre-diabetes. We know the pre-diabetes burden is more than diabetes in our population as well. And the rates of GDM are estimated to be 3.8 to 21%. That's what I said. We don't have enough data in our country, but definitely it's much higher than the West. And studies also show that the Asian population have high risk of GDM compared to the rest. And by 2010, 22 million of diabetic patients were there in our country with age, you can see the 20 to 40 years, and nearly 54 million women with IGT or pre-diabetes with the potential to develop GDM. They're in that reproductive age group of 20 to 40. So that's something we should remember. But let us look at the risk factors for GDM. So you can see here the history of GDM in the previous pregnancy, history of spontaneous abortions and unexplained stillbirths, obesity, ethnicity, persistent glucosuria, strong family history of diabetes. All these you should make in a woman to suspect the risk factors for GDM. That's very, very important whenever we take history. And of course, we should look at why it is relevant to diagnose hyperglycemia during pregnancy, because it causes high risk of maternal and perinatal morbidity and mortality. Offsprings are more prone to develop metabolic complications in the future, and it can identify women at high future risk of diabetes and CVD, which can offer opportunity for primary prevention, which most of us lack in our routine clinical practice, so where you can definitely look at this. Now, the International Federation of Gynecology and Obstetrics, the FIGO, classifies, as you can see here, hyperglycemia in pregnancy, which can be diabetes in pregnancy or GDM. And of course, diabetes in pregnancy is which is before the start of pregnancy, and the GDM is diagnosed for the first time during pregnancy, again can be bifurcated into type 1 and type 2. And we know the complications. And remember, the risk of congenital anomalies associated with hyperglycemia is the highest during the first 7 to 8 weeks of pregnancy. And the problem, the pregnancy is recognized after this critical period of 6 to 7 weeks of pregnancy. So the glycemic control, if it's not well established in a known case of diabetes or a pre-diabetes, then we already putting the mother and the fetus both into risk. So that's something we should remember. So despite the known risk factors, the known risk for themselves, 50% of the women do not plan their pregnancy and thus do not participate in the preconception planning. And once pregnancy is recognized, the optimal blood sugars must be established. So the dilemma of diagnosis continues. So the question is, who should be screened, when they should be screened, and what are the criteria? So look at this gestational diabetes, the ADA guidelines, which says screen all pregnant women, especially those who are at a high-risk group, which mark obesity, history of GDM previously, glycosuria, strong family history, and poor obstetric outcomes in the previous history. Of course, there are low-risk group also. And let us look at the universal early testing in population with high prevalence type 2 diabetes. Now remember, Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy compared to the Caucasians. And among ethnic groups, the South Asian population, Indian women have the highest frequency of GDM. So you should always keep that in mind whenever a female walks into your OPD. So the latest guideline says all women should be screened for gestational diabetes even if they have no symptoms according to these new recommendations. Now, the WHO observations and recommendations, of course, it's 2013, which said OGTT, and then it is not feasible for many of the patients who travel long distances to our clinic, especially from remote areas. So, consequently, non-fasting testing may be the only practical option. So, all of us should know this. So, a two-step procedure is required. Attendance on two separate occasions is often not feasible in many of our patients. Hence, we looked at a single test procedure to diagnose GDM. Now, this is a wonderful book by Family of Health and Family Welfare, Government of India, which says about diagnosis and management of GDM. I've taken a lot of inputs from this, which is a technical and operational guidelines. And you can see here, it is clearly says the WHO observations and recommendations way back in 2014 said fasting blood sugar is required, and they have to come, which they cannot come. They have tendency, nausea, all that, to keep it fasting. So the 2-hour value after 75 grams OGTT in fasting or non-fasting state value of more than 140 is equal to GDM. So this was way back in October 2016. And later on, our own Dr. Sheshaya proposed that all pregnant women attending health facilities will be tested for hypoglycemia using a single-step procedure as advocated by FIGO, IDF, and WHO also in 2017 onwards. It is a single step whenever they walk in with fasting or without. So what you do, give them a 75 grams glucose orally in about 300 ml of glucose water, and they have to swallow this in about 5 minutes and then check the sugar. And what is the criteria? This is again from the book which I mentioned. You can see they're testing for GDM at first antenatal visit. Positive if the 2 hours blood sugar is more than 140. Negative if the 2 hours blood sugar is less than 140. So what you do if it's negative? Repeat at 24 to 28 weeks. Again, if they're negative, then you can repeat whenever feasible. So this is how is the algorithm what you look at. So the proposed new diagnostic criteria based on DIPSI, which is our own country diagnosis, you can see here very clearly. More than 200, it is diabetes, whether it's pregnancy, outside pregnancy. Between 140 to 199, GDM 120 to 140 is GGI, which is gestational glucose intolerance, and less than 120, you can consider anybody as normal. So mild GDM should not be used. Of course, this is the guidelines which I was talking about. More than 140 is GDM. More than 120, 120 is a decreased gestational glucose intolerance. The first trimester, if somebody is negative, please repeat it after 24 to 28 weeks. And if negative again, repeat in third trimester. And one-step procedure is feasible, economical, and simple in Indian context. So we should always look at as far as with respect to Indian context. So that's why a recommendation for uniform policy came down. And let's look at what are the goals when somebody is diagnosed with a diabetic pregnancy. The fasting should be less than 95, 1 hour and 2 hour postprandial. Again, time consuming, you can just check 1 hour ppbs, less than 140 is sufficient to have a target. If it is 2 hour ppbs, it's less than 120. Now, how do you achieve this target? The next question is that, so you need to have the MNT, medical nutrition therapy, along with exercise, and then comes role of OHA and insulins. So again, you can see clearly the technical operations and guidelines by Ministry of Welfare and Family. The pregnant woman with GDM, MNT, physical exercise. 2 weeks you can try. After 2 weeks, repeat the ppbs. If it's less than 120, you can continue the MNT and physical exercise and monitor 2 hour ppbs as and when required. But if somebody's sugars are above 120, start on OHA. Metformin is the recommendation in our caste-constrained country, and our insulin therapy, I'll tell you what are the criteria to initiate insulin therapy whenever. So if somebody is more than 120, you can start on OHA. Monitor FBS, PPBS every third day or more frequently for insulin bi-weekly for metformin dose adjustment. Once in 2 weeks, if you can monitor, is fair enough. As per high-risk pregnancies, you need to recommend at least once monthly visits to our patients. So very important. Now what about the GDM diet? We generally say a diet with 2,000-2,500 calories of normal weight women and restriction to 1,200 to 1,800 kilocalories for overweight women is recommended. Now again, beautifully it is here given, though the slide is a bit crowded, how do you calculate the calorie requirement of a pregnant woman? You can see there, first calculate the BMI, then calculate the BMR, basal metabolic rate. For adult females, you can read the second point there, 14 into body weight plus 471. Those are the fixed numbers. So it comes to that values of 1227 kilocalories. Then the physical activity, again, the level, you can identify whether it's a sedentary lifestyle or a moderate or heavy work. You can see on the bottom of the slide. Then the total energy requirement of this adult can be BMR into physical activity level. So 1227 into 1.53 comes to 1877 values. You add on a reserve of 350 kilocalories because of pregnancy, and that's the total calorie requirement. It all takes 2-3 minutes. You can save these formulas in your phones and easily calculate the calorie requirement for any patient. Now, the nutrition therapy for GDM is primarily carbohydrate controlled meal plan that promotes adequate nutrition. Individualized carb counting has to be taught. 3 meals and 2 to 4 snacking is advised. Avoid high glycemic food, and at breakfast especially, limit carbs less than 45 grams. Again, you can see it is clearly given what are the complex carbohydrates, what are the simple carbohydrates, which are the ones we should take in large amounts, all that in the book, which I was mentioning about. Very clearly, it is all mentioned. So you can see there, the complex carbohydrates like whole grain, oats, bajra, jowar, ragi, all that they've given, and how do you do the food replacement is explained very beautifully. So eating a healthy diet will definitely keep their blood sugars under check, and small frequent portions, what we advise generally, is true for these patients as well. Now, this is what I was talking. Again, composition of lunch and dinner thali has been very clearly explained in this diagrammatic picture as well, where 1 serving of fruit, 1/4 of thali should contain the cereals, and then the protein-rich food, all that with the photographs they have mentioned. On the right-hand side, you can see the calories also. They're given the list of typical meal plan. So they need to maintain a weight, ideal weight. Of course, physical activity is very, very important. And Dr. N.K. Singh is very fond of physical activities and recommendations. He's seen promoting that exercise and following himself. So this is what we should also follow for our prenatal care, antenatal care, where walking, aerobic exercises, swimming are something which is there. Of course, for high-risk pregnancies, you need to keep in mind when you recommend physical activity. But remember, it will take 2 to 4 weeks for the exercise to give results in a diabetic pregnant woman. So don't expect immediate results. Now, finally, the pharmacotherapy, when and how. Again, you can see the flow chart here, the OHAs which I showed you. Metformin is the drug which is, and these are the 3 drugs which have been studied, metformin, glibenclamide, and acarbose. And ADA 2020 statement clearly talks about advantages of metformin, For want of time, I'll just miss these RCTs and recommendations. Of course, I clearly say, because of cost constraints, oral agents may be an alternative in women after discussion of the known risks and the need for more long-term safety data in offspring. So you need to explain that, and then please start on metformin. Now, SUs definitely are not recommended. For want of time, I'll skip and we'll go to the insulins in GDM. So GDM, who fails to respond to meal plan for the 2 weeks only, if FPS more than 90, 2 hours more than 120, then they require insulin. Very clear-cut indications, and this is what various bodies say, except DIPSI differs. IDF and ACOG are definitely on the same page, but if you see the DIPSI, the fasting glucose levels are persistently more than 90, and 1.5 hours PPG is what is proposed, more than 120 after 2 weeks of MMT, you need to initiate them on insulins. And of course, pregnancy and diabetes, where the insulin is the preferred drug for treating this at any point of time. Glyburide and metformin have failed to provide adequate glycemic control in separate randomized control trials, and that is why we prefer insulins whenever required. Remember, 15 to 20% requires insulin. Higher in obese women requirement may need to be increased progressively as pregnancy advances to term. It guides the dose and timing of the insulin. Prandial hyperglycemia must be reduced, as several studies have clearly shown, which is more predictive of adverse neonatal outcomes than fasting glycemia. Of course, it's true in most of our cases in regular diabetes management also. So the women are well controlled with premix insulins. If patients have elevated pre-lunch, then you increase the dose of regular insulin in the morning, which is usually necessary. If the post-dinner blood sugar is high, a small dose of regular insulin is necessary before dinner, in addition to the regular and intermediate acting, and of course, combination of regular and intermediate acting insulins before dinner may be necessary if fasting sugars are high, and 2/3 of the total daily dose, the same formula we use, 2/3, 1/3, and for each combination, 1/3 dose should be regular and 2/3 should be intermediate acting. If this regimen, the patient continues to have fasting hyperglycemia, then intermediate acting insulin has to be given at bedtime, and insulin dose obviously has to be individualized. Now, this is the various bodies which recommend the choice of insulin regimen. Insulin analogs been used in pregnancy and do not cross the placenta. Rapid-acting insulins, the Lispro, Aspart, shown to be safe. Premix are convenient, and especially in our country, reduce the prick burden, what I say. And NICE guidelines says that beware that the rapid-acting insulin analogs have advantages over soluble human insulin. And DIPSI also says it is ideal to use human insulins, which are least immunogenic in a pregnant. That's what we don't want. And of course, the regimen choice is of course basal bolus, and premix is again used. Remember, rapid-acting insulins have been found to be safe and effective in achieving the targeted PPBS values during pregnancy. And recommendations from our own RSSDA, insulin therapy with women with GDM. Again, the criteria they are fixed. Okay, thank you. It's 15 minutes, so I'll take another 2-3 minutes. As insulin does not cause placenta, which is the preferred choice, and NPH or insulin determer. Please read that lines very clearly. Insulin determer and NPH, what is recommended. And of course, it's considered more suitable over oral agents in women with pre-existing diabetes. And of course, individualized insulin regimen and glycemic targets by basal bolus. Ideal regular insulin or rapid-acting insulins are worthy. Determer or glargine may be used. Now, insulin regimens twice daily versus 4 times a daily, which is shown definitely better with 4 times daily insulins. And of course, the dosing of insulins in pregnancy or RSSDI, weight-based and trimester and weight-based, you can see. For want of time, I'll not get into this. And which insulin is safe? You'll be surprised to see these ultra-fast-acting insulins have got approvals already, which mimics mostly the 2 phases of secretion of insulin. This is the slide I wanted you to see. You can see their insulin determer can be used. Glargine and degludec both do not have a clinical data. Though all of us use this as a half label, but the bodies do not recommend because of the lack of data. And you can see the bottom most, which is highlighted, the NPH, Aspart, Lispro, all that. You can see the limited experiences in this. So you should remember, and whenever you initiate, you please document in your prescription that the risks of the same have been explained to the patient in their own language, just to save your, to safeguard yourself. Of course, metformin in insulin-resistant diabetic pregnant women, this is one of the studies which I say is better to add on. It should be individualized on the basis of SMBG. And insulin in pre-existing diabetics, again, standard of care 2021. For want of time, I'll skip all this. Monitoring. Once the target glucose is achieved, up to 28 weeks of gestation, once a month, and more than 28 weeks gestation, once in 2 weeks, more than 32, it's once week till delivery. CGMS can be used in high pregnancies, high risk pregnancies, but remember, in our country, the SMBG has been clearly shown is non-inferior to CGMS with respect to the postprandial glucose excursions. A1C, we use target blood glucose levels, I have discussed already in normal pregnancy. Intrapartum, again, the insulins during labor and postpartum is given. Insulin requirement falls in the postpartum period by 34%, that the required preconception period. And of course, during lactation also, it further falls. And COVID-19 and GDM, of course, they put it into more pregnancy. And summarize, pregnancy with diabetes is associated with the increased risk of maternal and fetal complications. Insulin has got an important role, and DIPSI guidelines are suited for our setting, including RSSDA guidelines. Analog insulins have demonstrated their efficacy and safety compared to your regular insulins. So thank you very much for patient hearing, and I'll skip all this. This is, of course, which summarizes all the talk in one single slide, the risk factors, the gestational treatment, and complications, etc. Just to use it, you can use this slide. And thank you very much for patient hearing.
Thank you, Dr. Srinivasan. A very vast topic covered brilliantly in just 20 minutes. Hats off to you. Any question for sir, as he has to leave for Bangalore? So we'll take the questions for him.
Most of them I continue to use if they are on metformin, sir. I don't try to initiate metformin. I'll convince them in insulin, because most of the patients, that is the pregnant woman, will eventually require insulin as they grow. So the requirement of insulin goes up second, third trimester. So it's better to prime them from day one instead of facing resistance at the second or third trimester. That's a good idea. But somebody is on metformin for PCOS, etc., then I would continue. But I don't try to initiate any OHS. I would prefer 100% of the women to be on insulin, at least one prick like Ditamir. That's what I use in practice. Exactly, sir. Yes. Definitely, sir. As I showed, that is one of the statements they made, including the ADA 2021 has made a statement in cost-constrained situations. You need to explain the metformin plus minus to the patient and then initiate on metformin. But ideally, it's the insulin. But I practice in Bangalore, so the cost factor is not much concern. So I would prefer, even, sir, when we explain to the patient, I think the cost factor is something which does not come into picture when something like pregnancy and in pediatrics. You know, for a child, you say anything, they'll vaccinate. They don't think even a laborer, roadside laborer would afford. So insulins, I think, is the must which we should prime them, because most of the patients, if you explain them properly, the postpartum complications, the delivery complications like macrosomia, neonatal, all these complications, and especially if somebody has got a comorbidity like PIH, all that, it's the ideal is insulin. That's what I propose. But metformin, of course, no doubt, we can definitely use in the rural setting and patients who cannot afford. Yes, sir. Which one, sir? Ditamir is once a day insulin, which is, of course, if the requirement goes above 40 units, we usually split it. We can give BD also. And you can, depending on the postprandial or preprandial sugars, you can start in the morning or evening. There's nothing like it just has to be given only in the nights. So you can give, if the PPB is more, you can initiate in the mornings also.
Excellent talk. You said your preferred insulin is Ditamir, right? Your preferred insulin is Ditamir.
Yes.
But is the fasting that concerned, or the prandial in pregnancy?
Sir, both has to be tackled, and as I showed evidence, the prandial insulins are more dangerous. So that's why I said you can give it in the mornings also, which can take care, or you can add a prandial insulin, which are recommended. Only the analogs are recommended in that. So again, the cost factor comes into picture, and you can have a basal plus one prandial insulin also, depending on the patient. It's always individualized. We don't initiate with the prandial insulins because most of the times, which is not be required. But if you have the sugar values, SMPG values of the given patient, then you can definitely start with the prandial if you know the postprandial excursions are the problem with this patient, especially if it's a diabetic patient who gets into pregnancy.
Okay. Thank you, Dr. Srinivas.
Thank you, sir. Thank you.
Excellent talk by Dr. Srinivas. Now I would like to invite our next esteemed faculty, Dr. Bijay Patni from Kolkata. He is going to share with us about advanced technologies in diabetes management for physicians.
Welcome, Dr. Bijay Patni. When we use technology all around us every day and night, so why should management of diabetes lag behind? We have Dr. Bijay Patni who will take us through the advanced technologies in diabetes for physicians. Dr. Bijay Patni is a renowned endocrinologist and he has graced this occasion. He has come all the way from Kolkata. Welcome, Dr. Patni, and please carry on.
Good morning, and thank you, chairpersons. At the outset, thank you, Dr. Akash Singh and Dr. Radha Kapoor, and the IDCM team. For inviting me to this particular forum, and I see a great audience even at 9 o'clock. Thank you. My talk is quite huge. What I'm going to do is just give you an overview of the advanced technology in diabetes management. So we all know by this time that diabetes is a complex chronic conditions, and the diabetic population or the diabetics, they have experienced psychological, cognitive, pragmatic, and even the physiological burdens. So whatever effort we make, the whole idea is to improve the quality of life. And technological advances is the way forward. This is what we have realized in the last decade. Particularly in the COVID scenario, one thing is for sure, it has taught us technology, both for the HCPs as well as the patients. So what is the scope of technology? This is very important, because where do you really want to use technology? It's in the measurement and documentation, because that is where you want to intervene and manage the patient. It's the education which is very important, and the treatment facilitation. So not only the dose adjustment, the various other modalities or delivery of insulins, et cetera, can be very well taken up with the scope of technology. And one thing is important, that this technology might reduce the cost of therapy by reducing the incidence of hypoglycemia as well as hospitalization. Information technology enables diabetes management is very important, because what you actually do, you synthesize the information and thereafter use the delivery of the knowledge. The efficiency of communication is very, very important. If the communication between the stakeholders is not great, probably you won't be able to achieve any outcomes whatsoever, and allowing for the coordination of the care across the delivery system. Of the existing technology, we have realized that the registries are very important, that can improve the outcome as well as reduce the talk. So, dollar is not the new currency. The currency happens to be the data, and that is what we have realized. At least all of you will agree that in COVID pandemic, those we could not even explain to them, even to get a glucometer at home, probably we have been able to influence that. And that was very important. So we could connect with the patients. And so the telemedicine is now the connected health. And that is where the outcome is. Communication among devices, clinicians, patients, including remote coaching, is now increasingly prevalent. And not only possible, probably this is the way forward. So just telling that telemedicine is going to help is not going to work. We have to show some evidence, and this is what the evidence shows. This is a 6 months randomized controlled trial where we had 3 randomized groups, and what was realized that the HbA1c do increase in the telemedicine group. So this is the evidence which is there. Along with that, there are a lot of meta-analysis. These are Chinese studies of the RCTs. They're in the Cochrane review, they had seen the 21 RCTs, as well as the systemic review of 46 studies. All of them showed that there is a better HbA1c outcome in these particular groups as far wherever we involve the telemedicine. Now, whenever you are talking about technology, there has to be certain areas where you need to focus on that. So one such area obviously is the glucose data, because glucose data is going to give you an idea about how to manage the patient. But all of them, the various sources of glucose data will have their own benefits and drawbacks. So all of us are aware of the glucose meters. It is probably a necessity for every diabetic patient. And obviously the drawbacks happens to be the finger pricks, which is very, very, very difficult for our patients to convince as well. And incorporating that into the daily routine becomes an issue. So what next? HbA1c. Obviously, this has been our, I would say, the way we have to go about, and then we have to plan out a therapy on the basis of that, because it correlates with the clinical trials most of the times. But what it gives is a 3-month snapshot. And along with that, it overlooks the glycemic variability. In last 5 years or 6 years, glycemic variability has become an important tool to actually forecast the mortality and morbidity in our diabetic population. So there, again, there is a drawback of HbA1c. So we move on to the continuous glucose monitoring, which probably is not only to give us the trends, but it gives the patient alerts as well. So reactive and predictive. So once, if you're aware of those alerts, probably you can modify your management as per what your healthcare providers provided you. But then every newer technology will have its own drawbacks. Coverage and accessibility becomes a big issue. But glycemic is always a package deal. You have to see the SMBG, you have to see the HbA1c, and along with the continuous glucose monitoring. All three combined can give you the outcomes. It's not one single entity which is going to really give you the better management, but all three combined together probably will be able to address most of the issue as far as glycemia is concerned. Now, this is what is the types of diabetic technology which we employ in today's world. One, obviously, is glucose monitoring. The other is the insulin delivery. Then we have the smart insulins. And last and foremost, the tech for the diabetes care, that is mobile application and artificial intelligence. So glucose monitors are very important, but what is so important is that all our patients should be having a glucose monitor at home. This is mandatory, and one should make it sure that each of our patients have a glucose monitor at home. We have tried various ways. I think there was a Defeat Diabetes program which tried to plan it out in that way. And secondly is, in the COVID pandemic, probably we have been to convince the patient to have a glucose monitor. But the glucose monitor needs to be approved one, validated one. That's very important. And the third part is the concept of type 2 diabetes and no need of glucose monitor home has gone. Probably it's very important, very essential, because it can give you an idea of how you're going to alter your management whenever you're altering your diet, physical activity, or medications. Accuracy is very important. Whether it's ISO standard or FDA recommendation, they have to meet certain standards and they need to be approved. So what is CGM? I think Dr. Bansi Saab talked about it, but what is more important, it is the glucose concentration of the body's interstitial fluids, and what it helps in getting the time in targets, the glycemic excursion, the daily profile, the glucose variability, and the patterns of hypo and hyperglycemia, which we cannot achieve, even with the 8-point CGM. But it's definitely, it's a poor cousin of CGM, 8-point SMBG. It's a poor cousin. You can get an idea, but CGM really gives a very good insight into the various glycemic variability intraday and intraday. But the limitation always remains. There is delay in registering the blood glucose changes in dynamic situation, and as I said, accessibility could be a problem. These are the trends, arrows, and implications as we see in CGM. I'm not going to talk about this. It gives a trend towards rising, very rapid rising, slowly rising, falling, and very rapidly falling, so that he can adjust, the patient can adjust accordingly. And these are the various CGM targets. They are variable in different populations, whether it's type 1, type 2, older or high risk, where we have a conservative targets. Pregnancy, TID, this is also important because the target range in pregnancy is very different from what the target range in other adults are. 63 to 140 is the target range, which has to be more than 70%. And if you see, if this above targets, it has to be more than 140, and it should be less than 25% of the times. So these are the various terminology: real-time, intermittently scanned, professional CGM, which probably most of us are doing it, and where we provide the CGM at the provider's office, and then it is analyzed, and we give an idea about it. See the major CGM devices which are available presently, and the one such device is the Sensonics. Sensonic is the implant, which is the lifetime of sensor lifetime is about 90 days, but another one which is a sugar beet, which is a non-invasive skin patches. So these are all the technology which is evolving and probably are not available presently in India, but definitely they will be there available in a few days' time. And once you get all this stuff, so you will be having a better kind of idea about your glucose status or the glycemic status. So now let's go to the next part, that's a newer insulin, the insulin delivery system. We know that we have already crossed the centenary year of insulin discovery. And if you see the various, the evolution which has occurred as far as the insulin delivery device is concerned, right from the launch of NovoSyringe to NovoPen, then the insulin pumps. 1970s was the one when we had the first commercial insulin pump, and thereafter modification, evolution, or that advancement in the insulin pumps and insulin pen were seen. And presently in 2020, you have the FDA-approved tandem control artificial pancreas as well. So these are the other forms of insulin delivery. Inhaled insulin, you are all aware of Afrezza, but then there is a difficulty in titrating the exact dose needed. So that again is a big issue in the inhaled insulin. Rest of them are still in the process. And the most important, what is awaited is the smart insulin, which is chemically modified to release the insulin in response to the glucose in the bloodstream. So once that is available, probably it will be one of the best insulin delivery system which we will be having it. Let's come to the insulin pumps. Obviously, if you remember that particular, I think it's not, that particular slide, the one which were variable insulin pump, a clumsy one, weighing a lot. And from there, we have come to these devices which are smaller and more user-friendly, and even artificial pancreas trials have begun and are already there. So basically, so the various evolution of the CSI insulin pumps are there. And though first used about 35 years or in 1970s, now the pumps, the recent pumps are probably a small pump, which you will see in the next, when we talk about the patches pump. So the benefits, obviously, insulin pumps are there. They are more convenient, flexibility in dosing, more accurate and precision. But again, there are drawbacks as far as insulin pumps are concerned. But it has slowly taken over because the newer pumps available, the smaller and more accurate pumps, where less of intervention is required, automatic, both the sensing is done as well as the dosage calculation is done. When they are available, it will be much more in vogue. So the patch pump, which is the next one, which I am going to talk about, the Omnipod or the Omnipod Dash, this is one which we do not require the plastic tubing to deliver the insulin to the cannula. So this is the new state of art, basically, the insulin patch pump. And this is what we are expecting. And I think it's not available presently, but in some experimental places, it is being used, I think even in Ahmedabad. Automated insulin delivery system is the one which will be able to eliminate most of the side effects like hypoglycemia, et cetera, and reduce the hyperglycemia as well. So it has a predictive low glucose suspend system. So these are the future. I mean, all the pumps are going to be automated insulin delivery systems. So this is the evolution from the open loop SAP to hybrid closed. Now we have the full closed loop, which is artificial pancreas in particular. So this is what we are going to get. It's absolutely fully automatic, no input needed during the normal operations. So that will become a boon for all the patients who need insulin pumps. So this is one, the closed loop, led by hormonal bionic pancreas, which has come into being in 2015 approved. The beta alpha bionics. Dr. Edward Damien in 2015 invented it, and it has been granted the breakthrough device designation by the FDA in 2019. So this again is the one which still not available in India, but probably this is a type of closed loop system considered 2 infusion pumps and connect to a CGM via a smartphone. So this is the technology which is the future, and probably with the patch pump and the artificial pancreas coming in, so the insulin pump initiation as well, acceptance by the patient will be much better. Now this concept, do-it-yourself artificial pancreas, is being talked about because what was happening, it was become very cumbersome, very time-consuming for the clinical trials and regulatory procedure for commercialization of the artificial pancreas systems. So what happens, this whole concept of do-it-yourself came into this, that we are not going to wait. The patient themselves started to share their knowledge as an open source hardware and software solutions. And though they are not validated, or they are using unauthorized algorithm, but it still is accepted term, an accepted way of communication in order to modify the CGM data and to calculate the insulin dosage accordingly and use them into daily insulin pump system. So further to that is advances the connected pens and caps. These are the various devices, and you can see the description used for the various insulins, and the devices are there, and there are more to come. So I'm not going to talk hugely about them, but NovoPen Eco is one which is being reusable rapid-acting insulin pen. InPen is another one, reusable rapid-acting insulin pen connects. Thank you. Data integration system, tech assist in the diabetic care is the most important, because data is the most important currency now. And you have various apps which are available in mobile apps, apps for wellness. These are all going to be complementary to the management of diabetes in our population. And if it's the nutrition app, you can have this MyFitness app. What glucose monitoring, MySugar app is variably used and is most commonly used by our population, by our SCPs when they try to incorporate into the management of the patients. So these are apps for wellness. Next you have the apps for the insulin titration and delivery. So basically all are becoming automatic. You have these apps, download the apps, incorporate a little bit of inputs, and you have the calculations done, and you have the proper titration as well as the delivery done. So artificial intelligence, obviously, this is a big data to improve. Everything is dependent on artificial in near future. And great talk by Dr. N.K. Singh on use of artificial in the clinics, sometime in some of the forum. And you can well imagine it's used for diagnosis, the BG control strategy, prediction of glycemic events, complication prediction and complication detection. As we know, it is very much there in automated retinal screening. Probably all of us, or some of us at least, are using them. And that becomes easier for us to recognize the retinopathy early in the disease and provide the requisite management for that. So this is what is happening, transforming diabetes care through the artificial intelligence, and this is the future, frankly speaking. Now, but whatever data you have to collaborate the data. So you have different data platform, you have different mobile apps, and different data sources. All need to be collaborated in order to really use them for a better outcome. So whenever you're selecting an app, you have to consider these various points. There's no point giving an app to someone or asking someone to download the app and use it. No, it has to be individualized, and these are the various criteria which need to be taken into consideration before even planning to ask for an app to be downloaded and to be used. So, but you need to identify and overcome barriers to technology use. In our own practice, we all are aware of the fact that barriers lie at the SCP, the barriers lie at the patient, as well as the systems. So there are barriers everywhere, and that has to be overcome. So that's very important. So you have to really, what happens, even we talk about from the podium about the this advanced technology, everything and all, still back to the clinics, we are tech avert. We do not want to include or inclusion of technology in our own practice. So how to communicate? Communication is the biggest skill. Let me tell you, whenever you try to incorporate all these advances, you have to be a better communicator. That is very important. Process for prescribing, education, training, and data interpretation. Data interpretation is another big barrier for us. So it's not only for the patient, it's a barrier for us as well. So we need to learn about it, and then we can really make it work. And the patients, obviously, the cost, access, etc., and the tech aversion is always there, which is understandable with the huge population which we are catering, the rural population, uneducated class, illiterate class. But everything needs education and counseling. You need to spend some time with the patient in order to make that work. And the making informed decisions regarding technology, one size fits all, doesn't apply. So you need to use whatever technology is available for every individual, individualize the therapy, and accordingly you can incorporate them. So again, this is the same thing: convenience, cost, complexity, constant reminder, diabetes, commitment required. All these steps are important if you really want to consider using diabetes technology. So importance: no device used in diabetes management works optimally without education, training, and follow-up. You need to train yourself as well before train the patients or the caregivers. So it's very important. Training is important. That should be an integral part nowadays for any management of diabetic patients. So optimal therapy plan, you follow the therapy plan, address the barrier as needed, and then escalate and de-escalate the therapy as required. So this is very important. So technology alone fixes nothing. So this is very important. You need to adjust, incremental adjustment, and address the barriers in order for the technology to work. So it is a team-based, personal-centered, and data-driven care. It has to be a collaborative effort, then only you can achieve the outcomes. Approach to data is very important. This is the last and most important slide, I would say. Data, D-A-T-A-A. Now, data means you have a data. Start with a global overview of the data. What the data means. Ask the patients what they have learned out of it, what they are going to do with it for self-management. Then you assess the safety, that is hypoglycemia, identify the time below range, percentage of the time, and interact with the patient so you can get to a possible causes and solutions. Thirdly, time in range. Have a positive attitude to others. Try to interact with the individual. Tell him that you were in time in range on those days of the time when the time in range was the highest. How did you do it? How can you replicate it in your daily routine? This is what you need. You have to be optimistic about it. Have a positive approach toward this. Areas to improve. Again, hyperglycemia. Why did it occur? What was the cause? How can you adjust and you can get a solution? And lastly, develop collaborative with the persons with diabetes. So this is where I'm going to end. I'm not going to go to further slides, but this is what's so important. Whenever you are planning for advanced technology in diabetes care, you need to understand one size doesn't fit all. You need to use appropriate technology with an appropriate individual, and then you have to have a collaborative effort in order to get the outcome. Thank you.
Thank you, Dr. Patni. I think exciting times ahead. And thank you for giving us an insight into what the future holds for us. We'll take the question answer session later on. There's a separate time allotted for that. Thank you.
Hello everyone. Sorry for the interruption. Our first speaker will be leaving soon, so we need to felicitate him. I invite Dr. Kamaldeep Chawla to felicitate our first speaker, Dr. LMNS. Would you like to say a few words, sir?
No, I think we are beyond the schedule.
Okay. Thank you. Thank you, everyone. Yeah. Okay. So our next speaker is Dr. Sameer Saini from Badora.
Thank you.
Dr. Saini, I think all of us know him well. He is our own alumni from MS University. And I would request, without wasting much time, I would request Dr. Saini to go ahead with his talk.
Okay. So, am I audible? Okay, so first of all, at the outset, good morning, everyone. And I think it's a very good crowd in spite of it being, what, 9, 10 o'clock and everybody having busy OPDs on Saturdays and all. We still have a good crowd over here. So thank you for that. Also, thank you for the kind introduction, and thank you for the organizers and the chair people who have given me the opportunity to be sharing the stage with all the eminent speakers here today. So my talk today is something which is, well, a recent development in what is an old and washed up topic like type 2 diabetes. It is about the fact that can we or should we subclassify type 2 diabetes. Now, before I go any further, I'll ask a rhetorical question. This is about four Indian gentlemen who have been recently diagnosed with type 2 diabetes in the last couple of months. The first guy is a young fellow, 20 years old odd. He has been diagnosed with diabetes recently with fasting sugars of around 200, with postprandials of around 300, and with an HbA1c level of around 11, 12 odd. The second gentleman is somebody in his late 70s. He has been diagnosed with diabetes recently with fastings of around 150, postprandials of around 200, and in HbA1c of around 8. The third gentleman is a middle-aged guy who is in his late 40s to 50s. Again, he shares the same fasting, PP2 and HbA1c values as the previous gentleman, around 150 to 200, and the A1c value of around 8 to 9. And the last guy is an obese guy, also in his mid-40s to 50s, and he is also sharing the same glucose values, let's say 150 to 200, and round about an A1c of around 8 to 9. So the question is, are all of these people the same? Do they require the same therapy? Is the requirement of therapy the same? No. Is their progression going to be the same? Is the risk of complications going to be the same? So since it is a rhetorical question, the answer to all of these is a big no. Correct? So that is what we are going to be talking about today. We know that type 2 diabetes is highly heterogeneous. Okay, it is highly heterogeneous because it has varying clinical characteristics. You have lean people, you have obese people, you have people who are young, who are old. It has varying degrees of disease progression. You know, we do know that some people are going to require insulin very quickly in their course of illness. There are some people who are going to not require insulin at all for decades together. Okay, they do very well with just metformin and maybe a second drug added onto it. We as clinicians know that the drug response is not the same in all of the people. Okay, so some people require metformin alone. They respond very well to metformin. Some people are not going to respond well even to insulin. They require very high doses of insulin as well. And then there are varying risks of complications, which means that the degree of complications in different people is different. So there are some people who have a propensity to develop microvascular complications such as retinopathy, neuropathy, nephropathy. And then there is the separate subgroup who is highly prone to develop macrovascular complications like coronary artery disease and cerebrovascular disease. But in spite of all the heterogeneity over here, what we have been doing till date is we have been defining diabetes on the basis of single metabolite, that is glucose. So if the glucose is high, you have diabetes. And if the glucose is low, you either don't have diabetes or you have controlled diabetes. But the problem with this is that we are responding to the actual effect of the pathophysiology which is leading to diabetes, which means we know that glucose is not the problem. It is the insulin secretion which is the problem. It is the insulin resistance which is the problem. There are certain genetic mutations which are the problem. Or a combination of any of these is ultimately going to lead to a situation wherein we have a high glucose value. But we respond to the glucose, we don't respond to the predisposing condition. And that is why the existing treatment strategies really do not help us in either preventing or in stopping the progression or in preventing the complications. There are numerous limitations to our type 2 DM guidelines, but I'll just highlight a few. Number one is we know that there is something called as metabolic memory. What this metabolic memory means is that if my sugar control is bad today, I'm not going to be facing the brunt of the complications today. Those complications are going to come 10 years into the future, a decade down the line. This is because most of our tissues, they have this habit of remembering that my sugar was bad, long back. And that is what is called as metabolic memory. But we, in our guidelines, we follow the glucose. We follow the metabolic control. We do not predict it. We do not prevent it. We do not take steps to intensify therapy when we notice that, okay, this patient is going to require a better glycemic control later on down the line. And that is what the problem currently is with the existing guidelines. So we have guidelines which say that, okay, if the sugar goes to this level, let's say you should start off with metformin, and then if it goes to this level, you should start off with another drug, and then if it is this level, you start off with another drug, and so on and so forth. But that is just chasing the horse. Okay, you are just chasing the metabolic control. You are not actually preventing it. You are not doing anything to prevent it. So maybe a reclassified approach to diabetes would be a better way to go about this. And we are going to be discussing about how we want to reclassify diabetes. But before I go up to the new age classification of diabetes, I would rather discuss how we classify diagnosis of diabetes currently. So this is what is the traditional classification of diabetes. Now I say traditional because even the most latest ADA guidelines, this has been taken from the ADA guidelines of 2022, they are following the same age-old classification which has been going on for 20 years now. How we classify diabetes? We go by a diagnosis of exclusion, which means we first exclude monogenic diabetes. So that monogenic diabetes is less than 3% of all diabetics less than 30 years of age who have a single gene mutation in certain genes which are going to lead to diabetes later on in life, and they respond very well to certain therapies, but that is what we find out first. Then we take up the secondary diabetes, that is diabetes due to either pancreatic disease or due to cystic fibrosis or hemochromatosis, or it can be because of steroid abuse or overuse or whatever, and we exclude that. What we are left with is a chunk, a huge chunk, out of which a small percentage is type 1 diabetes, let's say 5 to 6%. And these are people who have antibodies to the pancreatic islets, who have very low insulin production and who are going to require insulin in the very near future and are very prone to ketoacidosis. So if we exclude all of these, the small chunks, what we are left with is the huge chunk of 75 to 80% of our diabetics, that is type 2. Can anybody tell me how type 2 diabetes is defined? We know how to define type 1 diabetes. We know how to define monogenic diabetes. We know how to define secondary diabetes. We know what are the pathophysiologies behind it. But type 2 diabetes is such a huge heterogeneous group that we do not exactly have a definition for the same. What we are doing is basically we are excluding the other causes and we are landing up with this. So this is what is an overtly simplistic classification. This is the limitation of this. You're just excluding the minority causes of diabetes and you're landing up with a major cause. And now you have to think about, okay, what I am to do with all of the different populations that are there in this. The other thing is it doesn't classify type 2 diabetes. You know that type 2 diabetes lands up with almost 80% of all diabetic populations. It will be more than that in India, I suppose. And we are not classifying that. And the third thing is that there is no information regarding the prognosis or therapy in this classification, which means that, yeah, you know that type 1 diabetes is going to require insulin, monogenic diabetes is going to require something else. But what about type 2 diabetes? We just have a group of drugs which have been randomly arranged, like metformin, and after that, glimepiride, after that you give thiazolidinediones, and it goes on as a stepwise manner. But is this going to help in a particular patient? No. So in order to overcome these limitations, what certain people did was that they jumped 20 years into the future. So they made a molecular classification of diabetes. Now, if you see on the left side, there are a lot of pathways which can lead to diabetes. We know that diabetes is a result of multiple, pathways because of genetic mutations and all, which are going to land up with diabetes in a particular person. So what they tried to do is you find out which are the molecular pathways which are affected in each person. And you find out how many are affected and you classify according to that. But the problem is that this is very complicated. I mean, it is not going to work in our day-to-day OPD practice. Also, it is very costly. If you tell a patient who has come to you in the OPD कि sir मुझे diabetes हुआ है और मुझे treatment चाहिए, and if you tell him कि sir मुझे आपको classify करने के लिए 20-30 हज़ार रुपए चाहिए, nobody is going to come back to you. Also, as of right now, there is no information about either of prognosis or therapy, even from a molecular diagnosis. So in order to find a middle path, in order to have actionable classifications which we can act upon in the OPD itself, our brilliant colleagues from Sweden and from Finland, which includes illuminary names such as Emma Alquist, Rashmi Prasad, Leaf Group. What they did was they took certain clinical and lab-based variables. So now you have 6 variables. You have age at diagnosis, you have body mass index, HbA1c, you have either GAD65 positivity or negativity, and you have 2 basic pathophysiologies behind diabetes, that is insulin resistance, which is represented by HOMA-IR, and you have the insulin secretion, which is represented by HOMA-B. And what they did was they tried to classify diabetes on the basis of all of these clinical variables which can be present, which can be evaluated right at the point of contact. Now the initial clusters, this was a cluster-based classification. The initial cluster was done in the Andes group. I'm not able to highlight it here, but well, the Andes group was a cohort in Sweden, which was a prospective cohort, on the basis of which all of these clusters were defined, and then these clusters were retrospectively validated in other pre-existing cohorts in Sweden and Finland. These were the SDR, the ANDU, the DRV, MDC, CVA. We have various cohorts which are already pre-existing and which were being followed up for different reasons, but then these clusters were revalidated in the pre-existing cohorts. And what they found was, this is what is the newer classification of diabetes. You have certain clinical parameters on the basis of which you are classifying it as either SAID, that is severe autoimmune diabetes. You have SIDD, which is severe insulin deficient diabetes. You have SIRD, which is severe insulin resistant diabetes. You have MOD, which is mild obesity related diabetes, and you have MARD, which is mild age related diabetes. So you have around 3 different types of severe diabetes. You have 2 different types of mild diabetes. Now we'll come to what exactly this means, but how were these clusters identified? What happened is they found that SAID was the group in which there was GAD65 positivity. You had low insulin secretion, and on top of that, you had a young age of onset and poor metabolic control. So this coincided with the type 1 diabetes group. But surprisingly, type 2 diabetes was subclassified into 4 different groups. You had severe insulin deficient diabetes, which was characterized by GAD negativity, poor insulin secretion, young age of onset, and poor metabolic control, that is higher HbA1c levels. You had severe insulin resistant diabetes, which was a higher age of onset, obese, but the HOMA-IR was very high, which means that the insulin resistance parameter was very high. Then you had mild obesity related diabetes, in which obesity was present, the age of onset was higher, but insulin resistance was almost non-existent. And you had MARD, which is mild age related diabetes, which means that the age of onset was very high, these were not very obese people, and the relative risk of complications and metabolic control was good. The differentiation that they found in this cluster-based classification is that when they tried to classify the cohort on the basis of the traditional classification, all they could do was classify almost 1 to 2% as type 1 diabetics, 5 to 6% as LADA, and the rest of the 94% were type 2 diabetes. But when they did this on the basis of the cluster-based classification, what they found was the same. Type 1 diabetes and LADA were classified as SAID, but there was a huge chunk of almost 40% plus 22%, which was classified as MAD and MARD. These were the most common subtypes of diabetes. And then you had severe insulin resistant diabetes and severe insulin deficient diabetes. And the remaining pie charts that you're seeing are the validation of this particular cluster-based classification in the pre-existing cohorts. So you can see the percentage of patients in the entire 100% of population is almost the same for all of these clusters. So this was just the validation part. We don't require just validation. What we require is clinical information. What do we get out of classifying diabetes like this? So what they noticed was, if you take up complications such as nephropathy, that is macroalbuminuria and ESRD. Now there was one particular cluster which was far ahead of the group. That is, the severe insulin resistant diabetes was very highly prone to developing nephropathy. The same was holding true for NAFLD, that is fatty liver disease. The severe insulin resistant diabetes group, the SIRD group, was highly likely to develop NFLD over a prolonged period of time. And the surprising thing is that the nephropathy and the NFLD, they progressed in spite of the fact that there was good metabolic control, which means that there is some other pathophysiology which is lying behind these two. The glycemic control, that is HbA1c, was the poorest in the insulin deficient groups, that is SIDD and SAID, and these continued to be over, poorer over a period of time. Even over follow-up, the metabolic control used to be bad. Neuropathy and retinopathy were far more common in the insulin deficient groups, that is in the SAID and the SIDD groups. Now, if you think about the treatment as to how it helps in the treatment, so remember, these people were just trying to classify. They were not trying to treat on the basis of the classification. So the treatment was going on according to the older norms, okay, according to our currently existing guidelines. So what they found was that the time to metformin, that is the time to starting first drug. This is, the second chart is the time to metformin, is the least, that is the earliest time to starting metformin is in the SIDD group, that is the insulin deficient group. The time to second drug was also least in that, and the time to sustained insulin was also the least in this particular group only. Of course, SAID was a group where you had autoimmunity and you had to start off with insulin right at the point of contact. But the insulin deficient type 2 diabetes were having a far more faster progression in terms of therapeutic requirements. And the time to target, which means let's say you have a target of less than 7 of HbA1c. The time to target was the highest in the insulin deficient groups. So how do you interpret this? SAID, that is the severe autoimmune diabetes, is the same as type 1 diabetes. But masked within the entire subgroup of type 2 diabetes, there are two severe forms, that is a severe insulin deficient diabetes and a severe insulin resistant diabetes, both of whom have different properties, different progression, different requirements for therapy. Also masked within the entire subgroup of type 2 diabetes, you have two milder forms, that is mild age-related diabetes and mild obesity-related diabetes. These are milder forms because they do not require very high therapeutic requirements and their prognosis and progression is also slower. So if we talk in terms of treatment and complications, SIDD, you would be better off starting off on insulin earlier because you know that this particular patient is going to require insulin quite early in their course. And you have to look out for retinopathy and neuropathy in these patients. SIRD, they may not require insulin at all during their life, okay, but they are going to have progression of nephropathy and NFLD in spite of a good metabolic control. So you might want to target insulin resistance, which is the driving factor behind that. So metformin, thiazolidinedione, pioglitazone, these are the drugs which you want to try out in these patients. And MOD and MARD, these are far more common and they have mild disease. They respond well to therapy. In fact, what these people notice is that they respond very well to low doses of sulfonylureas also. And they may not require anything throughout their life. This was just about the initial cohort. Okay, so this was the cohort which was seen in Scandinavia, that is Finland and Sweden. Now people were interested in finding out whether this cluster-based classification actually holds true for other populations around the world. So the German diabetes study group, what they did was they validated this, but they also followed up these patients to see whether we tend to believe that type 2 diabetes is progressive, so all of these subgroups can actually change. I mean, there are certain patients in the periphery of those clusters who are going to change the cluster over a period of time. Let's say a patient from severe insulin resistant diabetes, he goes on to severe insulin deficient diabetes. Does that happen or not? What they noticed was this is very uncommon, which means that only about 10 to 15% of patients change their groups, change their clusters over a period of time. So these clusters are stable over a period of at least 5 years, probably more. Now this classification has now been validated in the UK-based population, it has been validated in US-based population, in Chinese population. We have cohorts of various CV outcome trials, that is, we have the leader for liraglutide, we have sustain 6 for semaglutide, we have the degludec trial. It has been validated in those cohorts also, it has been validated in the origin trial also. And now people are looking at finding out ways to associate genetic mutations to all of these clusters, which means they're trying to look at GWAS, that is genome-wide association studies, to find out if there are certain genetic mutations which are leading to these clusterings. And the initial studies do say that all of these clusters have different mutations which are associated with them. So the take-home messages from today's talk are that type 2 diabetes is not homogeneous. It is a highly heterogeneous group of disorders. It may not be the same disorder. And the same stepwise based approach therapy that we are using, I mean, like I said, you cannot use the same whip for every horse. The same stepwise based approach is not suitable for every patient of type 2 diabetes. You start with metformin, and then you add another drug and another drug, and then you add insulin. That may not be correct for all patients of type 2 diabetes, because prognosis, likelihood of complications are going to be different. They vary from subtype to subtype. And unfortunately, validation in Indian studies is still in its nascent stage. It is ongoing. There are certain private groups who are looking at validating these sort of cluster-based classifications in India. This same cluster is being validated as well. So if there are any takers in the audience, we are more than happy to collaborate. And with that, I'll end my talk, and thank you very much.
Thank you, Dr. Saini. It was a very nice, thought-provoking talk. I am sure there will be many questions, but we'll take questions at the end of the session. So now we will have the next speaker, and then I think we will have questions.
Excellent. Thank you, sir.
Sorry for the interruption. There are few cars on the road with the number 7650. Kindly note, please. 7650 1235 6042 47 1123 8807 4513 4345 4759. Kindly hand over keys to Mr. Sapan. Is it okay? Thank you. So with this, I am going to invite our next speaker, Dr. Anil Virmani from Jamshedpur. Over to you, Dr. Virmani.
Thank you. I don't need the mic. I got the call of mic.
Yeah, nowadays we have a lot of articles on reversal of diabetes, and a lot of patients do also ask us about this. So we have Dr. Anil Kumar Virmani, having an illustrious career, as you can see on the screen, will tell us about this topic, what works, what does not work, and is it a myth or is it a reality? Over to you, doctor.
Thank you, sir. Honorable chairpersons and dear friends. Thank you, Dr. Akash, Dr. Anuradha, and Dr. Kamaldeep. I love Vadodara. It's a very nice place. And today, what I'll be talking about in the next 20 minutes, I'll try to unravel the mystery whether diabetes can be reversed or does it go into remission. The conflict of interest that I have for this topic is not only with those fake babas who claim that diabetes can be cured, but also with some of my own colleagues who say that diabetes can be reversed. So let's look at some definitions. Cure, which basically means that everything is normalized and no clinical follow-up is required. Friends, there is no cure for diabetes, whether it be type 1 or type 2. Reversal. Again, reversal means the glucose levels have come down to normal, but it does not imply that any further support is needed. So you say, okay, now you go and enjoy your life. Sorry, sir, diabetes cannot be reversed. Resolution. Your original diagnosis was in error, probably because of a misdiagnosis from the lab. Yes, that may occur. So what is the definition? Definition is remission in diabetes that can occur. And there is an international consensus group was convened hardly a year back in August last year by the ADA. And they have defined remission as return of A1C to less than 6.5 after at least 3 months with usual diabetes medications. And it also means, very, very important, that patient requires ongoing support to prevent a relapse, including lifestyle changes and regular monitoring to allow. Now, that is very important. Not the end of the story that your sugar has come to normal. It's a lifelong condition. And it depends whether if surgery was the response for it, then 3 months after the procedure and 3 months after using medication. And if lifestyle changes, then 6 months after the beginning of these changes and 3 months after medication, because lifestyles take some time to act. But remember, remission is typically achieved with intense medical supervision and treatment. It is unclear if this heavy medical support provided in a clinical trial can translate into your day-to-day clinical practice. So these are the caveats you must understand. And we all know that when the blood sugar falls rapidly, retinopathy develops or worsens. And remember, even if your sugars come down to normal, micro and macrovascular complications can still occur. So it is very important that you have an ongoing monitoring system like annual A1C, a healthy lifestyle, avoid medications that cause hyperglycemia like steroids and antipsychotics, annual fundoscopy, and regular checkup for renal function, foot health, and blood pressure levels. So all this is a part of the game. Now, let's look at some of the clinical profiles that we have seen of so-called diabetes remission post-GDM. Patients go into remission, and then maybe 5 years, 10 years down the line, they develop diabetes. After COVID, we saw a lot of diabetes patients. Majority of them have come down to normal now, to stress-related or stress-induced diabetes. Drug-induced diabetes, and the number of drugs, we know steroids, diazoxide, thiazides, beta blockers, statins, even statins can lead to precipitate diabetes. Reversal of glucose toxicity. Patient comes with very high blood sugar, put him on insulin or the glargine, metformin, sitagliptin as in the REMIT trial, and patient goes into remission for about a period of 6 months, 1 year, 2 years. But don't forget the honeymoon phase of the type 1 diabetes. And this can last anywhere from 1 month to 13 years. And these are the patients who the Babas claim that I have cured of diabetes. Post-bariatric surgery, and we have sufficient evidence today, but the magic figure is a loss of 15 kg of weight. That's the magic figure, you must remember. And it is likely that less than 1 gram of fat in the pancreas can lead to diabetes. And each percentage increase in pancreatic fat increases the risk of diabetes by 7%. Now, who is the key player? Key player is the liver. And we all know triglyceride is stored intracellularly in the liver, and this affects the sensitivity of the liver to insulin. If you decrease the fat content of the liver, insulin suppression of glucose production can improves fasting plasma glucose. Storage of liver fat can only occur when the total daily calorie intake exceeds expenditure day after day, year after year. And during chronic positive calorie balance, any excessive carbohydrate after the glycogen depots are full is then stored by the process of de novo lipogenesis and triglycerides synthesized in the hepatocytes rather than in the adipose tissue. And this ultimately, insulin resistance in the muscles, which is the first detectable signal, leads to hyperinsulinemia. It further creates the vicious circle of excess fat storage in liver, metabolic stress in hepatocytes, and early rise of the liver enzyme. Friends, remember? Not working? Hello? Not working? Okay. So before diagnosis of type 2 diabetes, there is a long silent scream from the liver, and we often ignore it. And this is what is known as the twin cycle hypothesis. If you look at the cycle, the handlebars have excessive calories that are coming in day out, And this bicycle is controlled by the handlebars. And if you look at the front wheel, that is the liver, where there's increase in liver fat, resistance to the insulin, increased basal insulin secretion, and ultimately this leads to a vicious circle. So much fat is there in the liver that there is an overflow from the liver into the pancreatic, the cycle, the bicycle, the other portion of the bicycle. And this excess fat then causes increase in the islet triglycerides, a decreased acute insulin response, and ultimately the person develops type 2 diabetes. Now, if you are trying to drive this cycle, you're going to be shocked. Why shocked? If you look at the front wheel, it's going in the opposite direction. And the only way to correct is to correct the handlebars by reducing the total number of calories. If you reduce the total number of calories, the direction can be reversed. Now, this was a hypothesis. And we had the counterpoint study counteracting the pancreatic inhibition of insulin secretion by triglyceride in 2011, where patients were given 600 calorie diet. And during an 8-week period, various parameters were measured. And it was seen that over the 8-week period, with 600 calorie diet, there was a loss of 15.3 kg of weight. And what was the result? Fasting plasma fell from 166 to normal. Liver fat fell by 30% during the first 7 days. And this, the relationship of the liver cells and the fall in the fat was confirming the first part of the twin cycle hypothesis. There was no change in the muscle resistance, mind you, muscle insulin sensitivity. But if you look at the insulin, first phase insulin secretion, it took some time and then gradually it improved. So what was the meaning? It means that the beta cells were not dead. They were merely metabolically inhibited because of the excess fat. Is remission of diabetes durable? And then came the counterbalance study again in 2011, and they wanted to answer. So they further continued the study. This was counteracting beta cell failure by long-term action to normalize calorie intake. And this was done in another 30, and there was no weight gain, regain in the next 6 months. And look at the improvement in the liver fat, pancreatic fat, and all that insulin secretion. So if there was no weight gain, improvement persisted. And remember, 60% of remission occurred in those who had a duration of diabetes of less than 4 years. So it is also important, duration of diabetes is also important. And look at the dietary interventions that have taken place, the direct study, I'll talk about it, the diadem study, and basically the Vitra health study which used the ketogenic diet. The details, 46% to 60% remission. But look, what was used? Meal replacement. So they did not take regular food. And this was the direct study I talked about. Very low calorie diet for 3 months using meal replacement, structured food, introduction at 2 months. And this was the standard care. And this was conducted by the primary care nurses in UK or dietitians, and 8 hours training they had taken. And at 12 months, at the end of 1 year, 24% achieved weight loss of more than 15 kg. Again, I remind you the magic figure of 15 kg. And 46% intermittent group had non-diabetic A1C of all drugs. The liver fat fell from 16% to 3%, and pancreatic fat from almost 9% to 8%. Now this was, it remained constant during remission. But the importance is the remission depended on the degree of weight loss. Higher the weight loss, higher the chances of remission. Shorter the duration of diabetes, higher the chances of remission. And these are people who are on less than 6 years of duration of diabetes. So what is happening? We all know the pathogenesis of type 2. It is just a reversal or remission, you can call it. Liver fat comes down, liver fat export decreases to the pancreatic, pancreatic fat comes down, and the beta cell function improves. So very simple, you are just reversing the cycle. Now, there are some responders and there are not non-responders like in any other thing. Why is it that some people respond and some don't? Now, if you look at responders and non-responders, liver fat falls in both, pancreatic fat falls in both, but those who respond, there is improvement in insulin secretion. Those who do not respond, they do not have improvement in insulin secretion. And what is the cause? The cause is that there is some intrinsic defect in the beta cell. So there has to be an intrinsic defect in the beta cell if these patients don't go into remission. Now, the diets that have been used, low carbohydrate diets and very low calorie diets, that less than 800 calories. I will not go into details of low carbohydrate diets or very low calorie diet. Suffice it to say here that both diets are effective in facilitating weight loss and remission of diabetes. They are considered safe if appropriately supported and medically supervised. And it is also said that there is limited evidence that even without weight loss you can go into remission, but it is not sustainable. And the main driver and predictor, again and again I'm saying, is more than 15 kg weight loss. But the question is, are these diets sustainable? They are work only for a targeted, motivated population under a strict medical supervision and dietary counseling. Ketogenic diet, very much in fashion today. It's a low carbohydrate, high fat, high protein diet. We know that very low calorie diet produces ketosis, but it's because of energy deficit. Whereas the ketogenic diet does it by forcing the body to metabolize fats instead of carbohydrates. And the diet is not energy deficient. It does not reverse liver and pancreatic fat. Thus, it helps control glucose, but not insulin resistance. So it just fails to challenge insulin sensitivity. So ketogenic diet is no use. And there are the various diets under one umbrella, not much difference no matter what diet you use. And look at the remission, 54% with total diet replacement. Total diet replacement. Is it possible in your clinical practice? Friends, whole plant diet is the most effective for type 2 diabetes remission, says the American College of Life Medicine. And they say that you take plant-based foods, and there are healthy and Mediterranean, DASH, whole food plant-based diets. So what I say, the message I want to give is that go for the SNAP diet. And what is the SNAP diet? It should be sustainable, it should be nutritious, it should be affordable, and it should be palatable. That is the SNAP diet. So in whom does dietary intervention work? Less than 6 years, better glycemic control, less medications, males, good insulin secretion, less visceral fat, and good mental health, and who are motivated. Remember, we have data only for 2 years. More data is needed in an ethically diverse population, and there is often so-called relapse of these patients. What about physical activity? Even a single bout of exercise substantially decreases both de novo lipogenesis and plasma VLDL. But both calorie control combined with exercise is much more successful than calorie restriction alone. However, if you say only exercise, it is not going to produce weight loss. And it is important that both be combined together. And to maintain that, it is to have a combination. The critical factor is sustainability, both for diet and exercise. So what are the lessons we have learned from the twin cycle hypothesis? Is long-standing type 2 diabetes reversible? Yes, we have seen with bariatric surgery. Is diabetes with normal BMI reversible? Yes, because they have a fatty liver and you know how to diagnose fatty liver clinically. I don't have to go into the clinical details of this. Will diabetes come back? No, provided you maintain that weight loss. And remember, there's a distinction between weight loss that improves sugar and weight loss that causes diabetes remission. So what advice you give to patient to prevent weight gain? Eucaloric diet, low GI glycemic index with high protein diet. And that is the important thing. Now, bariatric surgery, we have seen wonderful results, particularly with Roux-en-Y gastric. and they are reduced in individuals who are on insulin, but durability favors bariatric surgery up to 10 years, but now we have data till 20 years in the latest ADA presentations. And results are basically, if you look at it, 73% surgical group compared to 13% intensive medical, but remember, is acute, profound decrease in calorie intake that is responsible. Of course, there are other mechanisms also. I don't want to go into details of that. There are certain genetic predictors, and we know food shortage as such can lead to remission. So what's new? Biochemical remission without any intervention, yes, provided you lose more than 10% of your weight in the first few years of diagnosis, you can have remission of 30% at 5 years. And this is a new drug that is coming up, dorzagliatin, which is a glucokinase activator, and it was used in the SEED trial, and it showed that there was a 52-week blood glucose remission rate of 65%. But then again, it is basically under trials. Now, this is the latest technology that Dr. Patni has been talking about, and this is the UpNight technology. This is from the Twin Health Mountain View, California, and they had patients who up to 8 years of that, and the remission rate, the time of increase, this is known as the twin precision treatment intervention, which basically has 4 sensors, the CGM to give you glucose values, the fitness tracker, the BP cuff, and the smart scale. And then you have a virtual image and you give a biofeedback, and the remission rates are almost to the 80%. Now, this was the slide that was put up in the ADA this year. We are back to square one. We know what is the definition. We know what are the predictors. But look at this slide in the middle. The failure rate gradually with time. So no matter what you do, no matter how much lifestyle intervention, no matter what diet, ultimately everything fails. So what is the concept now? They are saying, let's put them on maintenance therapy, just like it is done for cancer patients. So borrow concept from oncology. So if we're going to put patients on maintenance therapy, what remission are we talking about? So do I wrap up here or let the story unfold? कहते हैं कहानी अभी बाकी है, and I'm sure next year you're going to hear a lot about this. But remember, twin cycle hypothesis has told us that type 2 diabetes is no longer a long-term progressive disease. It is a reversible metabolic state precipitated by the single cause of chronic excess intra-organ fat, and which is accumulated in the liver and pancreas. And this makes the beta cells susceptible to fat-induced dedifferentiation. And this has changed the clinical guidelines today. Today, you are talking about if you want to treat blood sugar, treat obesity first. Bring down the weight. So the key message is, we must discuss about remission with every patient with short duration of diabetes of less than 6 years. No matter what you use, low-calorie diet or very low-calorie diet or low carbohydrate, remember, it is 15 kg weight loss that actually matters. Evidence is limited to 2 years, and we still don't know whether it's sustainable or not. So what are the issues? Remission offers hope. It requires support. It is not achievable for everyone. Intensive dietary change is not appropriate for everyone. Diabetes complications can still develop. And it all depends on the duration of diabetes, the weight loss, gender, and the motivation to achieve. Remember, friends, optimal diabetes management is about success, not failure. So people who do not achieve or sustain remission should not feel that they have failed. The health benefits of weight loss are much beyond reduction in A1C. Remember that. And the most important thing is structured and continuous regular support, including the involvement of dietitians for long-term success. So friends, in large percentage of cases, no matter what you do, relapse will occur. Don't blame your genes. Reduce the size of your genes. Thank you.
Great clinical pearls from Dr. Virmani. Thank you, sir. And a lot of food for thought for all of us now. And I invite the audience for some questions from our speakers.
Mike. How many are
Only
there?
question,
How
obviously.
many are there?
I think I gave you 15 questions. I think you have replied most of them. You said type 1 diabetes and honeymoon period. Why don't you use the same term in type 2 diabetes?
Conventionally, it has not been used.
No, don't go by convention. Why can't we use it?
Yes, you can use it. Why not? See, you can use it because the basic mechanism is same. The basic metabolic, the beta cells that are inhibited, they recover in type 1 diabetes after acute insulitis. And same thing is happening here. Here, it is not acute insulitis, but it is excessive fat that is deposited in the cells and they recover from that. So de-differentiation occurs. So the difference is there, slight subtle difference, acute insulitis, de-differentiation.
Actually, are you anti-honeymoon? It is a good drug. Use it.
Yeah. Honeymoon is always good.
So as far as medication is concerned, why don't you consider GLP-1 receptor agonist as one such modality for
My dear
remission?
People are not prepared to listen to diet. What about injectables, GLP-1, what, all that. Now tomorrow will say, why not use semaglutide oral 400 rupees tablet? My God, who is going to use it? Let us be practical. We live in India. We don't live in US. How many of you can afford to write or even afford to take a 400 rupees tablet per day, which is going to give you weight loss of 4 to 5 kg only, with no proven cardiovascular benefit also?
At least I think around 50,000 people
अरे
are
एक्सरसाइज
using.
करिए, आप तो यही सबको सिखाते हैं, डाइट करके एक्सरसाइज से कम दो, उसको तो करिए, फ्री में हो रहा है. आप क्यों 400 रुपया खर्चा करवाना चाहते हैं पेशेंट का? उसको इतना ही मोटिवेट कर दीजिए, वो 400 रुपये के बदले एक्सरसाइज करे, डाइट कंट्रोल करे, वो उसी में ही he'll be happy. Don't have to spend money on the drugs.
Even after,
let us be very realistic in life today.
There are patients which after giving the proper diet counseling and doing the proper exercise, you are not able to reduce the weight. Or
correct. Second
in that
step.
cases, I think there is a clear need of drugs.
Then go for bariatric surgery. Nothing like it. Go for
bariatric.
We have 20 years data now. 20 years excellent data. Highest remission rate with bariatric surgery.
Maybe in the days to come, the endoscopic bariatric surgery is coming up.
It is already come.
It already come, and I think there was excellent talk at the Dr. Patni conference.
Endoscopic bariatric surgery is the main thing today.
Yeah. But anyway, your talk was so illuminating that you balanced both. You yourself proposed it, remission is possible. You yourself proposed that it is not possible,
I never said it's not possible. I said possible, but look.
But only for two.
How much?
Yeah.
How much is required? 15 kg weight loss is not a joke. How many can you afford to lose?
But even with the semaglutide, in few of my patients, they are losing 8 kg in 2 months.
Sorry, I am not here to promote any pharma company's drug. But I can at least say, whatever drug you want to use it after proper motivation of the patient for diet and lifestyle. As simple as that. Let me be very simple and realistic. There are, dulaglutide is also there. I think it's a wonderful drug for reducing weight. Yeah.
Severe insulin deficient cluster, which previous talk was we heard just now.
Do you think Dr. Saini?
Dr. Saini is not here, I think.
Okay.
Do you think in those cases any remission will work?
In those cases?
Of the severe insulin deficient cluster.
No, that, okay, let me tell you. I wanted to discuss this with Dr. Saini also. The previous talk was excellent talk on the clusters. There's nothing new at the moment because now we have clusters even in pre-diabetes. Forget diabetes, even in pre-diabetes. The problem with those clusters was they were never validated in the Indian Asian population. The first study was done by Dr. Mohan et al. From Chennai, and he had the first validation done. And we had absolutely stunning results. And you know what are the stunning results? He said the age-related and obesity-related is very common. It is not common in India, sir. In India, what is common is severe insulin resistance and severe insulin deficiency combined. So what we are seeing down in South, of course, South means they have the whole Indian population in view, and they are coming out with an app, and they'll send you an app, and you feed the variables, and you will know what is the type of cluster this patient belongs to you. So today, the fact is that in the Indian population, It is the severe insulin deficiency and severe insulin resistance that is combined and present in the majority of cases.
Never you will get remission in
No,
those
no, no,
cases.
no. It's very difficult, very difficult.
That's why that is a good point.
Very difficult. Yes, sir. Sorry, sir.
Some patient, underweight patient, they have already weight of 40 kilograms. Should we reduce to minus 15,
See,
up to 25?
Yeah, any reduction in weight. Now, even in a person who is lean, what is the advantage of losing even 1 or 2 kg of weight? You are losing the pancreatic fat, you are losing the liver fat. That is the importance. Even 1 gram of fat causes increase in 7% of diabetes. So even if you lose 500 milligram of fat from your liver or pancreas, that is going to give you a lot of benefit.
It may not be the overall body weight which is of concern, that the fat content of the organs, liver and pancreas, which need to be reduced, and there where the pharmacotherapy comes. Yeah, what he said was lifestyle, definitely. No.
His point is, suppose my weight is 30 kg.
I agree.
Should I reduce more, less?
No,
For
no,
the
not
remission, it
necessarily.
is not possible. Rather, the thing is that the cluster is coming up, and according to the cluster, we have to go for the interventions. So in that cluster, it is not possible, it is not required, it will not
See,
work it also.
Again, sir, I must tell you, there are 2 ways of losing weight. One is by looking at the weighing scale, and the other is looking at your waist circumference. And which is more important? Your waist circumference. So even if your waist circumference comes down by 1 centimeter, it is equivalent to weight loss of almost 4 to 5 kg on the weighing scale. So you don't have to see any changes on the weighing scale. As I said, just adjust your genes, they become tighter and tighter.
Sir, this you are telling about the central obesity and peripheral obesity.
Right, sir.
And then you can make out by CT scan of abdomen whether there is a central obesity or peripheral obesity.
Absolutely.
So it is most important to reduce his central obesity rather than peripheral obesity.
Visceral,
That
visceral,
should be
sir.
the
Visceral
basic-
obesity. Visceral obesity is more important to reduce.
Thank you, Dr. Virmani, for such an entertaining and enlightening session. So with this, I would like to invite our next speaker, Dr. Sameer Dani from Ahmedabad. Over to you, Dr. Sameer Dani. Sorry for the interruption. We need some felicitation, right? करना है अभी? करना है felicitation?
I'd like to, Dr. N.K. Singh, I'd like to felicitate our speakers. हाँ उनको इसके नहीं उसके बाद दिलवा देंगे डॉक्टर ऐसी बता our HOD डॉक्टर विरमानी सर डॉक्टर विजय पटनी डॉक्टर N.K. सिंह
मेरे को भी क्यों दे रहे हैं वो
शैलेश भी डॉक्टर पंकज गुप्ता डॉक्टर शैलेश डॉक्टर चेतन भाई पंकज सर चेतन भाई
Hello everyone. Now we will start our next session. For that, I would like to invite our chairpersons, Dr. Kaku Shah, Dr. Nimit Yagnik, and Dr. Vinay Patel to preside over the next session.
फेलिसिटेशन लोगों को करना है ठीक है हाँ बैठ जाइए मुझे पता नहीं था तो सर वो देख लीजिए कैसे क्या करना है अनाउंस करेंगे फेलिसिटेशन
Good morning, everyone. So now we proceed to session 2 with plethora of speakers in cardiology. So may I invite the first speaker, Dr. Samir, to deliver his talk.
Good morning. Am I audible? Yeah. So first of all, thank you very much. I am honored and privileged to be here talking to you. Thank you, the organizers, the chairpersons. Let me begin my talk quickly. But before that, I couldn't help but notice the last talk. The discussion it generated. It's very exciting because we are talking about the benefits of prevention. We are talking about the benefits of primary and secondary prevention. And by inducing the remission in diabetes, we are mitigating certain risk of developing the coronary artery disease. And as a cardiologist, I must say that nowadays we are seeing that more and more specialties are merging together with the same common goal, and that is mitigating the risk of developing coronary artery disease. Because the final pathway for most of the metabolic diseases, or almost all the metabolic diseases, is coronary artery disease and heart failure. And that is how these patients die. The cardiovascular death is one of the biggest or the biggest cause of death in across all the countries, developing or developed or otherwise. So, and I love the statement that the benefits of weight loss are beyond the benefits of reduction in HbA1c. Similar to what we say that benefits of exercise are beyond the benefits of weight reduction. So exercise benefits outweigh the benefits of weight reduction. Not outweigh, I would prefer to say that it goes beyond the benefits of weight reduction. And if weight reduction happens, it's even greater. So then those benefits outweigh the reduction in HbA1c. Then if reduction in HbA1c happens, those benefits go beyond anything else in prevention of coronary artery disease. Now, coming back to coronary artery disease, the ESC guidelines on stable angina changed the word or the phrase or the diagnosis stable angina, because we have come to realize in last 10 years or 15 years that chronic stable angina is not really so stable. And that's why the term which is used now or preferred is chronic coronary syndrome, because this particular group of people or patients have different presentation and different way of progression of the disease. So chronic coronary syndromes encompass so-called stable angina or dyspnea, but that is a very small part. Generally, it is progressive. There is new onset of heart failure and suspected coronary artery disease. There are stabilized symptoms of less than 1 year after ACS or recent revascularization, or there are patients who have been there 1 year after initial diagnosis or the revascularization, or those are the patients who present with angina and suspected vasospasm or microvascular disease, and there are asymptomatic patients who are detected to have coronary artery disease on screening. And all these patients encompass the clinical spectrum of chronic coronary syndrome, and they have very different connotations and different way of progression of disease. We also know that the pillars of cardiovascular prevention are right now lifestyle, medical risk factor modification like lipid lowering, blood pressure lowering, glucose lowering, ACE inhibitions, anti-inflammatory, etc., and antithrombotic. And by using antiplatelets, we mitigate this thrombotic risk. Of course, lifestyle is very important. Medical drugs are very important. Today, my job is to focus on the thrombotic risk and how to mitigate that. We also know that any patient of coronary artery disease, when treated medically or surgically, after revascularization also, he has that residual risk. Statins reduce the risk by, say, 40%, but that 60% risk is still there, residual. And with optimal medical management, you have residual risk. And that residual thrombotic risk is not very effectively reduced by dual antiplatelet therapy in all the patients, not across the clinical spectrum that I just mentioned. So intensified antiplatelet regimen, we thought that by giving them dual antiplatelet therapy and even triple antiplatelet therapy by adding sulastazole in some studies, we thought that we could decrease the thrombotic risk in many patients, but it doesn't so, and it comes at a cost of increased bleeding. So dual antiplatelet or triple antiplatelet therapy across all the studies has shown that it reduces some amount of residual risk, but doesn't do so across the spectrum and doesn't decrease the mortality. So reduction is in non-fatal CV event, no significant reduction in fatal CV event, slightly increased bleeding, and no mortality benefit. And we have to look at other ways of mitigating this thrombotic risk. And the pathways for platelet and thrombin activation are just not only through platelets, it comes through the contact of platelets with the exposed vessel wall and direct activation by thrombin. And that's why thrombin inhibitors do play a role. And that's how the logic or the rationale behind using low-dose rivaroxaban to inhibit factor Xa to reduce the thrombotic risk came into play. And that was the thought behind the COMPASS study, which evaluated dual pathway inhibition approach versus aspirin in stable CAD. Patients with coronary artery disease who had MI within last 20 years, or patients with multivessel coronary artery disease with symptoms or history of stable or unstable angina, or multivessel PCI, or patients who had a CABG surgery with undergoing multiple grafts were enrolled. Aged, they were divided into two groups, 65 or plus and less than 65, with atherosclerosis or revascularization in 2 or more vascular beds, or less than 65 years with more than two or more additional risk factors out of these 4. Current smoker, diabetes, EGFR less than 60 ml per minute, heart failure, or prior ischemic stroke, non-lacunar. There was also another group of patients with peripheral artery disease, and they were also included in this. So 2 distinct groups included in the COMPASS study who were treated with DPI. The exclusion criteria was where the clinicians felt there was clear-cut need for DAPT or oral anticoagulant therapy, stroke less than 1 month, any hemorrhagic or lacunar stroke, very severe heart failure with ejection fraction less than 30% or NYHA less than 4, and EGFR less than 15 ml per minute. The results, it reduced the MACE rate, cardiovascular death, MI, and stroke, and all-cause mortality across the spectrum. It achieved the reduction in the endpoints, primary and secondary, across all the strata. A landmark trial indeed. The most important mortality benefit came from stroke reduction, but more importantly, the fatal and intracranial bleeding were low, and it was not statistically very different from aspirin alone. So this benefit came at a cost of increase in the major bleeding, but not increase in the fatal bleeding or ICH. So the trade was kind of acceptable. What are the drivers for high ischemic risk in CCS patients or chronic coronary syndrome patients? If you look at the REACH registry, the number of risk factors increase, the ischemic risk increases. So age more than 65, smoking, diabetes, renal dysfunction, heart failure, carotid disease or other peripheral arterial disease, or prior stroke. Your patient has any of these risk factors or enrichment criteria, and more than 1, 2, 3 such criteria, the ischemic risk increases, as you can see from the table, from the bar chart. And these patients, CAD and PAD, previous MI, diabetes, renal impairment, heart failure, were represented in COMPASS study. And if you look at these subgroups, again, they had the highest benefit from DPI, dual pathway inhibition. You can see that compared to aspirin alone, these patients, though they were chronic stable angina or chronic coronary syndrome, they derived more benefit, much higher benefit from dual pathway inhibition than aspirin alone. So we were, as cardiologists, we were inclined to think that way, that once we have done angioplasty or bypass after 1 year of dual antiplatelet therapy, once they are into chronic stable phase, we can reduce the antiplatelet agents, reduce the incidence of bleeding, and still have the same reduction in the thrombotic risk. We learned that dual pathway inhibition brings about higher reduction in thrombotic risk and reduction in mortality compared to aspirin alone. Or if you look at it historically, compared to DAPT also, because no DAPT trial has shown mortality benefit. If you look at the net clinical benefit, the concept is what is the benefit in mortality you get versus what is the risk of bleeding. So it's a trade-off. Higher the mortality benefit or higher the MACE benefit versus lower the risk of bleeding, you have more net clinical benefit. So the concept of NCB or net clinical benefit is kind of subtraction of risk from the benefit. And if you look at that, the net clinical benefit with dual pathway inhibition was great, number one. Number two, that net clinical benefit increased over time. So the risk of bleeding did not increase as you continue to give DPI to these patients months after months, years after years. Once you go beyond 1 year, 2 years, and 3 years, the gap widened. Means the risk of bleeding did not increase so much and the benefit increased significantly. So the net clinical benefit with COMPASS increased over time, and these curves were separating over a period of time, which means that DPI or dual pathway inhibition should be given persistently for a long time. So these are, I think these are the main take-home messages from COMPASS trial. It demonstrated significant reduction in mortality, fewer patients died by the end of trial in DPI arm than aspirin alone. The more the risk factors, more the benefit. The net clinical benefit was higher when you treated the patient longer. So if you compare with all other DAPT trials, the DPI trial gave you much higher net clinical benefits, and it gave you reduction in the mortality. So this is, now how does it compare with other trials of other agents? Like lipid lowering, if you compare with PCSK9 inhibitors or if you use SGLT2 inhibitors, COMPASS fares or the rivaroxaban therapy or the DPI approach compares almost same. So you get significant benefit, as much benefit with using dual pathway inhibition, say as much with lipid lowering. So that way, this is very important that patients of coronary artery disease or symptomatic peripheral artery disease who are at high risk of ischemic events, you use dual pathway inhibition, and now the guidelines have changed for the management of coronary syndrome, or the ESC guidelines for the management of ACS have now incorporated dual pathway inhibition as class 2A recommendation in high ischemic risk group and as class 2B in moderate ischemic risk group. So as a clinician, whom should we prescribe DPI? So the high ischemic risk, which is defined as diffuse multivessel CAD with any one or more of risk factors like diabetes, recurrent MI, peripheral artery disease, or CKD, or any of these risk enhancers, you give DPI. I'll not go into details of this because of time constraints now. I'll just go on to the treatment option of rivaroxaban and aspirin, and it compares favorably compared to DAPT. So chronic disease phase and post-procedural phase have to evaluate every patient whether he merits dual pathway inhibition or not, especially at the end of 1 year of the index event. Coronary artery disease, cerebrovascular disease, and PID, it reduced the primary MACE outcome by 24%, highest benefit in coronary artery disease plus peripheral artery disease, diabetes, CKD, heart failure, and prior stroke. That's it. Thank you.
Thank you, Dr. Sameer, for such a wonderful presentation. So question answer will be taken at the end of the session. So I would like to invite our next speaker, Dr. Atul Abhyankar from Surat. Dr. Atul? Okay. So Dr. Atul is not available, so we would move to next speaker. So I would like to invite Dr. Paresh Pai from Mumbai.
If I have seen further, it is by sitting on the shoulder of the giants. We have stalwarts
Thank
over
you,
here
Dr. Paresh.
who are helping us for fine-tuning the management of our patients. Thank you, all the speakers.
Good morning. It's indeed a pleasure to be here with you, and I'd like to thank the organizers for the kind invitation, and I really appreciated the interaction with the audience. I'm going to be speaking on management of venous thromboembolism and protecting patients with cancer-associated thrombosis. There's a very high risk of recurrence of VTE once we discontinue anticoagulation. And as the time goes by, the incidence goes up. The cumulative incidence of recurrent VTE is approximately 10% in the first year if anticoagulation is stopped. So guidelines are constantly evolving. The ESC 2014 PE guidelines suggest that patients with second unprovoked pulmonary embolism were recommended to receive anticoagulation for an indefinite duration. This is a class 2A level B recommendation. The ACCP 2016 guidelines suggest that if it's unprovoked with local moderate bleeding risk, we suggest extended anticoagulation therapy, that is no scheduled stop date over 3 months of therapy, grade 2B. If it's provoked by surgery or a non-surgical transient risk factor, anticoagulation for 3 months, grade 1B. Now this has changed a little bit, which I'll talk about a little later. The ESC 2019 PE guidelines suggest that oral anticoagulation therapy for indefinite duration is recommended for patients presenting with recurrent VTE, that is at least one episode of PE or DVT, not related to a major transient or reversible risk factor. So how does one look at this? So if you have a major transient provoked risk factor, for example, major surgery or trauma, the risk of recurrence of DVT is very, very low. It's less than 3%. But if you have a minor transient provoked risk factor, for example, pregnancy or long-haul flight, or if it is unprovoked, that is, there is no identifiable risk factor, then it's an intermediate risk varying from 3% in the minor transient provoked to 8 to 10% in the unprovoked case. If it is persistent provoked, for example, active cancer or thrombotic tendency, the risk is very high, up to more than 8%. So in these 3 cases, you consider extended anticoagulation. This is constantly changing over a period of time. About 10 years ago, it was suggested that if you had unprovoked, clearly you give it for an indefinite period of time. But if it's minor transient provoked, you can stop it. But data now has shown that when you look at these patients, the risk is a bit more. So here you can see that Einstein choice and Einstein extension pooled analysis suggests that there is a definite drop in recurrent DVT when it is given for a longer period, with the bleeding risk being less than 1%. What is also seen that rivaroxaban, when compared with just aspirin, shows that it's significantly reduction in the recurrence of VTE. And here, VTE provoked by minor risk factors with a similar risk of VTE recurrence compared with unprovoked is almost similar. Here you can see that one of them is 10%, the other is 5%. And here you can see that if it's a minor you get a risk of 10.7 and 4.9%. So both of these fit into the same criteria. So real world experience also suggests that there is no significant increase in major bleeding when extending anticoagulation in provoked VTE patients. So what are the clinical considerations when you look at for extending treatment of VTE more than 3 months? So one is unprovoked DVT. Second is VTE provoked by major persistent risk factor such as active cancer. If somebody has recurrent VTE, or VTE is provoked by a minor persistent risk factor. So consider a step-down treatment approach, where if you are using rivaroxaban, you start with 15 milligram twice daily for 21 days, 3 weeks. Then you continue for 3 to 6 months treatment with 20 milligrams, and then extended treatment depending upon the risk of bleeding. You can give it either for 20 milligrams once daily or 10 milligram once daily. Do not reduce the dose if there is recurrent VT on a lower dose, or it's a complicated comorbidity in the form of active cancer, high-risk thrombophilia, or concomitant atherothrombosis. Patients with cancer-associated thrombosis face an increased risk of recurrent VT and major bleeding compared to those without cancer. Here you can see that the drop in recurrent VT is significantly less. With cancer is significantly more. It's about 20.7 versus 6.8. And here you can see that the bleeding risk is also more. So what is the common regimen that is advocated? So basically there are two types of therapy. One is a sequential regimen where you start with either some form of heparin, unfractionated, low molecular weight, or a pentasaccharide like fondaparinux, and then change over to either a VK antagonist or using endoxaban, which is not available in India, so we don't look at that. Or you use a single drug approach in the form of rivaroxaban, where you start with 15 milligrams twice daily and then change to 20 milligrams. Or you use apixaban 10 milligram twice daily for the first 7 days and then drop to 5 milligram twice daily for the subsequent period. Or you can use low molecular weight heparin 200 international units per kg once daily and change to 150 units per kg daily after 3 weeks. So randomized trials in cancer-associated thrombosis, a meta-analysis suggests that all of these favor use of NOACs as against low molecular weight heparin. Major bleeding is more with NOACs comparatively, but it's not statistically significant. So what are the various cancer-associated thrombosis data that's available? So you can see that there are two types of studies which are there, where it includes both cancer and non-cancer patients, and subsequent to 2018, you have specific patient trials which are for cancer-associated thrombosis. This includes the Hokusai trial, the ADAM-VTE, the SELECT-D extension, which is for rivaroxaban, Caravaggio, which is with apixaban, and you have the Casta Diva and the Conco 11 trial that we'll refer to shortly. Now you can see here the Callisto program with rivaroxaban with a multi-study global initiative dedicated to addressing unmet needs in CAT. You can see the amount of data and the amount of trials which are there, which go to suggest, to look at the effectiveness of rivaroxaban. There are a few for endoxaban and quite a few for apixaban. So let's look at the rivaroxaban as a broad range of evidence in patients with CAD. So you start with the initial data, which is the Einstein. You have the Einstein DVT, Einstein extension, Einstein P, and Einstein choice, which includes both cancer and non-cancer. And you have the Callisto program, which includes the Casta Diva, the QAI, the Cosimo, the SELECT-D, the SEER, the Mayo Clinic data, and other real-world experience. So let's just look at the Cosimo study design. This is to assess patient reported treatment satisfaction with regards to anti-clot treatment scale, the ACTS burden score, for the use of rivaroxaban for the treatment of VTE and or prevention of recurrent VTE in patients with active cancer changing to this therapy. So you have patients who have initially been treated with low molecular weight heparin and warfarin or acenocumarol. Around 4 weeks, more than 4 weeks later, you decide to change to rivaroxaban. So you see the ACTS at baseline. You see the ACTS at 4 weeks, 3 months, and 6 months. And you look at the primary outcome, what is the treatment satisfaction with ACTS burden score at 4 weeks. So it's a short design. international prospective non-interventional cohort study. And what does it show? It shows that over time period, when patients were treated with rivaroxaban, there is a sustained benefit at 4 weeks, 3 months and 6 months with the reduction in the ACTS. Also, when you look at the FACIT fatigue score, that's functional assessment of chronic illness therapy, you find that the scores improve steadily and statistically after 4 weeks. So it's a sustained benefit and patients feel happier. So look at the SELECT-D trial. So SELECT-D compares the role of rivaroxaban versus dalteparin for the treatment of cancer-associated thrombosis. This is a study design involves a prospective randomized open-label multi-center pilot phase 3 study to look at recurrence of VTE in CAT, and the study same dose of rivaroxaban 15 milligrams twice daily for 3 weeks followed by 20 milligrams once daily versus dalteparin 200 international units per kg once daily for first 30 days followed by 150 international units per kg once daily. The significant variables that were looked at was stage of the disease, baseline platelet count, type of VTE, and the risk of clotting by tumor type. So what you can see here, that with the rivaroxaban, the decrease in VTE is statistically significant, comes down by 57%. And bleeding is not really very high, except when you look at clinically relevant non-major bleeding, where it is a little bit more with rivaroxaban. So major bleeding, hardly any difference. Chronic relevant non-major bleeding is a bit more, but there was no CNS bleeding events were observed in either arm. Most of the major bleeding events were at GI site, so GI malignancies. So these two studies are landmark studies. One is SELECT-D and second is Caravaggio. Caravaggio uses apixaban versus dalteparin, and SELECT-D we talked about is rivaroxaban and dalteparin. Here you can see that both there is a significant reduction in the recurrence of VTE. So what is the difference? The difference is the GI. Here you can see that the SELECT-D had more patients with all GI malignancies and also all GI upper malignancies, upper GI malignancies. And that is one of the reasons why the bleeding risks were a little higher in the SELECT-D as compared to the Caravaggio. So here you can see that major bleeding is a little more, what we talked about before. Clinical relevant non-major bleeding was much more, almost 3 times. But when you look at the Caravaggio, the major bleeding as well as the the clinically relevant non-major bleeding was less with apixaban as compared to dalteparin. So why is this happening? So one of the reasons is that there were more lower GI bleeds, GI cases in SELECT-D as compared to Caravaggio, and that is one possible explanation of why there was more bleeding in the SELECT-D as compared to the Caravaggio study. So what is bleeding important or is death more important? So results from Caravaggio and Hokusai VTE cancer demonstrated that VTE recurrence contributes to more deaths than bleeding in patients with cancer, a trend also observed in a meta-analysis of RCTs with prospective randomized trials. So here you can see that VTE risk is almost 3%, whereas bleeding risk is 1.5%. So when you look at real-world studies, there are 2 types of studies. The Zalia, the MSK, the Mayos, these are prospective cohort studies. And you have retrospective studies, which are the US Department of Defense, US market scan claims, and the SC study Pignatoros studies. So what do all these studies show? That the recurrent risk is 3 to 4.5%, and major bleeding is 1.5 to 3%. And the mortality can range from 0.5% in Zalia and MSK. The Mayo showed very high results, almost 30% mortality because it's a select group. What is also seen that the treatment duration in the US claim study, that patients who had rivaroxaban took the drug for a longer period as compared to patients who were on low molecular weight heparin. So compliance is much better when you are taking rivaroxaban, and as a result of this, you can see that statistically significant improvement in recurrence of VTE when you are using rivaroxaban as compared to low molecular weight heparin. So rivaroxaban effectiveness and safety in VTE patients and active cancer in real world studies all goes to show that it's a benefit for reduction in VTE. So summary of guidelines for treatment of CAT. You have the initial data up to 2019 where you had the option of using low molecular weight heparin with either endoxaban or rivaroxaban as an alternative. Subsequently, 2021 and 2021, you had these two studies which showed that it's preferable to use the NOACs as compared to LMWH, and minimum you use for 3 months, but ideally you should use for long term as long as the malignancy is in place. So in summary, cancer-associated thrombosis is associated with a high risk of VTE recurrence and major bleeding, and therefore an increased risk of mortality compared to patients without cancer. Various risk stratification tools are available for the primary and secondary prevention of VTE in patients with cancer. Evidence-based guidelines now recognize NOACs as part of standard of care for patients with CAT. Over the last 10 years, extensive clinical experience with rivaroxaban in patients with CAT means it has a larger evidence base than any other NOACs in this indication, and patient preferences and treatment satisfaction play a key role in choosing a treatment for CAT that best fits the patient's individual needs. Thank you.
Wonderful presentation by Dr. Pai. Question answers will be taken at the end of the session. So I would like to invite our next speaker, Dr. Prafulla. Okay, Dr. Prafulla.
Dr. Prafulla Kerkar is an eminent cardiologist from Bombay, and he has a lot of work and name to his credit. May I request Dr. Prafulla Kerkar to deliberate his talk.
इसके अंदर लगाना इधर लगा तो बाहर आ जाएगा बेल्ट. Okay, thank you. Thank you. Well, respected chairpersons and dear friends, good afternoon. And moving away from the previous topics, all heart cardiology topics from vascular events, I have been assigned to speak on targeting worsening heart failure event with variceal guard. Well, at the outset, let me not only thank the organizers, when led by Dr. Akash Singh, Dr. Kamaldeep Chawla, who's a cardiologist, and your good self, Dr. Anuradha, I believe. Yeah. So I commend them, not only, I congratulate them on their first diabeto-metabolic conclave that they have come up with, cardiometabolic conclave. But also I commend them for having included heart failure topic out here. Why? It's even the ADA has taken note of it recently, July 2022. ADA also tells you guys that heart failure is an underappreciated complication of diabetes. And this goes beyond vascular disease. Heart failure in diabetes can occur irrespective of whether you have coronary artery disease or whether you have hypertension. So that's how important heart failure is for you diabetologists. I suppose most of you out here are physicians and diabetologists. So having said that, the focus of my talk is, rather than diagnosis of heart failure, I'm going through a smaller fraction of those heart failure patients who have worsening heart failure. So I'll focus on what is worsening of heart failure, what is the role of this new molecule, which is as of now yet not available in India, but it's likely to become available next month onwards, I am told, the Vericiguat, and how it was tried out in the Victoria trial, and then the practice pearls of how to use Vericiguat. I haven't myself used Vericiguat, however, I've been using Riociguat for pulmonary hypertension, not to confuse it with that. So at the outset, let me take you through the journey of a heart failure patient, right from the time of the diagnosis till perhaps end of life. At the beginning, there are all these risk factors. Diabetes comes in there too. And risk factors tend to escalate. And if you have not controlled the risk factors, the inevitable is going to happen. That is, his risk of developing heart failure increases. And up until the point that you have diagnosed heart failure. Even after you have diagnosed, can I use the mouse? Yeah. Is that seen? No, that's not seen there. Which is a pointer out here? How do I speak? No. Yeah, so this mouse doesn't come up there, is it? Can you help me with the pointer? How do you use this? I don't know. Because I can use the mouse otherwise. Thanks to the corona pandemic, we are giving virtual talks, and I don't want advancer. I know to advance slides. I want to point out to what I'm speaking. Okay, which one is the pointer?
Center.
Center. And sorry, never mind. स्क्रीन पर नहीं चलेगा, लेकिन इस स्क्रीन पे माउस चलेगा, उधर नहीं चलेगा. I know, I believe it's your first conference, so that's fine. But okay, now coming back to up until the point of diagnosis. Even at this point, if you see that the baseline heart failure risk is still partially higher, isn't it, compared to not having heart failure. What is this risk about? That once you have made a diagnosis of heart failure, you are likely to get recurrent hospitalization for heart failure again, or you are even likely to die. Your probability increases. So right at the outset, when you have diagnosed heart failure itself, you are at a high risk. And unless you have given the patient guideline-directed medical therapy. So that's how important treating heart failure is. And in spite of having, and once you have started guideline-directed medical therapy, you can see that the risk has come down. The risk has come down. However, it has not reached to the pre-heart failure diagnosis level. It can never. So yes, still we give all the guideline-directed medical therapy, including we can even use device therapy. We can use CRT, etc., and try to keep the patient, so to say, in stable heart failure. Dr. Dani spoke to us about there is nothing like a stable coronary artery disease. Because why? The event rates still continue, and we have abolished that term. So also there is nothing like a stable heart failure. In spite of having brought down that risk, in spite of having controlled the symptoms, the bigger point out here is that heart failure is a progressive disease. And in spite of good guideline-directed medical therapy, the risk is going to escalate. And this is where you want to ensure that all guideline-directed medical therapies are on board. This patient is going to get recurrent hospitalization, and that's why those spikes. And after each hospitalization, patient is going to worsen. So that is what is the worsening phase of heart failure. And this is where you not only need to escalate what is the available therapy, but you also need to consider novel therapies. By novel therapies, I mean what is going to get launched. That is one such novel therapy which was specifically used in this patient population. If you haven't done that, you haven't prevented the inevitable, the advanced heart failure. That's when you're going to think about therapies like heart transplantation, MCS, mechanical circulatory support, or for that matter, you might just resign him to palliative therapy. So having taken you through all this, how do you define worsening heart failure? That despite guideline directed medical therapy, you have a progressive worsening of symptoms, and that after a prior diagnosis of heart failure, when the patient gets hospitalized or gets a worsening heart failure event, not only does the patient get hospitalized, but his need for receiving intravenous therapies, mainly intravenous diuretics, regardless of whether you are giving intravenous diuretics in an outpatient setting or an emergency room setting and then sending him home, or for that matter, in recent times, even if you try to up-titrate on his diuretic dosages, that's when you must recognize that this patient is going into what we are calling a worsening heart failure stage. And that is exactly the kind of a patient population that was the inclusion criteria for the Victoria trial that I'm going to talk about. So why is it this worsening heart failure so important? I did tell you the prognosis goes bad, but do we have trial data to show that? Yes, a large registry, a pinnacle registry, out of which they looked at patients who had developed such worsening heart failure. There were about 17% of the patient population, that 1,851 is out of 11,000 plus patients who had worsening heart failure. And if you look at their natural history, after the first worsening event, 1 in 5 patients, close to 20 to 25% of patients, will die within the next 2 years. So mortality gets worse. Not only does mortality get worse, like I mentioned to you, recurrent hospitalization shown in the bars out there. And you concentrate on the first bar there, 56% of the patients were hospitalized within the first 30 days of an hospitalization, of a worsening heart failure event, right? Then, if you look at that particular patient himself and look at the average number of, mean number of hospitalization per patient, within the next 2 years, the patient will get admitted again. So patient gets admitted twice. So that is the kind of recurrent hospitalization. Not only from this registry, one of the largest and the most impressive trials of heart failure is the ARNI trial. And look at the data from the ARNI trial and look at time from first hospitalization for heart failure. If you have no prior hospitalization for the heart failure, that's the baseline, versus within the first 6 months if you were hospitalized after the first event, then you look at the hazard ratio. 46% increase in the chance of getting hospitalization within the first 6 months compared to you were never hospitalized before. So that is what is the kind of a prognosis with worsening heart failure. And again, what data do we can't harp on Western data. We have to look at our own data. What else? Just like coronary artery disease, heart failure patients in our part of the world present a decade earlier. They are much younger than the Western population. That's a guesstimate. We have about 10 million prevalence of heart failure patients, and 2/3 of them would be diabetics, at least, going from the trials. I mean, at least pre-diabetics, 2/3 of them. And out here you can see prevalence of diabetes in the Trivandrum heart failure registry, it was 55%. And worsening heart failure is indeed a very important cause of death even in Indians. And again, why do we need novel therapies? Because all established therapies, including the new two kids, the blockbuster molecules as we call them, including ARNI, the Paradigm HF trial, ARNI, and the two SGLT2 inhibitor trials. If you see the red bars, the interventional arm, yet look at the event rates there, they're pretty high. So therefore, there is an urgent need to look at more and more therapies for heart failure. And that's how a pathway that was up until now unaddressed by the previous molecules that we were talking about, beyond neurohormonal blockade, that is RAS blockers, including ARNI, or beta blockers, or even neprilysin inhibition, or for that matter, we do not yet know, SGLT2 inhibitors. In none of these was this pathway addressed, a new pathway that we are talking about, which is impaired in heart failure patients thanks to endothelial dysfunction too. And that is the nitric oxide soluble guanylate cyclase, SGC as we call it, and the cyclic GMP. So when you address this pathway with vericiguat, you raise cyclic GMP, and with all its beneficial effects on heart, blood vessels, as well as kidneys. So it is a very important molecule, not yet tested for heart failure, that is gotten tested. And it is independent of the nitric oxide pathway also, because it's a direct stimulant of the of the SGC, increasing the cyclic GMP level. And in the long term, it is not in the decreasing as far as heart is concerned, inflammation, fibrosis, and hypertrophy, all which are responsible for worsening cardiac function and heart failure. Now let's look at all these blockbuster trials that we are today, and you're using these two molecules because of it. Now, all the three trials listed out here, Paradigm HF, DAPA HF, and Emperor, what do you find? That the second column there, second row there, recent heart failure decompensation was not a part of inclusion criteria. It was not required in spite of, because of its bad prognosis, right? And so also, if you look from heart failure hospitalization within the first 6 months, you see just 31% and 16% of the patients in these trials are having recent worsening of heart failure. Again, you look at their median NT-proBNP levels, and to put that into perspective, you look at the Victoria trial, 100% focus on recent hospitalization as well as if recent need for IV diuretics. So that is how it was. 84% had a recent hospitalization within the first 6 months. And again, an important aspect here, note the eGFR, the first row itself. You can go down to an eGFR of 15 ml per minute with vericiguat. And finally, obviously these are very sick patients, is what I'm trying to impress upon you. NYHA class 3 and 4, highest in this trial, 41%, and the event rates are very high. And therefore, to look at the benefits of the trial, this would be important. Event rates are close to 37 events per 100 patient years, and contrast that with the other trials. So symptomatic chronic heart failure patients after a worsening heart failure event were recruited for this particular trial. Of course, the setting did not matter, whether in hospital or out of hospital. They have to be recent in terms of hospitalization for heart failure. And 67% of them were within 3 months of a recent heart failure hospitalization, or 17% within the 3 to 6 months period. 84% of the patient population was like that. But if you were to initiate in hospital also, you have to, before starting vericiguat, ensure that the blood pressure is more than 100 millimeters, and patient is off all IV treatments. And unlike the Paradigm HF trial, there was no run-in period. Again, background therapy, absolutely excellent background therapy. If you look to the left of your slide, ARNI usage also 15% in this trial. Then you look at background beta blockers or ACE ARBs, 90%, 75%, and even MRA as high as 70%, right? Also ICD usage close to 30%. So good background therapy and in-hospital initiation is also possible. Here 11% of the patients were initiated on vericiguat in hospital. And what were the outcomes? These curves don't massively diverge. Why? Because you've got a very, very high risk population. However, the primary endpoint of first heart failure hospitalization or CV death was absolute reduction 4.2 events per 100 patient years. You might ask me, why am I talking about absolute risk reduction? Why am I not saying that a small 10% relative risk reduction? Because to do cross-comparison trials, as you will do in this, you see, you cannot just rely on relative risk reduction when the baseline risk is so high. That's why the absolute risk reduction, if you compare the absolute risk reduction and also the number needed to treat, the annual number needed to treat, very comparable to Paradigm HF, DAPA HF, and the Emperor reduced trials of SGLT2 inhibitor and ARNI trials. So that is what is the message I want to give you here. As also the secondary endpoints, all of them benefited. all of them which included heart failure hospitalization as by itself or in combination with mortality did benefit, except that it did not reach the statistical significance for cardiovascular death or all-cause mortality. So with that, on top of this effectiveness of this molecule, it is safe and very well tolerated. And what are we worried about? We are worried about, if you look at the AEs and SAEs, not any different for placebos compared to placebo, but actually numerically slightly lower. So also, most important thing is, after all, we know nitric oxide pathway and all that means blood pressure will go down. But you look at that, no significant difference. However, numerically slightly higher proportion did get their blood pressures going down, but statistically not significant and easy to up-titrate. And 90% of the patients in this trial have received the full dose, that is 10 milligram once daily. Talking about blood pressure analysis in further, a minimal reduction, you do get it like any other heart failure molecule. Yeah, I'll go on for another 5 minutes, yeah? Okay. So blood pressure reduction did occur initially, but afterwards it is back to what is there in the placebo arm. And in vulnerable patient subgroups, that is the very elderly patients, or for that matter, the ones with lower baseline blood pressure and those who are concurrently receiving ARNI, no difference between the things, no interaction absolutely. So you're good to use it in the elderly patients, or you're good to use it in patients with low initial blood pressure, that is less than 110 also. And we all know higher the NT-proBNP, and I told you the highest NT-proBNP was in the Victoria trial and therefore the highest risk. NT-proBNP in the range of 2,900 and highest as far as the risk is concerned and the event rates is concerned. And further analysis showed that you were good and you were effective with vericiguat when your NT-proBNP values were less than 8,000. And 86% of the trial population was that way. However, the benefit is not there when they are, which only means they are very sick patients. Probably nothing is going to help them at this stage. They are about to get into the advanced heart failure stage. And they are really amplified, and the best results were when the NT-proBNPs were in the 4,000 range. So finally, what is a typical patient scenario for vericiguat initiation? After a worsening event, whether when he has need for diuretics has gone up, after that, you may use it in hospital. Patient, the typical scenario, patient has been in hospitals, he's now been transitioned from IV diuretics to oral diuretics, and that's when you're good, he's ready for discharge, you're good to start vericiguat as early as that, or at the first patient follow-up, or for that matter, anybody who in an outpatient basis has received IV diuretics. So, however, like I mentioned to you, ensure that the blood pressure, starting blood pressure is more than 100 and that the volume status is optimized. Though I showed you the differential effects of NT-proBNP levels, it's not mandatory to do the NT-proBNPs. And a good point is that eGFR, you can come down till 15. And simple dosing, every 2 weeks up titrate, ensure that the blood pressure is not dropping to less than 90. Start off with a low dose of 2.5, 2 weeks later 5, 2 weeks later 10. Meaning within a 1 month period, you're good to go to the highest dose provided your blood pressure is fine. And of course, you cannot be on sildenafil, PDE5 inhibitors because that's an interaction. So finally, the vulnerable patient populations like ones at risk for hypotension, ones with renal impairment or ones with hyperkalemia. I can classically think about we are unable to start ARNIs or even start ACARB patients. And that's the kind of a patient. You have to start ARNI before. That's the message. But you're just not able to. That's the kind of a patient you will look for. So, optimized treatment for all heart failure patients with 4 foundational drugs or 4 pillars of heart failure therapy. That is the ARNI, or the other kind of RAS blockers is ARB, ARNI preferred over them, beta blockers, MRAs, and SGLT2 inhibitors. And in spite of that, if the patient is going to get his first worsening heart failure event, then definitely consider very Sigvard. Also consider very Sigvard whenever patient is unable to tolerate standard guideline-directed medical therapy, because hypotension, renal function issues, and potassium hyperkalemia is not such an issue with very Sigvard, and also for NT-proBNP levels less than 8,000. Small wonder that the other guidelines, the Western guidelines, had already given a green signal to very Sigvard following a worsening heart failure event. And so what have we gone, this is my last slide. So what have we gone through all this? Worsening heart failure, which means heart failure itself carries a bad prognosis compared to not having heart failure. So as diabetologists, your diabetes control, lifestyle control, and all the interesting talks that we are important in order that you don't get heart failure. Once you get heart failure, if you've got a worsening heart failure event, then the prognosis rapidly goes downhill, and you need to not only escalate therapies, but you need to add very Sigvard, which has got a very distinctive restorative mode of action. The impaired the tongue twister SGC, cyclic GMP pathway that is restored back, then very Sigvard reduces the risk of heart failure events, as I have shown you, and that it has got a very favorable safety profile. Thank you so much. Sorry for exceeding the time. Yeah.
Thank you, sir, for excellent talk. It is said that if I have an apple and you have an apple, and if we exchange it, at the end of exchange, we both will have one apple and each. But if you have an idea and I have an idea, if we exchange, at the end of exchange, we both will have two ideas. Absolutely. So now I invite questions from the audience. Thank you.
Either it was too much above the audience level, or it is pre-lunch session, is it, or hypoglycemic phase of state? No.
Anyone? Any question from the audiences? No question?
I can ask one question to Dr. Dani.
Yes.
Just to, because...
Yes, sir. Yes, sir.
Okay, Praful Bhai, so whatever the newer medicine you are trying, you really feel that it increases the patient survival or...
That's a very good question, because newer medicine, which means it's going to be taxing to your pocket, obviously, yes, right? But what happens is that this is a medicine. All newer medicines, when they get launched, they're expensive. This is one medicine, because the baseline characteristics were such that you had such a high-risk population, it did not improve survival. Because on those curves that I showed you right at in the first or second slide, is that he is otherwise going to go into a phase of advanced heart failure where no medicines are going to work, and you're going to think in terms of, which is again not meaning to improve survival, we're going to think in terms of cardiac transplants or keeping them on LVADs, or for that matter just resign to palliative therapy. But though it does not benefit in terms of, in this particular trial, in terms of mortality benefit, yes, but in terms of the hardest endpoint, the second hardest endpoint, heart failure hospitalization, recurrent heart failure hospitalization, that it is definitely has shown as being beneficial as a part of a composite outcome. That is, when you took heart failure hospitalization plus mortality together, that's how it was statistically powered to see. One other thing is, because you are up there on the high risk curve, what will happen, this to achieve statistical significance, the trial gets halted because you got the number of requisite events. And event rates are so high that this trial ran for only a 10.8 month period. And within that period, you already got benefit for which you went out to seek it, right? The primary endpoint. Therefore, it is an important molecule that needs, again, it acts by a separate mechanism of action. So I, for one, would use it. See what happens in, I'm sure Dr. Dani and Dr. Paresh Bhai will also agree with me, that in our practice, when you are dealing with heart failure, kidney function and blood pressure becomes such a major issue. Potassium becomes such a major issue. And what do we do that time? We, all of us, land up giving a molecule which is easily available, a combo preparation of hydrolysine dinitrate. And that too, we go in homeopathic doses and remain there. Correct? So this is one molecule which is going to, and what about that particular trial which suggests that you give this? It is in black African males, that data coming from 600 plus patients, that's about all. Here we are looking at 5,000 patients done with, and you got that statistical benefit. So that is the kind of a patient that I will definitely offer him, and we've got lots of such patients in our practice. Having said that, it is the company that's going to finally decide at what cost it's going to come here, because it's not going to go off patent so early. So we are always thinking beyond the companies, right? We think in terms of either breaking tablets or using something else with a similar mechanism of action. So somebody asked me a very valid question, is that can we use riociguat? Probably not, because it's got a very short half-life compared to this vericiguat, same class of medications, which has got such a long half-life going on to 27 hours or so. So I don't know if we can substitute, but that is one corollary to it. And it's possible patients of heart failure who are in such advanced stage, they would have developed pulmonary hypertension. So it really makes sense to use vericiguat. If your patient can afford it, definitely yes.
Sir. Sir, practicing physician, it has got definitely one advantage. At least last when the patients are dying, the relatives they say, let us see, we have asked the medicine from USA also and it is not working. So it gives them some consolation that whatever possible is done for these patients.
Has been done. And more, if there are more therapies, I did not speak on that omecamtiv mecarbil, the fourth trial that was listed there. So it has to be polypharmacy. Cancer ma polypharmacy de che, right? We are all right giving it. And this particular disease has got worse prognosis than even a breast cancer for that matter. And we have such a hype over breast cancer all over. People, cricketers will wear pink labels, etc., which is necessary, of course. But heart failure, we think that it's gone. No, today are very exciting times to treat heart failure. But again, please note what I was trying to tell you, that vericiguat comes in after you have those 4 pillars you have used. But there are a lot of patients who do not tolerate those 4 pillars where you will introduce vericiguat before.
Sir, small thing. Is it a bridge to cardiac transplant?
I would say so, by way of...
My whole point is, when you start using this drug, you must prepare for registry and everything. That patient needs, in near future, cardiac transplant.
Absolutely.
This is not the long-term goal. Long-term goal is a cardiac transplant.
It is quite possible to think on those lines. It is quite possible he has already slipped into that phase of advanced heart failure.
Right.
But even before that, we have a scope to use it in the hope that we are going to prevent cardiac transplant. They haven't done that kind of an analysis.
You get a lease period.
You might get a lease period.
Probably.
Probably you might get. They haven't analyzed the data to see whether it prevents heart transplants. No. But yes, that is one
It is not going to prevent, but you get a time for heart transplant.
Absolutely. We have, I'm sure that Dr. Dani will agree with me. Why don't you, you can take his opinion on that. We have enough chunk of such patients following up with us. And where we are helpless, you know, we cannot up-titrate our usual medications, and then we are looking for, you know, some other...
Absolutely. You are absolutely right. It buys you time.
It buys you time.
And finally, these patients, when they are in that inexorable heart failure, progressive heart failure phase, you will be able to offer nothing but cardiac transplantation if they are eligible for that. Some of the patients which were there in the Victoria trial probably would not even be eligible for heart transplantation.
Absolutely.
And these are the patients where you can help
Very
them
sick
by
patients,
adding.
it has been tried. So we do not know, and again, we must remember that it has been tried indication-wise after this, and therefore the guidelines are very clear. despite guideline-directed medical therapy, because also in the guidelines I highlighted that aspect. You have to, message here is that the 4 pillars first for everybody, and then very sick water. And after worsening heart failure.
If it doesn't increase the longevity, does it improve the quality of life? Does it bring from NYHA 4 to 3?
Yeah, that's again a very good question. When you are looking at I said the maximum people were in this kind of a class. The quality of life assessment, because they are up there, has not yet been done. And if it has been done, it was not a part of very significant trial. They weren't looking for it. But surely, as a post-hoc analysis, that data would also come in. And you expect definitely for them to improve, right? So most of them improve. The class of NYHA class improves with diuretics itself. And NYHA class se bhi zyada, what would be important is when you talk about heart failure, is the patient-entered quality of life improvement, which is the Kansas City cardiomyopathy questionnaire. Patient writes whether he is better or otherwise. And that in this trial, I do not think I found anything to that effect yet, but it's possible that is they are analyzing that data.
Over and above what we have been giving.
Absolutely. Over and above what we are giving.
Thank you, sir. Very nice talk. Since sir pointed out, talking from transplant perspective, when we look from this side, we think transplant is a very rosy picture. Transplant itself has a lot of challenges. So every transplant physician, every perspective before transplant is always considered. So every drug which can be given to avoid a transplant is always most welcome. So despite the advances in transplant immunology, despite our progression with LVADs, still every patient needs evaluation. For example, every patient who is considered for transplant, we always consider whether even one segment can be revascularized and we can avoid transplant. So transplant is considered as destination therapy, but it also has huge challenges. Absolutely. So every drug is welcome.
So all these also, with ARNI also, with the Pioneer HF trial, it was given in acute heart failure stage, right? In hospital initiation. There they have, as an exploratory outcome, looked at this thing about need for transplant. They have looked at it.
In fact, with SDL...
Also, they have prevented. So all these therapies of heart failure are all in the hope, because that's what I showed you, the natural history, which didn't play too well. But that is inevitable. Heart failure progression is inevitable. So we haven't been able to find drugs to halt that progression.
In fact, the video didn't play, but the most important thing is people who have one hospitalization, they never come back to normal. So that's the point sir highlighted. Once you've
gone there, it's a downhill course.
When you come up, it's like falling in a valley. You always come up on the lower peak. You never come back to the bigger peak. Same happens. Every fall, you just come up to the lower peak, never to the peak from where you fell down.
Samir Bhai was my senior, and we remember him as the only candidate who passed out of 38 or 40 students. Samir Bhai, a question for me. For chronic coronary syndrome, dual pathway therapy is advocated, aspirin plus rivaroxaban. Will the dose of rivaroxaban remain same if there is associated peripheral artery disease?
Yes.
No problem.
The rivaroxaban dose, vascular dose it is called. So whether it is coronary artery disease or peripheral vascular disease, the rivaroxaban disease which you add onto the aspirin remains the same, 2.5 milligram twice a day. The rivaroxaban dose only changes when you are trying to prevent the stroke in atrial fibrillation. So SPAF dose is different. But for coronary purposes and peripheral vascular disease, the dose is vascular dose, 2.5 milligram twice a day.
I may add here about rivaroxaban. That is the only, I have it built in. So that is the only NOAC where, this ingenious dosing that they have devised as to giving it twice a day, 1/4 the SPAF dose, right? 20 milligram otherwise is the dose for this. And the other NOACs have also been tested. They had to prematurely halt the trial with apixaban, okay, with this kind of a thing when they tried to look at it. So this is somehow this molecule is the only one amongst all DOACs which has got an indication. Anticoagulant, good old days even warfarin has been tried. Unfortunately the bleeding was far too high and ICH was high. So also in the apixaban trial the ICH was high. So this is the only molecule that in a DOAC we can use it. And now that it is available, people should be using it. My only one message is, which Dr. Dani also pointed out, is that all those guidelines that he showed, the underlying part of it is that these are patients where you take bleeding risk into account. Unlike when you give for stroke prevention, though you showed the net clinical benefit and all, even guidelines say first rule out high bleeding risk in your patient. And the best way to find out is when we have given them DAP. That's how at least we do it. We have given them DAP, and now they have 1 year of DAP they have received. They have received their stents. They've had a previous MI and they come into our outpatients. And now we're thinking, Baba, his ischemic risk is high. Ischemic risk is high by way of all those things. I will first rule out bleeding risk in that patient. And bleeding, otherwise Hasbled score has got no meaning when you give it for SPAF, because the ischemic risk also goes up. But here, only with low bleeding risk patients should you use, for that matter, even when we use DAP for longer period, we mentally do that. It's a different matter that we have a combo preparation available and everybody is on clopidogrel aspirin combo. And we have largest experience in the world, I think, about giving a combo of DAP. And this one is causing less bleeding than the DAP combo. But you have to check out bleeding risk.
Absolutely.
Before initiating Variciguat, should we not strive for optimum dose of those 4 pillars?
Absolutely. I mentioned that. Optimize 4 pillars first, but your inability to optimize for whatever reasons should mean that you should bring in Variciguat. Especially if he has had a worsening heart failure event. Because we know his trajectory is going to be downhill.
Because of hemodynamics and because of renal functions, you are not always able to optimize all the 4 pillars.
I thank you, all the speakers, for such a wonderful, enlightening and entertaining presentation and discussion. So we will take few time for the felicitation program. So before the start of next session, so I would like to invite Dr. Kaku Shah to felicitate our first speaker, Dr. Sameer Dani. Thank you, Dr. Kakusha. Now, next, I would like to invite Dr. Nimit Yagnik to felicitate Dr. Paresh Pai. Paresh, thank you, Dr. Yagnik. Now, I would like to invite Dr. Kakusha to felicitate Dr. Praful. Thank you, Dr. Praful. Thank you, Dr. Kakusha. Now we will start our next session. So I would like to invite our chairpersons, Dr. Shabbir, Dr. Vikas Doshi, and Dr. Ketan Desai, to preside over the next session, please. हाँ, chairperson. अभी नहीं होगा, उनका करना है. अच्छा, sorry. Sorry for the interruption. We need to felicitate our chairpersons also. So for that, I would like to invite Dr. Kamaldeep to felicitate our first chairperson, Dr. Kakusha. Thank you, Dr. Kakusha. Thank you, Dr. Kamaldeep. Again, I would like to invite Dr. Kamaldeep to felicitate our chairperson, Dr. Nimit Yagnik. Thank you, Dr. Yagnik. Thank you, Dr. Kamal. Okay, now we will start our next session. I invite Dr. Dr. Vaswani. Please come for the next session. So now our next speaker is Dr. P. Manokar from Chennai. Hello, Dr. Manokar.
Good afternoon, everybody. It's always a challenge to talk in a pre-prandial session. But for me, any invitation to Baroda is something like I can never refuse. So big thanks to Dr. Kamaldeep for this opportunity. But more importantly, you feel a lot of pride and happiness when your teachers are in the audience and your teacher is the previous speaker. So it's a real happy moment for me. So all the excitement for me starts even before the talk begins. So cardiology is always full of statements. People make grand statements and then we always eat them ourselves. So this is something by our renowned, whom we consider as the writer of the Bible of cardiology, Dr. Brownwald, making a statement in 1962 that there is nothing specifically we can do for patients with HCM. So this is the time when Yuri Gagarin was the first person to go to space, to today where we have these images from the NASA's new Webb telescope. So where do we start? So in terms of names, we had a lot of names, a lot of things, many things that were used to describe it. But to put it in simple perspective, it is not a very rare disease. So if you look at the population prevalence and a predominant male prevalence, it makes it a very important disease that we need to understand. In order to scare people, we always use this slide because every time you see a footballer collapse on the field and he dies, the news channels, everybody gets very excited. Everybody is like thinking, okay, HCM means sudden cardiac death. And obviously, we always highlight this fact that when you look at causes of sudden cardiac death in the young adults, HCM is on top of the list. So HCM becomes a very favorite media topic also, especially when footballers and big sportsmen die. But things are not as bad as we think, because this is a very special disease where if you are older, you survive longer. So normally in diabetes, we always say the opposite. Here, if you are older, and if you look at it, many patients actually don't require much treatment. If they survive longer, they always live. So aging is actually very good in patients with HCM, because outcome of patients after 60 years, if you start evaluating, their outcomes are far better. So very few conditions in medicine where being the oldest leads to cheers. Anyhow, going to the basics of it. So this is how the disease has been classified over the years. There's nothing new in it. But since I thought I have to go through the whole set of things, I just thought I'll put these things. The important thing is this apical hypertrophic cardiomyopathy initially reported in Japan. Nowadays, we see a lot of cases even in our setup, and that is something which is very often missed in clinical practice simply because echo tends to miss it because of the nature of the disease. So that's something we want to highlight. We all know echocardiogram is the basis of doing the diagnosis of this thing. So with respect to diagnosis, symptom evaluation, and for prognostication, all these things echo is the basis of it. But if you look at the guidelines, obviously transthoracic echo is recommended. Exercise echocardiography is very, very important, especially when you are not sure whether the gradients are significant, whether the obstruction is dynamic. If you want to show dynamism, exercise echocardiography becomes a very important tool. Contrast echocardiography we do not do in our country because of the cost of contrast, but in certain cases definitely it helps us in defining the apical HCM and also during septal ablation. Transesophageal echo is obviously very commonly used when surgical myomectomy is done. So echo is important because if you look at echo, this is how the 4 different types present. So you have a sigmoid septum and a reversed curvature, neutral septum and an apical variant. So these are the various things. This is an example of a contrast echocardiogram. This is an example of how the contrast echocardiogram helps you identify the apical nature of the HCM. So in apical HCM identification, contrast echocardiography plays a bigger role in other forms of HCM. It's also very useful, for example, if you are doing a TE in assessing the role of septal anterior motion in predicting the extent of MR and trying to manage things. Similarly, with the 3-dimensional echo, the wall impact on the mitral wall, all those things can be very well documented. This is during surgery, so how intrathoracic, transthoracic echo may not pick up, but TE will help guide the surgeon during the echocardiogram. So this is the important thing. But for students, it's always important to distinguish between an athlete's heart and a HCM. So this is something which very often is important because many times we miss this. So when we run our sports medicine clinic, so in the sports medicine, a lot of the athletes that are come for evaluation, a lot of them have hypertrophy. So it is a very important challenge for us to look at these things. So in our sports medicine facility, evaluation for HCM becomes a mandatory thing that we need to look for. Obviously, the gold standard in HCM is MRI today. The reason is MRI far outscores echo in terms of benefits. So it helps us assess the cardiac function, it assesses the MR, it also helps us classify the disease, and also most importantly, it helps us look at late gadolinium enhancement, which helps us predict the sudden cardiac death. So when you look at comparison, definitely MRI would score over, MRI would be far, far superior tool because of there is no operator dependence, there is an excellent contrast, and most importantly look for fibrosis. Most importantly look for other causes, like for example amyloid. Amyloid may have many features similar to HCM. So it helps us in all other aspects in comparing as compared to this thing, as compared to echo. So this is a case where the echo may look very innocent, and the symptoms sometimes may make people say, okay, this could be a patient who had probable hypertrophic cardiomyopathy. But when you do an echo MRI, the MRI is far different. It is suggestive of LV non-compaction, and actually the LV function in the MRI comes lower. And we miss these kind of things when we do an echo alone. So these kind of pictures are far more informative than the images that we get from echo. So the most important thing I showed in when we mentioned about the transesophageal echo. So when we have classify HCM based on MRI, there are far different variants which can be looked for, and a lot of phenotypes of HCM can be picked up by doing an MRI. This is a very nice article which appeared almost 12 years back, but it tends to give you all the information regarding HCM evaluation. So since we run a very robust heart failure as well as an MRI program where we tend to get referrals for imaging, we tend to get a lot of people, routine annual checkup, echo ordered, somebody picked up ASH, was referred. And you can see how thick the septum is. Look at the thickness of the septum. But interestingly, there is not significant LVOT obstruction occurring despite the fact that the septum is pretty thick. Similarly, so a lot of examples, I'll skip all these things because for want of time. But these are examples of HCM where you can see that almost the entire territory is getting obliterated. Look at how intense the obstruction is. But even better example is this case where apical cardiomyopathy, where you can see the obstruction is total here. There's no obstruction here. And the entire apex looks to be obliterated. In fact, this, in this patient actually, it was suspected as LV non-compaction by echo, but eventually it turned out to be thing. This is an example of a symmetrical involvement. So this is an example where the patient had symmetrical enlargement. So if you see how thick the IVS is, look at the thickness of the posterior wall. So these kind of examples give us a far better, this is a doctor who was evaluated, and the important is, see, this is a very important thing. This guy had vague uneasiness 3 months back and occasional palpitation. These are the guys who tend to have worse outcomes simply because you can see they are developing apical ballooning. You can look at that apical ballooning. These are the patients who have sudden cardiac death. So these patients need aggressive monitoring and this thing. I think this is the same patient. So look at the LV, how aggressive is the obstruction at the apex, and you can see this apical ballooning element, which makes it very important. Similarly, this is just to show how thick the septum can be. But most important is late gadolinium enhancement. If late gadolinium enhancement is more than 15% of the myocardium, these people have a very high chance of having events because they are more likely to have VT, more likely to have arrhythmia. That helps us make the diagnosis whether these patients need an ICD or not. Obviously, cardiac cath is not important. When I was a student in DM, obviously it was very important. So we all loved asking the students all these questions, but not of very practical importance, the Brokenberg-Braunwald sign and all those things. So as a professor, it is a good thing, but not very practical. In real life, may not help us. Coming to the treatment, so what has changed? Probably this is the best review on what are the drugs that have come up, published just last month. And it kind of reviews everything that has been published, but a lot of new things have happened, but most of the things remain the same. So the important thing which yesterday I was listening to somebody talk on bariatric surgery. So this is very important even in HCM, that what happens is from day one, people tell them not to do anything. So inevitably they go into this vicious cycle. You know, inactivity, obesity, and a whole cycle. So this is something which has been highlighted in one of the editorials where they say that, you know, from childhood, these children are said, don't walk, don't do anything. So at the end of 20 years, 25 years, they have other issues which are far different from the challenges of HCM. So that is something which needs to be addressed. This is a very busy slide just trying to tell you what are the problems in HCM and what are the drugs available. So LVOT obstruction, ventricular arrhythmia, heart failure, diastolic dysfunction, and AF. I'll skip all this thing because most of the things are all known. This is just to highlight the drugs that are available. The only point I wanted to highlight is the mavacamten, which has been recently approved by FDA. Rest of the drugs, most of them act through the pathways at the membrane level. Mavacamten is the only drug which acts on the myofibril, and that's how it acts. So these are the drugs which are approved from propranolol to verapamil, diltiazem, isopramide, and ranolazine. But most importantly, this is the proposed treatment plan for patients with NYHA class 2 to class 4 symptoms. They don't have obstruction, no symptoms, nothing. Otherwise, beta blockers, isopyramide, and refractory ranolazine. But patients have heart failure, then try to give ACE inhibitors, ARBs, and refer for heart failure in case patients have. So this is another thing saying how to progress with asymptomatic patients versus symptomatic patients and symptomatic non-obstructive and patients who are end stage, this thing. But what is new? So new is switching to a myosin inhibitor. So this is something which has come up only in the last 3 to 4 years. Myosin inhibitors have come up. So this is the new proposed algorithm, that this is something, what is there in the top is already known to us, but this is the new proposal. And myomectomy, starting this myosin inhibitor is considered as one of the options beginning. So what are myosin inhibitors? There are 2 drugs available. I will not go into the pharmacokinetics, but these are the 5 trials, and most of them, except that MAVA-LTE trial, which is yet to release the results in September 2023, all the trials have yielded positive result. The similar drug, aficamten, Redwood trial has come, Sequoia and Redwood Ole is pending, but mostly this second drug will replace the first simply because it has better pharmacokinetics and it has less of drug-drug interaction. So although mavacamten is the first drug in this group, my personal feeling is this drug, once it hits the market, will replace because of its better tolerability and other issues. I'll skip. So this is that landmark trial which was published in Lancet 2020, which got it FDA approval. And basically, like sir mentioned, this is also not a positive trial about mortality. It is about reduction of symptoms. So that is a very important thing that we need to understand when we are dealing with such patients. Symptom reduction, hospital admission avoidance are as important as mortality benefits. Coming to sudden cardiac death, this is something we know for a long period, traditional risk factors which are known to the thickness, presence of NSVT, all those things can be used. This is the guidelines on the basis of which we have to decide which are the patients who need ICD to prevent an event. But I found more than all this thing is a very simple app which is called as a HCM SCD risk score. It is available on Play Store as well as the App Store, where you enter this thing. This is just one example of 2 minutes. So this is just one example that I entered, which you can easily do. Put in the age, wall thickness, left atrial size, gradient, family histories, non-sustained VT, and you get the number. So risk of sudden cardiac, it becomes a very practical tool in managing these patients. Coming to the last part of it, arrhythmia management is complex, but important thing is atrial fibrillation is a very big problem. Patients with SCM don't tolerate atrial fibrillation, and patients with VT also need treatment. I'll skip this. This is how a patient developed RBBB, later on developed complete heart block as part of treatment. So this is how an AF ablation is done in patients with this thing. It's too complicated, we'll skip it. So looking at surgery, these are the surgical options. The new techniques that have come, Morrow's procedure is something well known, but the newer techniques are what is called as the Ferrazzi's modification and the Swistel's modification, where they have tried to make the results better. But the gold standard remains surgery. So definitely patients with HCM who have significant symptoms, the gold standard of treatment remains surgery. I'll skip this thing. So this is the present. Earlier the Morrow's was trans-aortic. Now the concept is if patient has mid-cavitary, go trans-aortic as well as go trans-apical. So this is a combination of a trans-aortic and trans-apical which is found to show better results. Coming to another topic which Dr. Praful sir would be an expert to talk on, but I'll just go through it quickly. So that septal ablation versus surgical this thing. These are the trials comparing the safety and efficacy of ablation and myomectomy. But the important thing is the meta-analysis shows not much difference. So that is the take-home message, that the meta-analysis shows not much difference between both modalities in terms of outcomes. This remains the indications for alcohol septal ablation in patients. But the decision making is tough. So the important thing we can always see is patient has pre-existing RBBB, it favors ablation. Pre-existing LBBB favors surgery. And other things like older patient for ablation and younger patient for this thing. But it's always a coin toss between both the conditions. So coming to the last part of my talk, the excitement in HCM is not related to drugs. The excitement in HCM in the future is all about genomic editing. Gene editing for HCM is going on in a big way. Eventually, this will change the way things are perceived in HCM. So this is a very landmark state-of-the-art paper from JAG where they looked at therapeutic genomic editing in cardiovascular disease and specifically for cardiomyopathies. And if you look at this thing, it's specifically directed towards cardiomyopathy. And last week there was a paper about CRISP gene editing for LDL. So LDL modification in patients. So same thing, same CRISP system and this zinc finger nucleases, talents, and all these things have been mentioned about how these patients can be edited. Am I very excited? Yes, simply because till now it was believed all this therapy was more effective for somatic because the myocardium doesn't divide. It was not such an exciting thing. But now with the newer things, definitely there are evidence that these things can be there. But obviously there are big ethical concerns. Gene means controversies and this thing. This is one Chinese paper where they have efficiently corrected a mouse model of HCM by modifying the gene. So I'll skip this. So testing, even more more confusing and difficult decision making. The challenges, in fact, Dr. Anand Ahuja was mentioning to me how many mutations are there. So I found out it's even more than what we discussed yesterday night. So who should be screened? Positive means parents, siblings, and children definitely must be screened. Thank you. Sorry for that.
Thank you, Dr. Manus, for such a wonderful presentation. I would like to invite our next speaker, Dr. Anand Ahuja from Vadodara.
Thank you, sir.
I hope the audio is much better. Thank you. So a very warm welcome and thank you so much Kamaldeep sir and Akash sir for, when you have such stalwarts talking before and to allow a small, night watchman to come and bat and talk when you have big stalwarts talking. So it's a big honor for me. So I talk about the heart failure guidelines. We talked about so many things which can happen to heart failure. Even if you can reduce one heart failure hospitalization, it would make a big impact in the patient's overall outcomes. There is a big difference between patients who are given guideline-based medical therapy and patients who are not given guideline-based medical therapy, because when you stick to guidelines, you offer the best possible armamentum, you use the best possible armamentum to offer the best survival advantages. And therefore, these guidelines should be adhered to whenever a diagnosis of heart failure is made, irrespective of symptoms. So I'm going to go through the entire stages, stage A, B, C, and D of heart failure, and how do you investigate, what is your initial evaluation and approach. And the talk is mainly based on the ESC 2021 heart failure guidelines and the ACC AHA 2022 latest heart failure guidelines. So we all know that there are 4 stages. I'm not talking of the NYHA classification, but stage A, which is at risk of heart failure, where patients have a risk. Can you see the slides properly? I think I can't. The focus, is it clear? It's okay. So stage A is people who are at risk. They do not have any overt clinical signs. They are just having hypertension or cardiovascular disease or diabetes or obesity. These people are at risk of heart failure. Compared to that, stage B, that is people who have some structural changes, either ventricular dilatation, ventricular hypertrophy, elevated filling pressures, or elevated natriuretic peptides, but still no signs, symptoms of heart failure. Now, the third is stage C, that is a symptomatic heart failure, where patients now develop signs and symptoms. And then if you continue, this continues unabated, then the patients move on to advanced heart failure, where despite medical treatment, patients continue to have significant hospitalization, significant signs, symptoms, and marked deterioration of their quality of life. This stage C, if the trajectory, they could either improve with treatment, they would either resolve their symptoms or they would worsen. So these are the various possibilities which can happen. So how do you address such a patient? So first of all, clinical history, clinical examination, physical examination with ECG. 2 very important investigations, echocardiography and looking at cardiac biomarkers, the NT-proBNP or the BNP levels. These 2 things are very, very important to establish a diagnosis of heart failure. So first of all, confirm heart failure, assess ejection fraction, try to look for precipitating factors. There's a formula A2I2. Almost 70-80% of worsening of any previously stable patient occurs because of two A's, anemia, arrhythmia, and two I's, that is ischemia and infection. So if you can address, if you can look for these triggers, you might be able to reduce future recurrences. So initiate treatment, up titrate to maximally tolerated doses, and then keep on surveillance, keep on surveilling regularly. So that is the main course of action. With this, you would either have patients with HFrEF, that is EF less than 40, HFpEF, that is EF more than 50, and heart failure with mid-range ejection fraction between 40 and 50, who might remain same, worsen, or they might improve with treatment. We need to understand that, because of improved quality of life, improved risk factor, worsening risk factors and better treatment of heart diseases, increased prevalence of obesity, hypertension, the overall prevalence of heart failure worldwide is going to increase. And we are going to see a lot more disease burden in the future than even what we are seeing today. There is significant ethnic variation, but despite that, the guidelines remain almost the same for all patients. We need to understand risk factors like hypertension, diabetes, obesity, and cardiovascular disease. These are the risk factors which can lead to either ischemic or non-ischemic types of cardiomyopathy. So there are two types of heart failures. One is ischemic heart failure, and the non-ischemic causes could be because of either say chemotherapy, cardiotoxic drugs, alcohol, myocarditis, peripartum, some hormones like thyroid disturbances, familial forms of cardiomyopathy, some special forms like amyloidosis, sarcoidosis, and hemochromatosis, which have some specific treatments available. We need to understand and identify these possible conditions. An initial clinical examination will involve evaluation for signs and symptoms of congestion. Try to look for hemodynamic stability, whether it is advanced. If you're looking at family history, try to involve 3 generations. Not just siblings or parents, but try to involve 3 generations to search for a family history. Try to look for specific treatable conditions such as arrhythmogenic cardiomyopathy or thyrotoxic cardiomyopathy or alcohol-induced cardiomyopathy, because treating that would be very, very rewarding. Try to identify triggers, which I said A2, I2, which are the most common in most of the patients. And your initial investigations will involve a complete blood count, liver functions, renal functions, electrolytes, glucose, lipids, as well as thyroid functions. And you should do ECG and any extra tests like biomarkers and echocardiography, of course. One slide special mention about biomarkers like BNP and pro-BNP. Remember, BNP is stable only for 2 to 4 hours. So if you have in-house laboratory, you might go for BNP. But NT-proBNP is stable for 24 hours. So if you're sending the sample to somewhere outside lab, then it is better to do NT-proBNP because the molecule remains stable. You will not get a falsely low reading. In patients with dyspnea, it helps you differentiate cardiac and non-cardiac conditions. In patients who are at risk of heart failure, you can look for development of LV dysfunction or new onset heart failure. In patients who are being hospitalized for heart failure, on admission, it can help you to establish prognosis, and on discharge, you can do again to look for in what direction is the patient moving. Is he worsening, is he stable, or is he improving? And in conditions, in chronic heart failure, you can do NT-proBNP to assess risk stratification. A small word of caution that NT-proBNP or BNP can be high in advanced age, burns, sepsis, severe renal failure or obstructive sleep apnea, respiratory infections, pulmonary thromboembolism, etc. So marginal elevations should be taken with a pinch of salt. So what are the other investigations? Chest X-ray, yes. It helps you identify cardiomegaly, pulmonary vasculature, and to find out any other respiratory or cardiac conditions which are contributory. Echocardiography can tell you the cardiac structure and function. Cardiac CT scan, MRI or PET scan can be done in specific conditions, especially where you are considering non-ischemic conditions or when you are planning for any device therapy or any other invasive procedures. It is not routinely done. And looking for ischemia, where you have a high possibility of underlying coronary artery disease, then functional testing should be done to determine whether a patient is eligible for coronary revascularization or not, because that would offer a treatable condition. But invasive hemodynamic studies should not be done routinely in all patients. Routine, even echo evaluation is not recommended for all patients who respond properly and who remain stable on guideline-directed medical therapy. So, all these patients, invasive hemodynamics is only for people who continue to worsen or who do not respond appropriately as expected to GDMT, but routinely it should not be done. Endomyocardial biopsy is only restricted for specific conditions like hemochromatosis, amyloidosis, etc., where there is a specific treatment available. And it is not done routinely because it has its own risks and complications. Regarding the use of wearable, now you have fancy devices available, wearable pulmonary artery pressure monitors. They should not be routinely done. In fact, even in patients who have a repeated history of hospitalization, who have good survival, even in them, the recommendation is just class 2B, because you have good clinical markers which can determine whether a patient should receive or what dose of diuretics a person should receive. On the other hand, functional testing, cardiopulmonary exercise testing is recommended to determine, differentiate between cardiac and non-cardiac causes of dyspnea. It helps you to determine which patients are eligible for what kind of treatment and whether a person is suitable for cardiac transplant or mechanical circulatory support devices. So to assess that, cardiopulmonary exercise testing can be done. Of course, treatment of other comorbidities is very important. So aggressive treatment of hypertension. If a patient is diabetic, prefer to use SGLT2 inhibitors. If the patient has coronary artery disease, coronary revascularization would be very useful. For people who are on cardiotoxic drugs, especially the cancer chemotherapy, a multidisciplinary approach to determine whether that drug is very, very essential or it can be substituted by a non-cardiotoxic drug. If there is a strong family history of cardiomyopathy, then genetic counseling and genetic testing can be recommended. People who are at risk, frequent surveillance can be done. So this is all for stage, people who are at risk, the risk factors to be managed. If you're talking of stage B, that is people who have some structural abnormalities. If there is LV dysfunction, offer ACE inhibitors. If there is recent MI, offer ACE inhibitors or ARBs or ICD if the duration is more than 40 days and ejection fraction is less than 35%. Similarly, beta blockers or MRAs can be offered and ICD can be also offered as a class 1 indication. Regarding the treatment of stage C and stage D, now this is where most of the focus of every CME, every talk happens, that once you establish a diagnosis of heart failure with reduced ejection fraction, the 4 pillars of treatment, RAS blockers, you should prefer with ARNI. That should be the first line of treatment as recommended in all latest guidelines now. If ARNI is not available or not tolerated or not suited, then you might consider ACE inhibitors or ARBs. All patients should receive beta blockers, all patients should receive MRAs, and all patients should receive SGLT2 inhibitors because these drugs offer survival benefit irrespective of symptoms. So even in asymptomatic heart failure, patients given these drugs would do better than patients who are not given these drugs. How do you start them? You start them with the lowest possible dose and you gradually uptitrate over 15 days period to the maximally tolerated dose. If the patients improve with treatment, you continue this guideline-directed medical therapy, ensure adherence, and keep on monitoring the patient's hemodynamics, blood pressure, kidney function, and potassium. However, if the patient still remains symptomatic, then there are certain other options, such as for African Americans. Even in Indians, we use isosorbate dinitrate and hydralazine combination. It works much better. If resting heart rate continues to stay above 70 and the blood pressure does not allow escalation of the dose of beta blockers, you can consider ivabradine. ICDs can be considered in suitable patients and CRT can be offered for patients with LBBB or a QRS duration more than 150 milliseconds. So these are other therapies which can be offered. And at the same time, we should also aggressively control and treat comorbidities. With this treatment, most of the patients would achieve remission, would be able to stay in stable condition, and you need to continue this therapy and continue to monitor. And if not, then advanced treatments. Now, the Western population, the Europe and the Americans also understand what we used to consider, whether all these treatments are value for money or not, like Sir asked in the previous talk. Whatever money that is spent is worth it or not, whether it is paisa vasool, whether it is value for money. So all, all class 1 treatments, be it RAS blockers, beta blockers, MRAs, or SGLT2 inhibitors, they're all considered good value for money because the money spent translates into better outcome benefits and therefore it is good value for money. Even isosorbate dinitrate hydralazine combination, it is cheap and it is good value for money. Regarding device therapy, both ICD and CRT when appropriately used is good value for money. So it is supposed to have a good high economic value. I already mentioned about the other drugs, I'll not go into more details of them. For ICDs, a small mention about CRT. CRT desynchronization between the two ventricles is an additional problem which accelerates or aggravates signs symptoms of heart failure. So apart from LV dysfunction, if there is also evidence of dyssynchrony in the form of LBBB or a prolonged QRS duration, especially more than 150, then offering a CRT makes substantial improvement in the patient's quality of life. If the QRS is between 120 and 150, it is a class 2A indication, and more than 150 is class 1 indication. If there is no LBBB, still if the QRS is more than 150, offer a CRT that is a class 2A indication, and if it is between 120 and 150, it is a class 2B indication. So all these patients try to look for QRS duration. This is very important. If the patients also have atrial fibrillation, try to treat that also. We'll come to that special slide. Regarding other devices, surgical revascularization for patients who have a suitable coronary anatomy is important. If patients have significant secondary or functional MR, treatment of this MR will also help improve patient outcomes. So optimize that. If the patients have severe MR, the ejection fraction is low, the LV systolic and end systolic volume is low, or the PA pressure is low, then you can offer a mitra clip or a transcatheter edge-to-edge mitral valve repair. Otherwise, mitral valve replacement should be a preferred choice of treatment. For secondary functional MR, if the patient is as such undergoing CABG, surgical revascularization, then you should offer a mitral valve replacement. That is much better. Try to preserve the chordae. So chordal sparing mitral valve replacement offers much better result. If you're not doing, that gives better results than mitral valve annuloplasty. However, if the ejection fraction is poor and you're not offering, then a mitra clip or just mitral valve repair percutaneous can be offered. But try to treat mitral valve secondary or functional MR quite aggressively. What is the recommendation for people who have just mildly reduced ejection fraction, that is between 40 and 50? Diuretics, class 1 indication depending on the patient's volume overload. SGLT2 inhibitors have received a class 2A indication. I just finish in a moment. And the same other guidelines receive class 2B indication. And this is the same for heart failure with preserved ejection fraction also. A special mention, I need help. These are special situations if the patients continue to receive, require IV inotropic support. If their functional status remains class 3 or class 4 with evidence of hypoperfusion, end organ dysfunction, ejection fraction persistently remains low, and they require repeated hospitalizations, this is the time for the patients to be referred to a specialist for advanced treatment. Just a brief mention that we frequently over-dehydrate a patient and we give excessive salt restriction to this patient, which is not good because it will paradoxically worsen the RAS overactivity. The RAS is concerned with our salt and water homeostasis, which will get overactive if you dehydrate a patient. So salt restriction or fluid restriction should only be advised if there is clinical evidence of volume overload, not in euvolemic patients. Make sure they're not dehydrated. Inotropic supports, they do not improve the patient's outcome, but they certainly improve the patient hemodynamics. So use it sparingly only when required or as bridge to definitive therapy, not in routine cases. Similarly, LV assist devices only for those patients who continue to have hypoperfusion, end organ dysfunction, intolerant to guideline-based medical therapy or required repeated hospitalizations. They should be offered to special selected patients only. Because they are not value for money, they are not paisa vasool, they are intermediate economic value. So identify which are the best candidates and do not offer this to all people. I'll not talk a lot about cardiac transplant also, but even that is not value for money, not paisa vasool. It is also offering only a intermediate economic value. So only for selected patients who have good otherwise overall survival, but they have only cardiac related problems, you can offer a cardiac transplantation. Address all these patients, the same issues to be addressed for acute decompensated heart failure patients also. Try to identify underlying precipitating factors A2, I2 and other conditions and try to treat them also very aggressively so that when you offer guideline-based medical therapy even during hospitalization, now Arnie has shown that even during hospitalization you can safely give and it offers survival advantage. So try to use this. Diuretics or decongestive therapy should be determined according to the patient's volume status, not as a blanket loop diuretics for all. If patients respond, it's great. Otherwise, you can escalate the dose, give IV infusion. You can use sequential nephron blockade by adding a thiazide or a MRA. But you should down titrate as soon as the patient becomes euvolemic. Monitor the patient's weight and titrate the doses accordingly. Do not over dehydrate a patient. So with that, I would just conclude. That was all I had to talk about. the same as the repetition. Thank you so much.
Very nice presentation, doctor. Thank you. So I would like to invite our next speaker, Dr. Kilol Kaneria from Vadodara.
Good afternoon, everyone. I'm at the last hurdle before lunch. I will not take that much time. And thank you to the scientific committee for providing me this opportunity. My topic is a little bit different. So today I'm going to discuss regarding the quality of life, an important aspect in management of heart failure. See, what I feel, not only in the heart failure, but any chronic disease, a quality of life matters, because it is also matter for a healthy individual. But we never prescribe any measurement in our prescription which is likely to improve the quality of life of an individual, particularly in chronic diseases. Yes, we are prescribing the medications which likely improve the patient's symptoms and reduce the mortality and ultimately improving their quality of life. So what the mean by quality of life according to the World Health Organizations? As per the current definition, it is an individual's perceptions of their position in the life in context of a culture and value system in which they live, and in relation to their goals, expectations, standard, and the concern. So when we look at the definitions of quality of life, it does not include the health. But how one can derive the measurement regarding the quality of life of particular chronic disease patients? So when we look at what are the indicator of quality of life, there are so many indicators, and one of the indicator is physical as well as mental health. So you can see, in addition to the wealth, the most important parameters to assess the quality of life is the presence of mental and physical health. So if you have a good mental and physical health, along with the wealth, you have a better quality of life. Wealth will not do anything except in absence of good health. So why the patient with the heart failure will have a poor quality of life? Because particularly when we are looking at the individual who have a heart failure and reduced infections, this individual have a low cardiac output. Because of low cardiac output, they have a symptoms of low cardiac output like fatigue. They have a elevated left ventricular and diastolic pressures, which ultimately convert into the increased pulmonary congestions. They have symptoms of orthopnea, PND, breathing difficulty. They may have a pedal edema, and because of that, they have a limitation in routine daily activity. And because of that, they ultimately become depressive, or they develop a depression and anxiety. So the quality of life is significantly reduced in the patient who have a heart failure with reduced ejection fraction, particularly if they are symptomatic. So why one have to focus on improving the quality of life in the heart failure patient? So see, nowadays we have a measurement for blood sugar. We can send the sample to the laboratory, and then they will give us a very good value of regarding the random blood sugar or fasting or postprandial. But what about the quality of life? See, till now we don't have any laboratory tests to assess the quality of life of a particular individual. But this is one of the most questionnaire which used in the heart failure patient, and this is a Kansas City Cardiomyopathy questionnaire. So what this questionnaire contains, it has a 6 domain. There are first domain is symptoms assessment, second one is physical function assessment, third is a quality of life assessment, fourth is a social limitation, and the 2 accessories domain are self-efficacy and symptom stability assessment. So every patient with the heart failure has to give under 23 questions which belong to these 6 domains, and they have to collect the answer from the patients regarding these 23 questions. So on the basis of the answer of that question, the score was given from 0 to 100. If the individual have a score of 100, they have a better quality of life. Even it is not possible for the normal individual also, but higher the score, good quality of life. Lower the score means poor quality of life. In the different randomized control trial in the heart failure, they use the different word like clinical summary score or overall summary score. See, overall summary score means they will calculate all the 6 domains, and clinical summary score means they will look at just the patient's symptoms and physical function level. So these words will come repeatedly in my lecture. So next question is, are the patients with the heart failure have a gradual downgrade their quality of life or not? This is an article from the American Heart Association. The change of health-related quality of life over time and its association with the patient's outcome in the patient with the heart failure. You can see here, this was a study where they've just follow up the patients with the heart failure over the 12 months. And the total number of the patients including in the study was around 392. What they found, like around 24% of the individual, means around more than 100 patients have a deteriorate quality of life as per the Kansas City Cardiometabolic Questionnaire. It is not like that these patients are on suboptimal treatment. You can see in the downward here, the treatment was in form of SE inhibitor, beta blocker, diuretics, and the mineralocorticoid receptor is equally as that of the patient who remain stable. And only around few patients, like around 25% patients, show the improvement in the quality of life in form of score. So definitely, if you treat your heart failure patients with the maximal guideline-directed medical therapy, they are likely to have a low quality of life in form of decreasing the index more than 5 points over the 12 months. So how it will impact particular individuals, means in patient with the heart failure. So this is one of the beautiful slide which was taken from the global congestive heart failure study, include the 23,000 patients. As I told you, if the individual has a very high score, they have a good quality of life. So you can see here, on the x-axis there is time durations in the days, and on the y-axis there is a survival probability. So first curve, which is mentioned in the blue line, belong to the individual who have a score between 0 to 24. So they have a mortality of around 40% at the end of 2 years. So if they have a score between 0 to 24, they have a mortality around 40%. But if the individual have a score more than 75, means they have a good quality of life, the mortalities belong to only 8.8%. So there is a significant increase in the mortality. We can see at least 5 times in the individual who have a score more than 75, who have a score less than 25 in the individual with the heart failure. This is the same thing, but how the improvement in the quality of life in the heart failure patient will impact the mortality. You can see on the x-axis there is a time durations which is up to the 12 month, and on the y-axis the survival probability. When the study was started at particular point, and then the patient was treated with the adequate heart failure therapy, and this middle line is showing the stable patients. The lower line, lower graph, which is showing the patient who have a deterioration in the score more than 5 points over the 12 months. And you can see the mortality of that individual is increased 1.5 times compared to the stable patient. But if the score is reduced to less than to more than 5 points, again they have a low mortality. So quality of life or quality score assessment, or if the patient have a poor quality of life, it is directly related to the higher mortality in the individual with the heart failure. Now, regarding the interactions between the quality of life score and the NYHA class. See, on the x-axis you can see the Kansas City Cardiometabolic Questionnaire score, which is divided into 4 quadrants between 0 to 20. One quadrant is 0 to 24, second one is 25 to 49, third one is 50 to 74, and the fourth one is 75 to 100. And on the y-axis, it is a probability of mortality. You can see if the individual, even who have a very low score, low quality of life score, but if they have a higher NYHA class, they have a higher mortality rate. And when you look at the last one, which score is between 75 to 100, even between the patient who have a NYHA class 1 or 2, which is mentioned in the yellow bar, have a 8.3% mortality, while if the patient have a NYHA class between 3 and 4 and have a score even more than 75, they have a higher mortality. So one of the worst combinations in the patient with the heart failure is a poor quality of life along with the higher NYHA class. So in nutshell, a poor quality of life in the patient with the heart failure is linked to the negative clinical outcome, including the higher rate of mortality, including the higher rate of hospitalizations. Therefore, regular assessment and the improving the patient's quality of life play a vital role in improving their clinical outcome. So one has to do the guidelines-directed optimal medical therapy in the individual to reduce the, to improve the quality of life in these patients. What about the recent guidelines recommendations on the management of heart failure with reduced ejection fraction, as Dr. Anand already mentioned the guidelines. So that was also in 2021, they emphasized the assessment of quality of life in any individual with the heart failure and reduced ejection fractions, so one can improve it with the optimal medical management. Now, we all know we have so many medications available to improve the mortality and morbidity in the patient with the heart failure. See, initially we have a triad of a beta blocker, mineralocorticoid receptor antagonist, SE inhibitor or ARNI, and since last 2 to 3 years we added the SGLT2 inhibitor as a fourth pillar in management of the heart failure with reduced ejection fraction, with or without diabetic. So, did this therapy is likely to improve the quality of life or not? See, I will go in detail with each molecules. This is a study taken from PubMed. It is a meta-analysis about the effect of beta blocker therapy on quality of life in the heart failure patients, systemic review and meta-analysis. See, initial concern was that like beta blocker is likely to knock out the sympathetic activity in particular individual. So this patient have a more symptoms related to the fatigue and may have some erectile dysfunction. So concern was created like the beta blocker is likely to reduce the quality of life in the patient with the heart failure. No doubt beta blocker is improve the mortality in the patient with the heart failure. But in this study, it was clearly mentioned, the study, the meta-analysis to conclude the 9 trials and around 1,954 patients, and it is shown the addition of beta blocker to the standard heart failure therapy is not likely to deteriorate the quality of life in the patients with the heart failure, but it is not shown the superior to improve the quality of life in the individual with the heart failure. What about the SE inhibitors and the ARBs? We don't have that much clear-cut trial regarding the SE inhibitor and the ARBs in form of improving the quality of life. This is again the meta-analysis done and taken from the PubMed. What it show, it's showing there is no clear-cut evidence regarding the improvement in the quality of life, particularly in the individual who are taking SE or ARB to reduce the mortality and morbidity in the heart failure patients. But we need a randomized control trial to show the effect of SE inhibitor and ARB to improve the quality of life. So among the overall available 4 pillars, beta blocker did not improve the quality of life. There is a mixed result with the SEA and ARB. So now we have another molecule in place of SEA and ARB, which is a sacubitril valsartan, known as ARNI. What about the role of ARNI in improving the quality of life in the patients with the heart failure and reduced ejection fractions? So you all know the landmark trial which showed the benefits of the ARNI over the SE and ARB in the heart failure is Paradigm HF trial. And this is a sub-study of that study, particularly emphasized on the looking towards the positive effect of ARNI in improving the quality of life. So what this study will show, the yellow one is for the sacubitril valsartan and black one is for enalapril. On the on the y-axis it is score, which is same score, Kansas City cardiomyopathy questionnaire score. You can see from the baseline to the 12 weeks, the score is improved from the baseline 64 to 73, while in enalapril group is improved from 67 to the 71. And when we look at the value of interaction by changing the score, it is less than 0.05 and it is a clinically significant. So it means patients who are treated with the ARNI have a better quality of life compared to the enalapril. Same thing, in this they divide the score in between 2 things, clinical summary score, which include the symptoms and physical activity, and overall score, which is also include the independence of the individual. Here also you can see the patients who are on the sacubitril valsartan have a better improvement in the quality of life compared to who are just only on the enalapril. Now the next question is there, when these patients are likely to improve the quality of life who are on sacubitril valsartan? And from this same study, it was showing once you start the sacubitril valsartan, they see the improvement in the quality of life immediately after 2 months of initiation of therapy. So the effect of this therapy on improving the life is also immediately compared to the other medical therapies. So what the RNA will do, it improve the quality of life score, it improve the sexual activity, it improve the 6-minute walk test, and if you do the invasive study like PVO2 mix measurement, it will also increase that one. So definitely, in conclusions, changes from the same study, change score in the quality of life in clinical summary as well as in overall summary were better in the patients who are treated with the sacubitril valsartan compared to the enalapril. This is the same thing, but how much the RNA will add related to the survival benefit, you can see on the x-axis is the age group and on the y-axis it is a quality score. So when we will plot the plot a chart for the enalapril and Vimada, you can see the score, the difference between the age is around 9 years. So the patients will feel better compared to the enalapril group. What about the SGLT2 inhibitors? It is a molecule like we have empagliflozin and dapagliflozins we are commonly using nowadays in heart failure with reduced ejection fraction patients. This is one of the meta-analysis which conclude the 9 articles and around more than 9,428 patients. 2 minutes only. And what it show, the meta-analysis show by using the SGLT2 inhibitor, particularly in the patient with the heart failure and reduced infections, it's likely to improve the quality of life. See, nowadays, if you want to launch any diabetic medications, it's likely to have some effect on the reducing the cardiovascular mortality. Likewise, if any medications will launch in the heart failure, has to undergo the trial which show the improvement in the quality of life of the heart failure patients. So we have more and more data for the recent medications, while the older medications, SE and ARB inhibitors, we don't have that much data. What about the cardiac rehabilitations? As you all know, the cardiac rehabilitation not only include the medical therapy, but include the exercise also. So this is taken from the NHIR, National Health Institute and Research Center, which show the exercise-based rehabilitation for chronic heart failure patients does not affect the mortality or hospitalizations, but does lead to the improvement in exercise capacity and health-related quality of life. So it is exercise-based. So here the rehabilitation should be exercise-based, not only just medications. And it will not improve the mortality, but it will definitely improve the quality of life of a particular individual. And lastly, the heart transplant. So we have a very higher threshold to refer the patient for heart transplant. Now this is one of the study from the Germany where they conduct the quality of life improvement in the patient who have a end-stage heart failure versus who have a cardiac transplantations. And you can see this, they include not only the ischemic cardiomyopathy, but they include the patient who have a non-ischemic cardiomyopathy and other form of heart failure. And in this study, they used the WHO questionnaire to compare the quality of life, which is almost similar to that of Kanasa heart failure questionnaire. And when you look at all the aspects like sexual improvement or in the physical improvement or the symptomatic improvement, everywhere the p-value is significant. So patients who underwent the cardiac transplantations have a better quality of life compared to who are on medical therapy. But you have to refer the patients who are in good condition to the cardiac transplantation. If the patient will develop the multi-organ dysfunction in form of like chronic cardiorenal syndrome who has a creatinine more than 2.5, then it is unlikely that patient will get much benefit. So this is one of the transplant indication for transplantation, and you know we have to refer the patient for transplantation where their VO2 max is less than 12 ml per kg per minute. So how we can identify in our busy practice regarding which patients need to refer for cardiac transplantations, and you can see one of the best indicators or one of the best low-cost tests which you can do in your routine clinical OPD is take 100 meters to draw a 2 line at the distance of 100 meters. Ask your patients to walk for a 6 minutes. If patient with the heart failure and reduced ejection fraction can walk more than 350 meters in 6 minutes, this patient most likely doesn't need a cardiac transplantations. But if it is less than 350 meters, this is a time where you have to refer the patient for further evaluation of cardiac transplantations and further hemodynamic invasive study likely to make the candidate for cardiac transplantation or may defer the cardiac transplantation. So in conclusions, a low quality of index associated with the higher mortality and morbidity in the heart failure patients, treat all the heart failure patients with optimal medical management including the RG and SGLT2 inhibitor Treat the patient with the beta blocker also, because it is not likely to reduce the quality of life in particular individual. Exercise-based cardiac rehabilitations also improve the quality of life in heart failure patient. Heart transplant recipients show the better quality of life compared to the end-stage heart failure patients. And 6-minute walk test or 6-minute walking distance is one of the best parameter which will help us to refer the patient for cardiac transplantation. Thank you.
Thank you, Dr. Kilol. Nice presentation. So since we are running short of time, so we allow 2 questions from audiences. So kindly ask any 2 questions.
I think 1 or 2 questions we can have, and the rest you can have during the lunch session.
One question I wanted to ask, a simple question, practical one. A patient comes with an acute coronary event. His blood pressure is about 100/70, and his ejection fraction is about 30%. So we would like to start something. Out of the 4, which one you will start with, and how will you progress?
Sir, if this is an acute coronary syndrome, it's a completely different scenario. We're not talking of heart failure. What's it?
After some time, it's about a month for acute coronary.
Okay, after you have managed the acute coronary syndrome, if at all there is a candidate for revascularization, you have done that, then the treatment would be RAS blockade and beta blockade. Which one to start first? It depends on the patient's hemodynamic stability. If the patient is off all inotropic support, he does not require IV diuretics, you have shifted him out of the ICU, then ARNI, because there is evidence to suggest that early initiation of ARNI does improve outcomes, it is well tolerated and it can be safely started. So I would rather choose to go with ARNI and then beta blockade, and then gradually increase the doses of both of them. Thank you, sir.
Any more question? I think our audiences needs to be energized. So we will take few minutes for felicitation program. Okay, should we start? So I would like to invite Dr. Vikas Doshi to felicitate Dr. P. Manokar. Dr. Manokar? Okay, sorry, Dr. Manokar is not available here. So I would like to invite Dr. Ahuja to the stage, and Dr. Vikas Doshi, kindly felicitate him. Thank you, Dr. Doshi, and thank you, Dr. Ahuja. I would like to invite Dr. Ketan Doshi to felicitate Dr. Kilol Kaneria. I would like to invite Dr. Basant Patel to felicitate our chairpersons. I invite Dr. Vikas Doshi on the stage. I request Dr. Basant Patel kindly felicitate our next chairperson, Dr. Ketan Doshi. Thank you, Dr. Basant Patel. Thank you. Okay, so now let's take a break for lunch, and some sessions are going on downstairs, so if you want to join, you can join. Thank you.
Hello. Check. Hello. Check. Check. Check.
Hello, everyone. Good afternoon, everyone. We will start our next session. So I would like to invite our chairpersons, Dr. Neerav B. Shah, Dr. Sanjay Shah, and Dr. Mujahir. Kindly come to the stage, sir, to preside over the session. Dr. Neerav B. Shah, Dr. Sanjay Shah, Dr. Mujahir. Dr. Mujahir is not here. Hello, Dr. Mujahir. I request you to please come to the stage. Dr. Mujahir. Sorry, Dr. Mujahir is not available. So we will start our last session. So I would like to invite Dr. N.K. Singh from Dhanbad.
ये है करने का चेयरपर्सन कुछ बोलेंगे क्या? लेट देम स्पीक देन आई विल स्टार्ट।
सर
कैसे जाएगा देखो तो।
थोड़ा सा
ठीक ठीक ओके।
Hello. Hello. This is a post-lunch session, but we have interesting topic and eminent speakers. In the armamentarium of the diabetes, we have a magic bullet, SGLT2 inhibitors. So Dr. N.K. Singh would enlighten us about its qualities. He is an eminent speaker. His credentials are on the screen. I would not like to take much of time, and I would request Dr. Singh to start his lecture. Thanks.
Good afternoon, chairpersons and dear colleagues. At the outset, many thanks to Anuradha, Akash, Dr. Chawla for creating an event. That is, I think this is the first one, but this has surpassed many other conferences too. Thank you and congratulations to you. Now the problem is we are at post-lunch session and already taken heavy meal, I think. And this time hardly the brain works. This is true. Yes. So I will not go for to bombard you with the whole, so many data which has collected. But next 20 minutes allotted to me, I will just tell you what is happening with the SGLT2 inhibitors in the renal protection. This is my topic basically. Initially, we are well aware that when you give SGLT2 inhibitors to a heart person, how the heart becomes happy. But time has come, we should tell our target audience, the frontline physicians, that look, if you start SGLT2 inhibitors in a case of CKD, in a case of diabetic nephropathy, for a very early stage, you can make your kidney also happy. So there has been amazing advances. Nobody thought of those advances which has occurred. So there has been a great leap in 2020. Initial concern was 4 or 5 years back when we were heard about the SGLT2 inhibitors for the kidneys. That was focused on possible. लोग बोलते थे कि ओ SGLT2 inhibitors दोगे, there will be detrimental effects on renal system. This was the concept. What we'll do is we'll do the GTI, genitourinary infections, bladder health will be compromised. तो ये जो टेंशन था कि SGLT2 inhibitor देने से ये सब प्रॉब्लम होगा, ये आज पूरा ईज हो गया है, खत्म हो गया है. Number one. The second part, when you will start SGLT2 inhibitors, there will be deep in EGFR. EGFR तो घट जाएगा. So how it will help to your kidney? ये भी खत्म हो गया है. We have understood it, and in this time, अभी भी बहुत से डॉक्टर्स को the initial concept is कि when will you start SGLT inhibitors, अरे वही blood volume कम जाएगी, BP down हो जाएगा, आदमी गिर जाएगा. In elderly patients, so lots of things in your mind. Believe me, now it is all vanished. I will tell, vanished. The third thing, we learned about all the renal things initially from all the cardiovascular trials. And the identified that SGLT inhibitors to reduce the risk of onset and progression of several cardiovascular conditions. This we understood. So this appears very, very pertinent these days. Because ultimately the SGLT inhibitors are derivatives of a chemical florigine that you get from the bark of apple. और आज भी हम बोलते हैं कि एक सेव रोज खाइए और डॉक्टर को अवेयर रखिए. Now the new mantra is कि एक SGLT inhibitors अपने पेशेंट को दीजिए, उसका किडनी फंक्शन को ठीक रखिए, हटा दीजिए, फेंक दीजिए और MI से भी बचिए. So this is the final message of my talk. So I will end anywhere my type. So this is the final thing which I want to tell you. Now ये रिश्ता क्या है डायबिटीज एंड किडनी का? The first thing you understood, we should understand the science कि what is happening if you are giving the SGLT2 inhibitors. So in diabetic kidney disease, which is 60% of new patients beginning renal replacement therapy. Remember, data is so problematic. I will not go in the Indian data also showing the same thing. So basically we are concerned about two things, that is the DKD, CKD, and this is the leading cause of end stage renal disease. So we need to interfere at some place. This is very, very important. So greatest increase in this type 2 diabetic prevalence has occurred in low to middle income countries where risk of CKD is high. So India has a very, very bad situation. And remember that incidence of cardiovascular disease in patients with type 2 diabetes has improved, definitely. But this effect had not been associated with any substantial reduction in type 2 diabetic associated renal impairment. This point must be noted. Cardiovascular में improvement हुई है, but renal replacement therapy में improvement अभी तक नहीं हो पाई है. But you can do it, remember. We had already the RAS blockers for the renal protection. And this was the only thing, almost, reduction of the BP, some dietary control, and RAS blocker. And that way we were trying to GFR preservation, and independent of the effect on the blood pressure. And we had the renal trial, IDNT trial, where that showed that losartan and irbesartan brought it. But remember, diabetic kidney disease, already on the RAS blockers, they progress to kidney failure. This is very, very important point. Ki even after taking all these things, RAS blockers, they were progressing. But, and हम लोग लड़ इस तरह से रहे थे. Diabetic kidney disease से हमारे nephrologist जो है, they were only using BP control, salt reduction, RAS blocker. तो ये लड़ाई किस तरह थी कि इस तरह के डिमॉन से आप एक छुड़ा लेके चल रहे हो, इससे क्या होगा? इसके लड़ने का अलग आपको वीपन चाहिए, और वो वीपन आज हमारे पास है. वो क्या है? दैट इज SGLT2 इनहिबिटर्स. सो नेक्स्ट क्या हुआ? नेक्स्ट कहानी है, द इंपॉर्टेंट टू रिमेंबर दैट द मेजॉरिटी ऑफ पेशेंट्स, 80% इन द अर्ली SGLT2 ट्रायल्स वेयर ऑन ACE or ARB, I told you. And then came the credence trial. उसने माथा खोल दिया हमारा credence trial. I will show you. तो ये पता चला कि SGLT2 inhibitors work in patients with DKD or RAS blockade, which produce efferent vasoconstriction. ये पता चला, लेकिन ऐसा क्यों हो रहा था? So today, time has come where you should not tell that SGLT2 inhibitors is a diabetic drug, anti-diabetic drug. It is a cardioprotective, metabolic protective, and nephroprotective drug. This is the new nectar in the diabetes and non-diabetics too. I have not time too much. I will not tell you, but there is science what is happening in the diabetic kidney disease. And this whole process can be reversed if you give the SGLT2 inhibitors. You see here, जैसे ही SGLT2 inhibitors आप start करते हो, what are the problems we are going inside the kidney that becomes reversed? I have not time, I will not tell you, but so this happens. Ultimately, the leading points are, when patients start on SGLT2 inhibitors, the inflammation or fibrosis decreases, oxygen consumption and hypoxia decreases, there is alteration of energy metabolism, and there you get the cardioprotection, and ultimately leading to nephroprotection. Things are quite clear these days. तो ये हंट्स रेमेडी की तरह काम करता है, काम करेगा ही, don't worry about that, करेगा. And this concept, latest concept in 2022, diabetes, you are giving SGLT2 inhibitors, somehow the ketone body is increasing, and ultimately the whole process is targeted on renal mTORC1 hyperactivation. And today we know there is this tubular damage, this podocyte damage. If you block this renal mTORC1 hyperactivation, this can be reversed, और यही SGLT2 inhibitors करता है. तो this science, जहाँ erythropoietin भी increase करता है, and renal and extrarenal, so lots of actions are there, and leading to all the ways how it protects your kidney. In next 6 minutes I have got, so अब मैं जो बात कर रहा हूँ वो हवा में कर रहे हैं या कुछ proof है इसका? Let us see it. We cannot, this audience, I cannot fool you. ये बाबा रामदेव का नहीं बता देंगे कि टाइप 1 डायबिटीज भी वो क्योर कर देते हैं. That is not happening here. इसकी साइंस है, this is happening. And we have got renal protection studies. We have data from CVOTs. We have data from the renal trials. See here. पहले बार माथा खुला जब एम्पारेक ट्रायल आया. Luckily, I don't know Dr. Patni was there or not. I was lucky enough at Stockholm, I think, when this the first time we heard live at Stockholm. That time, एम्पारेक आया. That time लगा कि किडनी के अलावा एक, सॉरी, हार्ट के अलावा एक किडनी को भी प्रोटेक्ट कर रहा है. And then ये पता चला कि slowing of annual rate of decline in eGFR is possible by empagliflozin. And this resulted in regression of albuminuria, that is very, very important, by EMPA-REG trial. And then lots of trial came, EMPA-REG, CANVAS, DECLARE-TIMI with DAPA, VERTIS-TIMI, different criteria when you take of definition of substantial loss of kidney function, all showed benefit. But the first landmark trial I was telling you that highlights the power of SGLT inhibitors was the CREDENCE trial. It was just like a silver lining in the dark clouds of diabetic nephropathy. Very, very important trial. And this showed us the conclusion of the CREDENCE trial are certainly exciting for clinicians managing DKD. This has significant benefits in both renal and cardiovascular outcomes, even in individuals with more advanced CKD. That was I'm not going into details of CREDENCE, but this happened. You can see here what CREDENCE showed. But now today, in 2022, we have lots of trials. Apart, we have got DAPA CKD, Emperor reduced, Emperor preserved, Vertis CV, EMPA kidney. And all trials are giving us the same message, You see here, this is the kidney outcomes is showing consistent message is coming. Now also the message came that diabetes में तो फायदा हो ही रहा है, but non-diabetic kidney disease में, even a non-diabetic person, if you are using SGLT2 inhibitors, the same benefit is coming, same. This is really amazing. You can see here, from Emperor reduced, you see here the slope difference. The relative risk reduction, you can see, HR 0.5, so important. And you can see here how this is happening. And then came the Emperor preserved. And this also showed the same confirmatory things, how the rate of eGFR decline in patients treated with EMPA was half that of patients treated with the placebo. So you can see here. Then DAPA-CK was a catalyst to the change in whole concept again. And the same things, same message, this year also, by sub-analysis of the DAPA-CKD, is coming that DAPA reduced the risk of abrupt decline in kidney function in patients with chronic kidney disease and substantial albuminuria with and without type 2 diabetes. You see here. And then, so this has been DAPA-CKD established. 3 फायदा होता है. Reduce the risk of kidney failure, reduce the risk of CV death or heart failure, hospitalization, and prolonged survival. Very important. As you can see here, this was a significant victory with and without diabetes. And then this year on 16th of March, this EMPA kidney trial was halted because we got the very exciting results. It has not been so published now, but things are first time this trial, very, very important trial. Broad spectrum of adults with CKD took with mildly to severely reduced eGFR. अभी तक ऐसा नहीं किया गया था कि mildly to severely reduced में भी उसमें cohorts में थे with normal and increased level of albumin, with or without diabetes, and with CKD attributable to a wide range of underlying causes. And many of these patients have been never represented in any of the previous trial. So I again say this was a landmark trial, and within 1 or 2 months you will get the whole results. So I told you that in the EMPA kidney expands the scope of types of patients with CKD which are benefited from SGLT2 inhibitors. CREDENCE interested only in patients with type 2 and having the diabetic nephropathy. DAPA-CKD, 2/3 of enrolled patients had type 2 diabetes and all had CKD. But EMPA kidney, 46% of had diabetes, including a very small number of type 1 diabetes. So this was a departure. EMPA kidney, 20% of patients did not have albuminuria also. So even ऐसा केस तो हमारे प्रैक्टिस में रोज मिलता है जहाँ पर कि उसको albuminuria नहीं है, diabetic है, non-diabetic. तो ऐसे केस में भी you can see it. So this is a very, very exciting trial. Wait for it for details. I think the next, I think 2 minutes are there. So EMPA kidney is the largest and has the widest range of people with CKD, I told you. So this is again very, very exciting. And now the list, these are the things which you will get in next 2 or 3 years by 2024, even with the semaglutide flow charts will be coming. So lastly, you see here, this is by the big picture is, what is the big picture? Give me 2 minutes more. फर्स्ट थिंग, क्योंकि ये इम्प्रिंट हो जानी चाहिए आपके दिमाग में, दिस बिग पिक्चर. नंबर 1, आप जैसे ही SGLT2 इनहिबिटर देते हो, स्लोइंग इन GFR डिक्लाइन आप कर रहे हो. वेरी इंपॉर्टेंट, नंबर 1. Second, see from the NEGM, the canvas trial, sorry, the credence trial, reduction of hip GFR. See here, in nutshell, अगर कुछ मोटा बुद्धि लगा के भी हम बोले हैं, तो ऐसा लगता है कि इस दवा को देने से उसका 15 साल जीवन आप बढ़ा रहे हो, उसका हॉल्ट करके GFR, in very short and very rough way, if I say. So this is the message from this trial. You can see here, ये 15 साल का जो दिखा रहा है, this is very, very exciting. This is the second point, very important. And remember, if you compare with the GLP-1 RH, GLP-1 RA, lower risk of MACE in those with atherosclerotic cardiovascular disease. It is the only SGLT2 inhibitors which exact improve HHF and kidney disease progression. This is quite clear today. So final points are, in the 2020 therapies are effective down to eGFR of 25. But Dr. Patni has attended ADA. Now the ADA 25 eGFR level is probably going to be 20. It is already by KidGo guidelines. तो ऐसा नहीं है कि 40 हो गया तो ये SGLT2 इनहिबिटर्स नहीं देंगे. 30 तक तो कोई मैंने आप देख बिना सोचे हुए दे सकते हो. इन बिटवीन अब तो 20 पर भी देना होगा, और मेरे ख्याल से नेक्स्ट 2 years you will hear then even with the 15 eGFR you can start it. इसका कारण है. So large severity RCTs in diabetic and non-diabetic CKD patients on RAS blockade have shown that they slow kidney disease progression, decrease CV events and improve survival. तो और आपको चाहिए क्या diabetic patient में? यही तो चाहिए हमको. And these benefits appear to extend beyond diabetes also. So you can use it with having the hypertension, etiology, vascular nephropathy, on even although the glomerulonephritis cases. यहाँ भी आप इसको नॉन डायबिटीज में भी यूज कर सकते हो. So as a frontline physician, my urge is that you initiate SGLT2 inhibitors with type 2 diabetic patients. At least अगर उसका eGFR 30 के above है, तो with peace of mind से you can start. And if you defer कि okay, I will refer to a nephrologist or endocrinologist and they will start the SGLT2 inhibitors, you will lose the time. Don't lose the time. और ये माथा से हटा दीजिए कि आप SGLT2 इनहिबिटर्स दोगे तो UTI हो जाएगा, GTI हो जाएगा, उसका BP डाउन हो जाएगा, वॉल्यूम कम जाएगा, वो गिर जाएगा. कुछ भी नहीं होता है clinically. We have got the data from the real world studies. I am able to show if you want. So prescribe it should be aware that initially GFR drop होती है 2 हफ्ते तक. When you start the SGLT inhibitors 2 हफ्ता तक की GFR घटेगा और फिर वो stabilize हो जाता है. ये clear है. So then you will get the slow the decline in GFR. So I told you about the safety. Last slide है हमारी. ऐसा न हो कि HbA1c बहुत बढ़िया था, हमने बड़ा अच्छा इंसुलिन दे दिया, हमने SGLT2 सल्फोनाइलूरिया से उसको कंट्रोल किया, उसका HbA1c हमने 6.4 पे रखा, हमने 5 पे रखा और अल्टीमेटली उनको ग्रेफ में जाना पड़ा prematurely. But this can be halted if you start SGLT2 inhibitors. I think this is my last slide. Thank you very much.
Thank you, sir.
Questions are now or later on? Later on. Okay. Thank you. Thank you, sir. Thank you.
As expected, very nice, fantastic session by Dr. N.K. Singh. So I would like to, question answer we will take after the last session. So I would like to invite our next speaker, Dr. Pratap Jethwani from Rajkot.
Hello. Can I start?
You can start.
So let me first thank Dr. Akash Singh, Dr. Kamaldeep Chawla, Dr. Kapoor and the entire team of IDCM for inviting me to this inaugural event at Vadodara, and I think we would like to see future events. Already there is large gathering, and I think you need to have a bigger space to accommodate more people who will be interested in attending this kind of events. So after an excellent talk by Dr. N.K. Singh highlighting the importance of SGLT2 inhibitors in the management of CKD in type 2 diabetes and also in non-diabetic individuals, I will touch upon this newer thing, that is SGLT2 inhibitors and prevention of diabetes. What is the rationale behind that, and is there any evidence to support this thing? So first I will touch upon prevention of diabetes, when and how. We all agree that we are facing the tsunami of metabolic disorders, particularly diabetes and other cardiometabolic disorders in our country because of lifestyle changes which are occurring in our country. And we need to prevent this disease, not only to give them a good long life, but also life free of complications. So we all know that pre-diabetes is a state where we can target those patients for prevention of diabetes. It includes IFG as well as IGT. These are the various terminologies, you all must be aware of that. But the important thing is that pre-diabetes is mostly associated with obesity, and also it is associated with multiple cardiometabolic risk factors which are being termed together as metabolic syndrome or cardiometabolic syndrome. Pre-diabetes is not only associated with an increased risk of development of diabetes, but there is an evidence to support that it is also associated with an increased risk of microvascular disease, which is peculiar to type 2 diabetes or type 1 diabetes, being facilitated by persistent progressive hyperglycemia. There is evidence to support that microalbuminuria is quite common in people with pre-diabetes as compared to the people who are having normal glucose tolerance. Same way, if we see, retinopathy can occur in 1 to 2% of such subjects, and also CKD is more common in pre-diabetes as compared to those who are having normal glucose tolerance, although it will be much higher in frank diabetics, but still, before the definition of diabetes is established, even in the stage of pre-diabetes, there is damage being done to microvasculature also, resulting in the development of microvascular disease. And even nephropathy is there. There is a report from Monica study. If you see the macrovascular disease, we all know that the clock starts ticking before the diagnosis of diabetes. So even when there is obesity, there is metabolic syndrome, there is pre-diabetes, multiple severe risk factors, the risk of macrovascular disease or cardiovascular events increases. And this is the recent most meta-analysis which was published in British Medical Journal in 2022. And 3 important messages from this meta-analysis of 129 studies involving more than 10 million participants. First thing is pre-diabetes is associated with an increased risk of all-cause mortality and cardiovascular disease, both in the general population, and even if the patient is having established cardiovascular disease and at the same time having pre-diabetes, then the risk of further cardiovascular events as well as mortality increases in that population also. Second thing is IGT is much more dangerous as compared to IFG if you see all-cause mortality or cardiovascular events. And third thing is, if you consider impaired fasting glucose, then the risk increases only when the fasting plasma glucose crosses 110 milligram deciliter value. It is not with 100 to 125 as per ADA definition, but the definition of IFG as per WHO, that is 110 to 125, in that category, the risk of all-cause mortality is higher as compared to the people who are having fasting plasma glucose less than 100. So these are 3 important messages from this meta-analysis, and it clearly confirms that pre-diabetes is not only a state where there is increased risk of diabetes, but there is increased risk of macrovascular disease as well as all-cause mortality. If we touch upon heart failure, this is a data which was published in 2021. Pre-diabetes associated with increased lifetime risk of heart failure also. So it is a state where we have to focus not only on prevention of diabetes, but we have to focus on improving other cardiometabolic risk factors also, so that we can prevent cardiovascular events and premature death which occur in these individuals who are having pre-diabetes. And if you see here, the combined IFG and IGT, as the dysglycemia progresses, the number of persons who are having metabolic syndrome increases. In combined IFG and IGT, almost 2/3 of them, they are having multiple cardiometabolic risk factors, suggesting that they are at high risk of cardiovascular disease. This we all know that metabolic syndrome can result in variety of conditions. There is abdominal adiposity, there is dysglycemia, there is hypertension, and there is dyslipidemia. And I think you all will agree that SGLT2 inhibitors, they target almost all the things which are there in the metabolic syndrome. And so that should be, probably in future we will hear much more about the role of SGLT2 inhibitors in metabolic syndrome, not only for prevention of diabetes, but for improving overall metabolic and cardiovascular health. We all agree that prevention of diabetes, it requires lifestyle modification, weight loss mainly. If you achieve weight loss to the tune of 7%, you can reduce the risk of development of diabetes by almost 58%. That is 2/3 of individuals as per DPP. So the focus should be on weight loss, on increasing physical activity, and that will translate into reduction in the development of new diabetes. Now let's touch upon, so pre-diabetes is associated with not only increased risk of diabetes, but also cardiovascular risk is there, and we need to modify all the things together. And if there is a single pill, then that will be a very good way to treat these people who are having pre-diabetes and multiple severe risk factors. So what is the rationale of SGLT2 inhibitors? We all know that SGLT2 inhibitors, they not only reduce blood glucose, but they have got beneficial effects in the form of reduction in body weight, reduction in blood pressure, and reduction in ectopic fat. We all agree that they are the molecules which change the way we treat our type 2 diabetes patients. Now, all the organizations, they agree that you have to divide your patients, type 2 diabetic patients, in two categories. One who are already having either established cardiovascular disease, established renal disease, or multiple risk factors for cardiorenal disease. In this group of patients, you have to use these agents irrespective of their glycemic control, because here you are using them not only for glycemic control, but for altering the pathophysiology and providing them cardiorenal protection and survival, longer survival. So cardiovascular benefits are there already. Dr. N.K. Singh highlighted about cardiovascular and renal benefits of SGLT2 inhibitors. Definitely there is a weight loss. Data is there with all SGLT2 inhibitors. This is one trial where empagliflozin over a period of 4 years was able to maintain weight loss of almost 4 kg as compared to placebo and 5 kg as compared to glimepiride. So it provides good amount of weight loss, and weight loss is definitely associated with reduction in the risk of diabetes. So we can use these agents for prevention of diabetes also. And the weight loss is mainly from fat loss. There is a decrease of adipose tissue mass after 6 months of intake. So it is not only diuresis and water loss which contributes to weight loss, but it is because of loss of fat, and mainly ectopic fat, which is there in the abdomen, in the liver, that is reduced with the help of SGLT2 inhibitors, and probably because of them they are providing variety of metabolic and cardiovascular benefits. There is definitely a reduction in both systolic and diastolic blood pressure. This is data from 3 different studies, canagliflozin, dapagliflozin, empagliflozin. If you see the systolic blood pressure reduction, and there is data to support that this is much more pronounced in Asians as compared to white counterparts. As far as lipids are concerned, people still feel there is some controversy related to lipids, but if we see here clearly, triglycerides will go down definitely, HDL cholesterol will improve, LDL will increase, but at the same time, the small dense LDL cholesterol will go down and the large buoyant particles of LDL cholesterol will increase. So this will provide atheroprotective effect. And there is mild ketogenesis. So there will be a nutritional ketosis which can be achieved with the help of therapeutic carbohydrate restriction. I think we all Indians, we consume a lot of carbohydrates, and it is very difficult to persuade your patients that you have to restrict on your carbohydrates. So if you give them SGLT2 inhibitors, they will give same effect like therapeutic carbohydrate restriction and result in nutritional ketosis, and that is beneficial as far as cardiovascular health is concerned. As far as NASH or NAFLD is concerned, there is a loss of hepatic fat to the tune of 25 to 30%. This is data from Delhi, Professor Ambrish Mittal and his team. There is E-lift study, decrease in hepatic fat with empagliflozin and almost 30% reduction in hepatic fat. And we all know that hepatic fat is the culprit which contributes to the development of diabetes in people who are having metabolic syndrome. Uric acid, there is a metabolic syndrome nowadays. One component is also considered that hyperuricemia is a part of metabolic syndrome. And there is data to support that they reduce uric acid, almost all gliflozin, mainly empagliflozin, if we see, almost 30 to 40% reduction in uric acid levels. So if we see metabolic syndrome, abdominal adiposity, that is reduced by SGLT2 inhibitors. If we see dysglycemia, that is corrected by SGLT2 inhibitors. Hypertension, it is also corrected by SGLT2 inhibitors. High triglycerides, low HDL, also corrected by SGLT2 inhibitors. If we see NASH, if we see PCOS, if we see hyperuricemia, all the components of metabolic syndrome, if you give SGLT2 inhibitors, definitely there will be improvement in each and every component of cardiometabolic syndrome. And this justifies that there is a rationale to use SGLT2 inhibitors for prevention not only of diabetes, but also to give pre-diabetic individuals good cardiovascular health. This is a recent study where mouse model was used, and they have proven that SGLT2 inhibitor, they improve energy expenditure, they reduce obesity, and the important thing is they reduce ectopic fat accumulation, which is the contributor of insulin resistance and which is the contributor of all the aspects of cardiometabolic syndrome. So there is weight loss, insulin resistance will go down directly, indirectly. There is evidence to support that the beta cell function will improve, and almost there are cardiovascular benefits. So this gives you a rationale that SGLT2 inhibitors can be used for prevention of diabetes. Now, is there any evidence to say that SGLT2 inhibitors can be used for prevention of diabetes? So first, there is no randomized controlled trial or particularly focusing on this question as a primary outcome. But DAPA-HF and DAPA-CKD, these both trials, they have done exploratory analysis. DAPA-HF, I think, was already highlighted by Dr. N.K. Singh, that patients with heart failure reduce ejection fraction. If you give them DPP-4 inhibitor, this SGLT2 inhibitor, dapagliflozin, that will reduce risk of worsening heart failure and death from cardiovascular causes. And this was independent of the presence or absence of diabetes. So what they have done exploratory analysis of people who were not having diabetes at the baseline. Those individuals who were having heart failure with reduced ejection fraction, no diabetes at baseline, HbA1c of less than 6.5 at baseline, and then they have followed up them. Some were on empagliflozin, some were on placebo, and median follow-up was only 1.5 years, 18 months. If you see, diabetes developed in 7.1% in the placebo group and 4.9% in the dapagliflozin group. So there was a relative risk reduction of 32% in the development of new onset diabetes in people who were having heart failure with reduced ejection fraction but no diabetes at baseline. Almost 90% of these individuals, they were having pre-diabetes at baseline. So we can say that individuals who are having pre-diabetes, heart failure with reduced ejection fraction, if you give them dapagliflozin, the risk of tuned onset diabetes in these individuals will be reduced by 32%. And if you see the absolute risk reduction, it is 2.2%, and the number needed to treat is 46 over 18 months. The important message from this trial was the HbA1c was almost same. So important 3 points which were highlighted by this trial. First, you can use SGLT2 for diabetes prevention in individuals who are having pre-diabetes. Second, a single drug can prevent diabetes as well as it can prevent death in these individuals who are having heart failure with reduced ejection fraction. And third thing, this reduction is independent of any effect on HbA1c. So it is not a mere reduction in blood glucose. It is doing something with beta cells, with insulin resistance, and probably because of that, the people are not developing new onset diabetes, even if they are having HbA1c between 5.7 to 6.4. And therefore, we need to have bigger trials, particularly in younger individuals, to say that these agents can be used for this purpose also. Same way, DAPA-CKD trial, I think Dr. N.K. Singh has already highlighted that this is the drug which in DAPA-CKD will reduce the risk of renal progression, will reduce the risk of cardiovascular problems, and prolong survival. Same way, exploratory analysis of DAPA-CKD done, and it has also shown that the reduction is to the tune of around 30 to 33%, reduced from 4.7 in the placebo group to 3% in the canagliflozin group. And when they have done a pooled analysis of both these trials together, and they have tried to find out what is the impact, where almost 65% patients were from DAPA-HF and 35% from DAPA-CKD, the hazard ratio was 0.67. So 33% reduction in the development of new onset diabetes when you use these agents either in people who are having heart failure with reduced ejection fraction or people who are having CKD and pre-diabetes at baseline. So this is only exploratory analysis, and we should not be convinced by exploratory analysis. We need to have a proof of concept study, and this study is going on where they are trying to find out whether the SGLT2 inhibitor will have an impact on beta cell function or not, and they are using various sophisticated techniques of intravenous glucose tolerance test derived glucose stimulated C-peptide secretion and various other measures which they are doing at baseline, at 6 months and 12 months, and even after washout they will stop SGLT2, washout period will go away, and then again they will measure all the things so that they will give us a clue whether SGLT2 they are actually altering the pathophysiology which is occurring in pre-diabetes so that they can be used for prevention of diabetes, and that will be a short treatment. You give this, diabetes prevention will take place, and probably their beta cell function will improve. Only time will tell. So till we find new evidence, I think I have already justified that SGLT2 inhibitors are the drugs which target not only pre-diabetes, not only hypertension or high normal BP, but obesity also, and they should be used much ahead in the hierarchy as far as diabetes is concerned. Even in pre-diabetes, if they are having multiple severe risk factors or heart failure or CKD, you are justified to use these agents to provide cardiorenal protection, and prevention of diabetes also will be a byproduct of these agents. So this is the way the SGLT2 inhibitors they work, and ultimately they improve cardiovascular, renal and metabolic status, and probably in near future we will hear much more about these agents, and probably they will be used much ahead in the hierarchy in type 2 diabetes management and even in pre-diabetes patients. Thank you very much.
Thank you, Dr. Jitwani, for a nice, interesting talk on the potential benefits of SGLT2 inhibitors in pre-diabetes. Now we go on to the next session, next lecture.
Our next speaker is Dr. Shaival Trivedi from Baroda.
Good evening, friends, seniors, and colleagues. I would like to thank organizers, particularly Dr. Kamaldeep and Dr. Akash Singh, for inviting me here. Today's topic is sexual dysfunction in diabetes. In first part, I will just brief about the female sexual dysfunctions, and in second part, we'll discuss about the erectile dysfunction in details. So, even though the prevalence of sexual dysfunction is high as a part of diabetic complication, still it's a neglected topic. And if we diagnose them earlier, then we can prevent the further vascular alteration, or we can detect hypogonadism early in the disease of diabetes. So, as a part of WHO, they have defined sexual health is an physical, emotional, psychological, and social well-being in terms of sexual desire, not just lack of disease, dysfunction, or disability. So, like ejaculatory problems and erectile problems are common in more frequent in diabetic male. Same way, women with diabetes also at a high risk of sexual dysfunction. So, inquiry about the sexual dysfunction is very important as a part of diabetic history. So, this is the DSM classification of sexual dysfunction. They classify as a male hypoactive sexual disorders, erectile disorders, premature ejaculation, delayed ejaculation, female organic disorders, female sexual arousal disorders, and substance or medicine-induced sexual disorders. So, in female, in various studies, the incidences are found between 40 to 60%. And in this national health data, it shows that the females are more prone to develop sexual dysfunction, like 43% in female and 31% in male. So, this meta-analysis showed that the higher frequency of female sexual dysfunction in diabetic women than in healthy control. And we can see that in a type 1, that is odds ratio is 2.27, and in type 2 it is 2.59. So, type 2 is more, they are vulnerable for sexual dysfunction. And overall, as we discussed, is around 68% in the last all different subclasses. So, female sexual dysfunction is classified as like hypoactive sexual disorder, hypoactive sexual desire disorders, female sexual arousal disorders, persistent genital arousal disorders, and female orgasmic disorders. So, like sexual health is a combination of lot many factors like cardiovascular problems, neurological issues, hormonal factors, interpersonal relationship, traditional governing family and community, culture and religion. So, ultimately it leads to a heterogeneous combination of disorders that is characterized as major disorder in one's ability to respond to sexual response or sexual pleasure. These disorders include women's abnormality in women's orgasm, arousal, pain, and unknown sexual dysfunction. So, as we said, etiology of sexual dysfunction, particularly in diabetic female, is neurological, psychological, as well as vascular factors. Even hyperglycemia, neurovascular alteration, and hormonal changes and recurrent genital infection, they contribute to female sexual dysfunction. So, International Society for Study of Women's Sexual Health has developed a process of care that provides practical recommendation to diagnose sexual dysfunction, because women, they don't come out with the problem by their own. So, they have made a questionnaire. As we discussed, pathogenesis, hypoglycemia actually leads to reducing lubrication as well as mucosal dehydration, leads to dyspareunia and genital urinary infection. Depression, it affects all aspects of sexual function, and this neural and vascular factors, they are also contributory, because lack of vascular condition of female genitalia leads to reduced lubrication as well as endothelial dysfunction and atherosclerosis damage, reduce engorgement of the clitoris, and leads to painful sexual intercourse. So, there are various indexes have been developed to classify or to scale the female sexual dysfunction. These are 4 common classification which is used, but they are more of an academic interest. So, the occurrence of sexual dysfunction can result in the what are the symptoms we find? It is decreased libido, low accountability, decreased vaginal lubrication, organ dysfunction and dyspareunia. Now what are the treatment approach available? So most important is optimum diabetes control, which helps in all aspect of sexual dysfunction along with lifestyle changes and psychotherapy. In perimenopausal women where the estrogen deficiency is common, we can go for estrogen replacement therapy. Even testosterone have been found to improve female sexual function, but because of the hirsutism and all that, it is not commonly used. Then rest of the therapy like cognitive behavior therapy, they are all like couple therapy. There are certain devices also available like Eros clitoral therapy device and the interim system. So as far as the testosterone is concerned, it is said that it is recommended that the postmenopausal women with hypoactive sexual disorder with or without estrogen therapy, testosterone exerts a beneficial effect on sexual function at the physiological doses. But still US FDA haven't approved androgen therapy in females. Even phosphodiesterase inhibitors, they improve the vascular congestion and improves vaginal secretions, so they can be helpful. Now this one molecule, ospemifene, it is actually estrogen receptor modulator. Actually it is not hormone, but it acts on certain part of the body on estrogen receptors. And it used to treat painful sexual intercourse and vaginal dryness in women after menopause. Same way flibanserin is 5-HT1 agonist and 5-HT2 antagonist, which improves the libido in a female, and it is helpful for women with hypoactive sexual desire disorders. So now we come to erectile dysfunction. It is well studied and it is more common. So ED is defined as a persistent failure to achieve or to maintain a penile erection satisfactory for sexual intercourse. So erectile dysfunction is common in men with diabetes, and they tend to be present with a more severity and more refractory to treatment. So erectile dysfunction is a common complication of diabetes, have a threefold more risk of developing diabetes, ED in diabetic patient than a normal individual. It occurs at earlier age, more severe, and increase with disease duration, being approximately 15% at 30 years of age and 55% at 60 years of age. And overall incidence is found in different studies from 25 to 75%. So now why ED is studied more? Because it is said that it's a marker of silent vascular disease. Even ED, if you detect ED earlier, you can diagnose hypogonadism also. So such knowledge may prevent further vascular and endothelial deterioration. So there are direct correction between erectile dysfunction and cardiovascular disease have been widely confirmed. So it is like erectile dysfunction precedes the onset of coronary artery disease by 2 to 5 years, providing great opportunity for the early diagnosis of silent coronary artery disease, stroke, and particularly in patients less than 60 years. It is said that the atherosclerosis affects the smaller arteries first and then larger arteries. So penile artery are affected earlier than the coronary arteries and all other arteries. So if you detect erectile dysfunction, then you can predict that within 2 to 5 years person can develop cardiovascular events. So it is actually complicated role of complication and cofactors. So what this statement says, the diabetes is having comorbidities as well as complication. This side is a comorbidities and this side is complication, and all this contribute to erectile dysfunction. If we just briefly see comorbidities like hypogonadism. So like it is said that the 40% of the diabetic patient may be testosterone deficient. And current guidelines says that the person with the symptoms of testosterone deficiency should be tested with total testosterone, LH, serum sex hormone binding globulins, and free testosterone. And there are various mechanisms by way the hypotestosteronemia lead to erectile dysfunction. It affects the vascular function also. It affects the insulin and leptin dependent gonadotropin releasing hormone neuron, and even vascular problems. So according to Endocrine Society, like cutoff value is 264. If you have any doubt, then go for free testosterone level. If it is less than 64, then it's a diagnostic. And you can go for penile color Doppler ultrasound to see the flow, and after treatment you can evaluate. Like obesity and metabolic syndrome. So they are pro-inflammatory conditions. They release inflammatory markers like TNF-alpha and interleukin 6, leads to endothelial dysfunction. Even obesity and metabolic syndromes can cause hypogonadism also. Hypertension. In SPRINT trial, it has been shown that men with hypertension have 60% incidence of erectile dysfunction, and there is a risk of ED increase significantly with each 10 mm increasing systolic blood pressure. Antihypertensive medicine like beta blocker and diuretic, they affect the erectile function adversely. So same dyslipidemia leads to atherosclerosis and vascular problem, can aggravate the erectile dysfunction. Even erectile dysfunction, it is a clinical manifestation of obstructive sleep apnea, and the pathogenesis is closely linked to endothelial dysfunction. So CPAP therapy, continuous positive airway pressure, which can improve oxygenation of both pituitary gland as well as corpus cavernosum, can consider as an additional treatment. First line is always phosphodiesterase, but additionally you can add CPAP therapy to sleep apnea patient. Then depression, it affects all part of sexual activity, including erectile dysfunction, reduced libido, decreased frequency, and all antidepressant, particularly SSRIs, they adversely affect erectile function. Then the complications of diabetes, like nephropathy. So nephropathy is actually independent risk factor for developing erectile dysfunction. It damages endothelial and vascular, causes endothelial and vascular damage by affecting renin-angiotensin system. Uremia leads to neuropathy, so the neuropathy itself causes erectile dysfunction, and it affects the hypothalamic pituitary gonadal axis, and it leads to primary testicular damage. Then comes the neuropathy, both peripheral and autonomic neuropathy. So peripheral neuropathy is responsible for impairment of sensory impulse from penis to reflexogenic erectile center and motor impulse to pelvic floor muscles. And autonomic neuropathy is characterized by decrease in absence of parasympathetic activity, which is necessary for relaxation of corpora cavernosa smooth muscle. Then certain other like urinary tract infection adversely affect erectile dysfunction, particularly SGLT2 worsens this condition. Then certain newer molecules have been found, like Rho associated protein kinase, then renin-angiotensin system, and TNF-alpha. They are in experimental stage, so future therapy can be directed to these molecules. So various anti-diabetic drugs and erectile dysfunction. Now metformin in various studies when combined, then meta-analysis shows that the administration of metformin resulted in improved BMI and HOMA index and international index for ejaculative function. So it has a positive effect on erectile function. Same comes the pioglitazone. It reduces insulin resistance, and it also has a positive effect on, it improves the effect of sildenafil, and it has a positive effect on erectile function. Like glibenclamide, it blocks the K-ATP receptor, and blockage of K-ATP channel has a adverse effect on erectile function. So glibenclamide probably may worsen the erectile function. Same SGLT2 inhibitor, in previous slide we show that it causes urinary infection and can adversely affect, but empagliflozin trial showed that it can positively affect the erectile function by weight loss and certain other mechanisms. So DPP4 and GLP-1. So GPP1 also improves the effect of vasorelaxation mediated vascular endothelial growth factor, and GLP-1 along with that improves the testosterone level also. So what are the treatment options at present available for erectile dysfunction? So of course lifestyle modification and glycemic control, as we show that obesity and metabolic syndrome has adverse effect on testosterone level. So lifestyle and glycemic control is a mainstay of treatment. The first line of medical treatment is phosphodiesterase inhibitors, then alprostadil, there is prostaglandin E1 application, vacuum erection devices, then penile prosthesis and penile revascular surgery. So this is chart shows the person with a cardiovascular disease and type 2 diabetes. If they are in the NOH 3 and 4, they should not advise any of this therapy because sexual activity is contraindicated in NOH grade 3 and 4. We evaluate for testosterone functions. If the testosterone are normal, then we can, first line of therapy as we discussed is phosphodiesterase inhibitors, local alprostadil, then low intensity shock wave therapy that I am going to discuss later in detail, and vacuum devices and penile prosthesis. If the testosterone are low, then obviously testosterone replacement therapy is effective. Alternatively, we can go for beta HCG treatment if person wants to preserve fertility. And of course, lifestyle modification is always recommended. So as phosphodiesterase inhibitors, they block the PDE5 and increases the cyclic GMP, leads to vasodilatation and engorgement of the penis and erection. So these are the various PDE5 inhibitors. So tadalafil has the longest half-life, and a few other three are also available, which I have not mentioned because it's not easily available here. And there is some difference in their ratio of phosphodiesterase 5 to phosphodiesterase 1 or 6 ratio. Like sildenafil has effect on phosphodiesterase 6 also. So at the peak effect, it causes slight blurring of the vision. So in that regard, they have slightly different safety profiles. Then comes the application of local alprostadil. It can be applied locally in a pellet form, of course little bit complicated, or you can give, best effect is we get from alprostadil injections. Then vacuum devices, they cause pain and skin necrosis, they are heavier devices like this. Then comes the surgical implant. This is a inflatable pump. So whenever required, you can inflate the device and then you can deflate. These are permanent penile prostheses. These are not, actually this is was most commonly used nowadays. And just I previously will just little bit go in detail about low intensity shock wave therapy. So actually shock wave therapy we are using in a kidney stone since years. But the low intensity therapy has shown results in recent years in not only sexual, actually it is designed for cardiovascular and other tissue hypoperfusion disorders, but it works well for erectile dysfunction also. So it has shown to be effective in treating ED by improving International Index of Erectile Function score and peak systolic velocity on penile color Doppler. So it has attracted great interest over the past decade. A number of controlled trial studies in the general ED population suggested modest but significant short-term benefit with minimal or no side effect. And this is the data of pooled analysis. sham control trial reported on 61 men with diabetes and ED respectively for responsive to phosphodiesterase inhibitors and another 48 who didn't respond to PD inhibitors. So clinically significant improvement in erectile function were noted in 80%, 77% and 66% at the interval of 1 month, 6 months and 12 months. So it has a longer lasting effect. And importantly, over half of the treated men who had been not responded to PD inhibitors, they have also responded. So this encouraging data merit further research, further data. Of course, there are a lot many studies are ongoing at present. So these are various clinical trials where the benefits of this low intensity therapy has proved to be effective. So in conclusion, low intensity extracorporeal shock wave therapy is safe, effective and well tolerated in the treatment of diabetes. There are 12 treatment protocols which are effective. And as we discussed, they are effective in phosphodiesterase responsive patient where it has a much more effect, and in resistant patient it has some effect. So this is the machine which is used to deliver extracorporeal shock, and you can see there are 5 sites on penis where we apply this shock. Even it has shown to be beneficial in female sexual dysfunction also. Luckily, this therapy is available in Vadodara at Ayushman Heart Center. Actually, it is originally purchased for cardiovascular patient who we cannot revascularize, having LV dysfunction or chronic angina. But beneficial effect was seen in erectile dysfunction also. So we started using in erectile dysfunction patient, and it showed, we have treated couple of patients, it showed benefit. So this is it.
Thank you, Dr. Sheval Trivedi, for a nice talk, enlightening on many points.
We will start question answer now.
You just showed 3 drugs, tadalafil. What about the abanafil? Have you got used it?
Other 3 which I haven't mentioned, but abanafil, udenafil also
abanafil is available. It is freely available. Abanafil is available.
I don't think. Just now we are.
I have used it.
Because vardenafil is available at present.
And I think.
And avanafil also available. I think that is quite
yeah.
costly, but I think that costed 304 rupees.
No, it is something around 90 rupees per tablet.
One brand, but originally is I think 400 rupees.
So I think there are some advantages over other tadalafil and other drugs.
Yeah, because of the ratio of PG5 versus PG1 or PG6 ratios.
It is considered
so
safe,
some less headache, some less blurring of vision. So that is found.
And
yes, definitely.
Also, even if you have taken alcohol, somehow it is, you can take it.
Yes,
even with alcohol. So this is a big advantage.
But tadalafil is benefit. You can use permanently low dose tadalafil for the long, and it has shown benefits in prostate patients, or and just now trials are going on that it improves the glycemia also.
You have just also mentioned about this extracorporeal wave. So can you just highlight what is the mechanism, how it works?
Actually, it generates high amplitude pressure waves. They are acoustic waves. So they are high impulse, and they peak fast and they go down fast. So they compress the tissue. Just compress and decompress the tissue. So tissue gets stressed. So when tissue is stressed, it causes neovascularization and nerve regeneration, and that's why and even that brings down the mesenchymal stem cell or progenitor cells also. That's why it helps. And cardiac patient we see lot many benefits. ED patient we have only used in couple of patients.
I think we have heard a couple of talks by Dr. Deepak Jumani. He talks lots about this arginine and some natural ingredients.
Yes.
So have you got any experience with that, and what is your opinion?
Mixed response. Like even in CKD patient also we use antioxidants and arginine and that because like they don't they are not effective as as PDE5 inhibitors.
That is true, but
that Irex is saturated with along with that methi leaves and all that that was there.
The nitric oxide generators.
Yes. So it
but
costed.
Can you suggest some natural products like I have in my patients I have found some beneficial effect with the if you are taking this pomegranates anar juice or some beets having that has got contains high level of this nitric oxide. So ultimately, if some patients is not on going for the drugs, I think the intense physical activity is very, very much important.
Exactly, because it reduces insulin resistance as well as it improves the testosterone level.
And these some of the natural products which definitely improves your endothelial health. So
actually, I have a list of natural products which can cause, but they have not shown any effectiveness in clinical trials.
Excellent talk, Sheval. Have you seen any effect of patients on anti-cholesterol medicines and the hormones going down and causing this?
So there was actually controversial data of statin and erectile function. some people say that it improves the atherosclerosis, it improves the vascularization, but it has shown negative effect also on erectile function. Definitely it has shown negative. So just now we cannot 100% sure that it is effective or it is detrimental.
सर NK सिंह सर, अब जमाना दूर नहीं कि पेशेंट आके बोलेगा किडनी वाला कि मुझे SGLT2 क्यों नहीं दिया. It is going to happen in few years time and we have to be ready for that. We have to write in the case paper why we did not give SGLT2.
It is, I think, nice comment and futuristic comment. But only thing that still I will tell you that when you start SGLT inhibitors, assess your patients. There are some contraindications for also that. It is not a panacea for all the things. So see the BMI, because we don't have data. Suppose BMI is 19 or 18, there is problems. Or patient can develop glycemic diabetic ketoacidosis in certain situations. And even today also in circulation there is a big paper coming that says that even in type 1 diabetes, although it is very, very beneficial, but there are lots of things before you assess about the things that the patient is monitoring with the ketometer or keeping watch on the ketosis, you should not. Or if patient is from rural area cannot monitor, you don't use it. So at least there are some precautions for SGLT2 inhibitors that should be taken care of. Well, it is not a right and left drug, like other drugs also. So there are some safety issues there also. So I think, but anyway, in those who are eligible, and if you don't write, they will claim, definitely. Yeah. Regarding UTI, in most of the real world studies, UTI is a very common problem with the SGLT2 inhibitors. I have found that around 10 to 12 persons basically they develop, but again it differs from Delhi area where there is some more humid climates to our climates according to the intake of water. But remember, most of cases I have never stopped it. You continue it. If there is UTI, you treat it and let it continue. But definitely, there was recently one patient. Whenever I started SGLT2 inhibitors, he developed UTI. वो उसको दिमाग में हो गया सर इसको मत लिखिएगा. And she was a very fatty lady, and she was on around 80 units of insulin, all 4 drugs, still not controlled. Then this came the semaglutide tablet, Rebelus, and although this is, it is a one tablet is costing around 320 rupees. तो मैंने उससे पूछा कि can you take it? वो बोली पहले तो बोली कि सर आप तो मेरा बजट पूरा खराब कर दोगे, लेकिन उसके हस्बैंड ने कहा कि ठीक है मैं गहना इसको नहीं खरीदूंगा, इसका अगर वजन, मैंने बोला उसको कि वजन घटेगा 5 से 6 किलो, इसको याद रखो. Really I was surprised after 2 months. He messaged me, my weight has reduction 5 kg, 2 months. Insulin dose reduction, and first time achieved normal HbA1c. So this is really a good drug, I think. So regarding the JTI, you should keep watch. If there is some genital infection in that way, that we have to stop it, but very, very rare. It is not so common, but still in some studies from the Amrish Mittal group, I think from Delhi, it is something around 20% or 22%. But I have found around 8 to 12% in my area. Not much. You can use all 3 approved drugs, DAPA, canagliflozin, or this empagliflozin. Even today we are using more DAPA because the cost reduction is too much. Generic is available, 10 rupees, 8 rupees, 9 rupees. So any comment from Dr. Jethwani also?
No, I totally agree with Dr. NK Singh, sir. UTI is not that common, but GTI, genital mycotic infections, they are quite common. And you have to be very careful, particularly when you are using it in younger individuals. You have to counsel them very much about genital hygiene, because that will be having a very detrimental effect on their quality of life.
So I think any more questions? If you UTI, you're asking what UTI, you can tell.
I think in diabetes there are many patients who are having chronic UTI, persistent culture positive. These are the patients where probably we should avoid these medications if there is flare-up of UTI. Otherwise, we can safely give them. Once UTI is there, you can give them proper antibiotic, correct it, and either you can reduce the dose or withdraw for a time being, and reintroduce it again. But particularly people, elderly people who are having BP, obstructive uropathy, or particularly in coastal areas where renal stone is very common in our part of world, there you have to be cautious while using this molecule, because these individuals, they are at high risk of development of UTI, AKI, and all the issues of kidney problem.
I think Dr. Jethwani has beautifully shown that extra renal and extra cardiac benefits of the SGLT inhibitors, some reduction in hypertension, even the very significant reduction of the uric acid, hyperuricemia. So that is a big thing. I think again another thing are OSA, obstructive sleep apnea. The EMPIREC trial, again the exploratory analysis has shown, last year ADI presented, that there was a significant benefit with the reduction in the all parameters of the OSA. So that is also a very important thing. So I think they have got multiple benefits with the SGLT inhibitors. Now even although most of our nephrologist patients, nephrologist colleagues, they are using it in a non-diabetic cases also. Like in the heart failure cases, even the preserved ejection fraction, I think this is the best molecule at present available to you. The best data is with the SGLT inhibitors. So these are few things with the SGLT inhibitors. So I think the time has come that we see changed our mindset. Initially when this molecule came, लोगों ने bombard कर दिया कि इसमें ये होगा, इसमें वो होगा, इसमें वो होगा. But I have also the best man on the SGLT inhibitor from the Canada. I have many time interactions. उसने मेरे को बोला कि तुम भाषण जब भी देना तो जरूर बोलना कि इससे ज़्यादा कुछ नहीं होता है. Don't worry for the GTI, don't worry for the UTI. Keep watch on that, treat it. In a few selected cases, you have to stop it. Otherwise, you continue it.
I think in near time, SGLT2 will be like metformin. Your type 2 diabetic patient should be on metformin unless and until there is contraindication. The same will apply for SGLT2 also.
Dr. Patni, can you any comment on that?
Dr. Trivedi is also.
Yeah, Dr. Trivedi is there. Come, sir. Please come.
I think already have been said much about SGLT2 inhibitors. Agree. So basically what we got from the two talks, that you need to introduce SGLT2 in each and every Indians at least. He might say that there are certain precautions which need to be taken into. Precautions is later. First is prevention, right? So each and every individual of Indian population should be on SGLT2 as per Dr. Prakash Jethwani or Dr. N.K. Singh. But I don't think so, right? Correct? So it's not panacea for all, correct? What I think is, when you're managing type 2 diabetes or a pre-diabetes, at least at the pre-diabetes stage, some pharmacological therapy need to be introduced in order to cut down on the epidemiology, right? So this is one such drug. Along with that, I too believe if finance has not been an issue, GLP-1 receptor agonist would have been equally good, at least in the prevention or progression from pre-diabetes to diabetes. This is my thought. And every individual who is financially viable, the initiating drug should be, if the patient needs a triple drug, it should be metformin, a GLP-1, and a SGLT.
Franjo regime is coming on, that is apart different from the ADA and AS guidelines. So that also says that metformin or pioglitazone plus SGLT inhibitors plus GLP-1 are agonist. But simple point is, if patient is suffering from atherosclerotic cardiovascular disease, the first choice would be the GLP-1 RA. Heart failure, hospitalization, if you want to check, or some reduction in the MACE, go for the SGLT inhibitors. It is very cheaper now in comparison. So this point should be also taken that it is a cheap drug now.
You see, if you remember the 2019 guidelines of the European Society of Diabetes, if you remember the 2019 European Society of Cardiology guidelines, here they had mentioned about the anti-diabetic drugs, first drug as SGLT2 inhibitor rather than metformin. Somehow or other, there is all political pull, push, everything, and whatever Europe is doing, US will be exactly opposite to that. And they change. And they change the things again. Sorry.
It's okay, no, sorry.
Namaskar, pranam. So in that reference, again the guidelines were changed and metformin came as the first line. So metformin followed by SGLT2 inhibitor. So it's a tug of war, but then it does deserve a place and it is going to be very important as things I've said. Thank you.
So last comment I will tell, maybe not in all diabetic patients, but where it is indicated, please start it, where it is indicated. I don't go for that debate now. You can use anyone. We have if you want for the reduction for total mortality, the best data is with EMPA. If you want to tell for the primary prevention of MACE, heart failure, I think the DAPA has a bit here also for primary prevention, according to the different CVOT trial, the better data is with the dapagliflozin. But otherwise, you can use any of three.
Thank you, sir. Thanks a
Yeah,
lot.
thanks. Everyone will proceed with the inauguration ceremony. Inauguration of the conference and book launch ceremony. I am Dr. Kamaldeep Chawla. I am a cardiologist working with Sterling Hospitals. May I invite Dr. Mitesh Shah, President IMA Vadodara, Convener BJP Cell Central Gujarat, Senate and Syndicate Member MS University. Forget, he is my batchmate. Yeah. May I invite Dr. DP Khaitan sir, past President CCDSI on stage. Sir is a veteran in the field of cardiodiabetes and he needs introduction in Vadodara, but he needs no introduction in India. May I invite Dr. Abhiram Kulshresh sir, Director General of National Institute of Education and Research, New Delhi, a doyen in the field of education and has his own deemed university. Dr. Ranjan Iyer sir, MS, Medical Superintendent, SSG Hospital. I think he's busy in operation at this moment of time. May I have special invitees? Dr. B.K. Soni sir, President, Association of Physicians of Vadodara on stage. Dr. Bijay Patni sir, President, Diabetes Research and Welfare Association. I would like to invite Dr. Sailesh Trivedi sir to represent the physicians of Vadodara on stage. May I invite Dr. Dhiren Patel sir, President, Association of Physicians of India, Gujarat chapter on stage. And another special invitee, Dr. N.K. Singh sir, Head CME India, Group Lead, Researcher, Academician, and National Faculty in Diabetes and Cardiometabolic Diseases. Dr. Shalini madam has reached? Not yet, okay. So I would like to introduce my team IDCM, Dr. Dishank, Dr. Sushil Patel, Dr. Anuradha Kapoor, and Dr. Akash Singh just come to have a photograph with the dignitaries, and may I have the corporate video of IDCM? are waiting for Madam Shalini Agrawal, our guest of honor, chief guest, to be present. I think I'll request Maharaj Shri to bless us and honor us with few words on this occasion.
ओम सहना भवतु सहनौ भुनक्तु सह वीर्यं करवावहै तेजस्विनावधीतमस्तु मा विद्विषावहै ओम शांति शांति शांति. I'm glad that I'm here today. IDCM has invited us for this event. We are waiting for Collector Shri, Dr. Rajan Iyer, Dr. Khetan Bhai, Dr. Mitesh Shah, Dr. Kulashrestha, Dr. B.K. Soni, Dr. Patni Dhiren Bhai Patel, and Dr. N.K. Singh. Dr. Akash Kumar Singh, Dr. Kamal Deepji, Dr. Anuradha Kapoor and Dr. Dishank Patel, आप सभी ने हम सभी को यहाँ आमंत्रित करके, और आप सब तो अपने अपने प्रोफेशन से, अपने अपने बैकग्राउंड से, अपने अपने क्वालिफिकेशन से, जिस जिस क्षेत्र में आप कार्य करते हैं, आप सभी यहाँ उपस्थित हैं. सिर्फ मैं एक अनाड़ी हूँ इसमें, जिसमें मैं आपके क्षेत्र से नहीं और अपनी बात कहने जा रहा हूँ. Like we know that previously it was IQ, then we got the concept of EQ, then later on we got the concept of SQ, intelligence quotient, emotional quotient, and then spiritual quotient. Accordingly, sometimes I think that there are three kinds of diseases in the world. One is physical, second is emotional or psychological, and third is fortunal. It was in my fortune, it was not in my fortune. Like तनरोग, मनरोग और भवरोग. तनरोग जो फिजिकल है, मनरोग जो साइकोलॉजिकल है, और भवरोग जो फॉर्चुनल रूप से हम जिसका स्वीकार करते हैं. And if you want to find the solution of these three of them, of course, when we talk about the physical diseases, we comes to you. When we talk about manarog, psychological diseases, either we go to psychiatrist or we go for some meditation therapy or something. और तीसरी बात, fortunal disease, we start doing our spiritual practices to change our प्रारब्ध ने बदलवा माटे. गुजराती में कहते हैं ना कि हम अपनी डेस्टिनी को प्रारब्ध ने बदली शकाय एवी ताकत सेमा छे, तो we do prayers. तो we go for that spiritual quotient. तो जो बात दवा से हो न सके वो बात दुआ से होती है. जो बात दवा से हो न सके वो बात दुआ से होती है. और सफल गुरु जब मिलता है तो फिर बात खुदा से होती है. गुरु का मतलब सिर्फ मैं जो पहन के बैठा हूँ या तिलक चांदलो करीने कोई बैठो हो, गले में माला हो, वही गुरु नहीं हो सकता है. अकॉर्डिंग टू हिंदू फिलॉसफी, जिस किसी से आप कुछ नया सीख सकते हैं, जिस किसी से आप कुछ पा सकते हैं, जिस किसी से आपने कुछ पाया है, वो आपका गुरु है. जिस मेडिसिन के बारे में आपको मालूम नहीं है और कोई सीनियर डॉक्टर, कोई एक्सपीरियंस डॉक्टर आपको उस मेडिसिन के बारे में बात करता है, उसी क्षण वो डॉक्टर आपका गुरु बन जाता है. और यही सुंदरता है, यही सुंदरता है इस पूरे मिशन की. और जिस प्रकार से कार्डियक डिसीज़ को लेकर, डायबिटीज़ को लेकर इन चारों महानुभाव डॉक्टरों ने जिस तरीके से अपना ये अभियान प्रारंभ किया, और इस पूरे अभियान में जिस प्रकार से IDCM के माध्यम से हम सभी ने एक विशेष प्रसंग में आज उपस्थित होकर अपनी प्रसन्नता व्यक्त की है। मैं अपने शब्दों को जब आगे ले रहा हूं, मैं श्रीमती शालिनी बेन अग्रवाल का भी बहुत बहुत स्वागत कर रहा हूं। आपका भी मंच पे स्वागत है। तो तनरोग, मनोरोग और भवरोग की हम बात कर रहे थे। तो जब तनरोग होता है तब हम डॉक्टर्स के पास जाते हैं, मनोरोग होता है हम साइकेट्रिस्ट के पास जाते हैं या किसी स्पिरिचुअल गुरु के पास जाकर मेडिटेशन प्रैक्टिस को सीखते हैं। और फॉर्चुनल जो रोग होते हैं उसके लिए हम रिलीजन और स्पिरिचुअलिटी, हम दोनों अलग अलग बातें हैं। जैसे पर्सनालिटी एंड कैरेक्टर, दे बोथ आर डिफरेंट थिंग्स। पर्सनालिटी इज व्हाट यू सीम्स बट कैरेक्टर इज व्हाट यू आर। ऐसे ही धर्म जो है और आध्यात्म, रिलीजन एंड स्पिरिचुअलिटी, धर्म जो ग्रंथों में लिखा गया है वो है, और व्हेन वी एग्जीक्यूट दैट philosophical aspects in our day-to-day life as a practice of religion, it becomes a spirituality. तो आज के समारोह में जब ग्रंथ विमोचन के लिए मुझे बुलाया गया, दीप प्रागट्य बाकी है आप सभी के बीच में, मैं अपने इन 2 शब्दों के द्वारा ही अपनी प्रार्थना आप सभी के लिए, प्रभु आपको यश प्रदान करे। जितने भी मेडिकल फील्ड के आप सभी यहाँ उपस्थित हैं, प्रभु आपके कार्य को यश प्रदान करें, ऐसी प्रार्थना कर रहा हूँ। मैं किसी हॉस्पिटल के ओपनिंग में गया था, मुझे कहा कि आप आशीर्वाद दीजिए। मैंने ये कहा कि मैं बहुत आपका हॉस्पिटल अच्छा चले, ऐसा तो मैं नहीं कह सकता हूँ। इसका एक अर्थ ये होता है कि समाज में ज़्यादा बीमारी फैले, लेकिन इतना ज़रूर कह सकता हूँ कि जिस किसी मरीज़ के इलाज करने का सौभाग्य आपको प्राप्त हो, आपकी आंगुलियों में इतना यश ईश्वर प्रदान करे कि उसका रोग दूर हो। यही मेरी आप सभी के लिए प्रार्थना। शुभम भवतु। थैंक यू।
I take this opportunity to welcome on dais Ms. Shalini Agrawal, IAS, Commissioner, Vadodara Municipal Corporation. May I request all dignitaries and all delegates to please stand, and we'll have a national anthem.
विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मागे, गाहे तव जय गाथा, जन गण मंगल दायक जय हे, भारत भाग्य विधाता जय हे, जय हे, जय हे, जय 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 हे।
Thank you. So we'll proceed with the proceedings of the day. May I request all dignitaries to please come forward for lamp lighting ceremony.
या वीरा
सम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you, Maharaj Shri. Thank you, Madam. Thank you, all dignitaries on stage. IDCM as an organization has been associated with propagation and awareness of diabetes and cardiometabolic diseases. But we also conduct several courses. And I would like to use this opportunity to hand over certificates of a second batch of students who have cleared their eco course. So may I request Dr. Abhiram sir, Director General NIER, Dr. Khetan sir and Dr. Mitesh Shah to please hand over to our 3 students. So Mitesh Patel, Milap Shah and Ashish Patel. Madam is receiving her the degree on behalf of Ashish Patel. She is receiving on behalf of Ashish sir. Dr. Mitesh Patel. And Dr. Milap Shah. Thank you, sirs. So, moving forward, yesterday we had a marvelous session of paper presentations. Original research done by students and faculties in and around Baroda. It was a competitive session wherein there were 25 entries which were received, and we are going to honor the top 2 entries. So may I request the students, Dr. Komal Rana, who presented her paper, Prevalence of NAFLD in Type 2 Diabetes Mellitus, and she comes from Parul University. Is she there? Please, madam. So there's a joint winner along with Dr. Rana Malde Bhutia, who received first prize along with Madam, study of clinical profile of patients with peripartum cardiomyopathy, and he comes from SSG Hospital. May I request Dr. Patni sir, Dr. Dhiren Patel sir to please honor the prize winners. Yeah, the first prize winners. दूसरे का I think students will like what we are giving you. Yeah. So may I request Dr. Sailesh Trivedi sir, Dr. N.K. Singh sir and Maharaj Shri and Madam to please honor the second prize winners. Again, there's a tie for the second prize also. So it's Dr. Pratishtha Srivastav. She presented a paper, Study of Cardiovascular Manifestations of Autonomic Neuropathy in Diabetic Patients. And the joint win, she comes from SSG Hospital. And Pratashri Patel, who presented the paper, Study of LV Systolic Function in Iron Deficiency Anemia by Echo. There was a difference of only 0.5 marks between the first and the second positions. Thank you, students, for participating. We go on to the important section of today's ceremony, the book release written by Dr. Akash Singh, Dr. Anuradha Kapoor and myself, textbook of diabetes. And may I invite dignitaries Maharaj Shri Dwarkesh Lalji and Madam Shalini Agrawal to please release the book. And can we have the e-version on the screen, please? We are truly motivated and blessed by everyone's presence on stage, on dais, in the hall. And thank you all. We are truly motivated and feel blessed. May I request Madam Shalini Agrawal to speak a few words on today's occasion.
આજના કાર્યક્રમમાં ઉપસ્થિત દ્વારકેશ મહારાજજી, મંચ ઉપર ઉપસ્થિત તમામ મહાનુભાવશ્રીઓ અને અહીંયા ઉપસ્થિત તમામ મહાનુભાવશ્રીઓ. I forgot that it's a national conference. Huh? I have to speak in Hindi or English? Hindi. Okay, good. आज का ये कार्यक्रम बहुत स्पेशल है क्योंकि मुझे जो इन्फॉर्मेशन दी गई है उसके मुताबिक इंडिया में सबसे पहली नेशनल कॉन्फ्रेंस डायबिटीज़ और कार्डियो मेटाबॉलिक डिजीज़ एसोसिएशन द्वारा फर्स्ट नेशनल कॉन्फ्रेंस कोविड के बाद में फ़िज़िकल हो रही है और इसकी जो शुरुआत है वो वडोदरा से हुई है. तो सबसे पहले तो मैं वडोदरा की लोकल टीम को खूब खूब हार्दिक अभिनंदन देती हूँ कि वडोदरा के लिए ये एक प्राउड मोमेंट है कि आप फर्स्ट नेशनल कॉन्फ्रेंस को होस्ट कर रहे हैं. दूसरा, ये जो सब्जेक्ट है डायबिटीज़ एंड कार्डियोमेटाबॉलिक डिजीज़, आई थिंक गुजरात इज़ द बेस्ट प्लेस जहाँ पे कि ये कॉन्फ्रेंस की शुरुआत हुई है क्योंकि पूरे भारत देश में सबसे ज़्यादा जो केसेस डायबिटीज़ के होते हैं वो मोस्टली गुजरात से ज़्यादा होते हैं. और तीसरा, ये कॉन्फ्रेंस इसलिए भी इम्पॉर्टेंट है कि कोविड के पहले और कोविड के बाद जो कॉन्सेप्ट है हेल्थ का वो बहुत ड्रास्टिकली चेंज हुआ है. आई थिंक नाउ वी आर टॉकिंग अबाउट वेलनेस. और जैसे महाराज जी बोल रहे थे, हम सुन रहे थे और सोच भी रहे थे कि वेलनेस इंक्लूड्स ओवरऑल पर्सनालिटी एंड ओवरऑल वेलबींग ऑफ अ पर्सन, जिसमें कि आपका स्पिरिचुअल वेलबींग भी हो गया, साइकोलॉजिकल वेलबींग भी हो गया, फिजिकल वेलबींग भी हो गया. नाउ वी आर ऑल्सो टॉकिंग अबाउट एप्टीट्यूड एंड एटीट्यूड. तो एक पॉजिटिव जो जीवन में सकारात्मकता की ज़रूरत है, तो उन सब को लेके एक मनुष्य का संपूर्ण और सर्वांगी विकास, उसको लेके अब हम वेलनेस की बात करते हैं. जबकि कोविड के पहले मेरा एडमिनिस्ट्रेशन का जितना भी एक्सपीरियंस है हेल्थ में, वी यूज्ड टू टॉक अबाउट हेल्थ की जब बात आती थी तो इम्यूनाइजेशन, वैक्सीनेशन, वेक्टर कंट्रोल मेजर्स, वाटर कंट्रोल मेजर्स. कॉमन लोगों के लिए यदि हेल्थ की बात करते थे तो हॉस्पिटलाइजेशन, एलोपैथिक ट्रीटमेंट, आयुर्वेदिक ट्रीटमेंट, ज़्यादा से ज़्यादा होम्योपैथिक ट्रीटमेंट. बट कोविड के बाद में सडनली पीपल हैव स्टार्टेड रियलाइजिंग कि हम लोग सुबह उठ के और रात को जब तक सोते हैं तब तक का हमारा हर एक थॉट और हर एक एक्शन बहुत इम्पॉर्टेंट है. और लॉन्ग रन के लिए हमें जीवन में हैप्पीनेस, सेटिस्फैक्शन एंड एट द सेम टाइम पॉजिटिविज्म होना बहुत ज़रूरी है. और कोविड ने पूरा समाज, पूरे विश्व का एक दृष्टिकोण बदला है. गवर्नमेंट ऑफ इंडिया और ऑनरेबल प्राइम मिनिस्टर साहब की बात करें तो उनके 2-3 मूवमेंट्स हमें बहुत अच्छे लगते हैं. एक तो फिट इंडिया मूवमेंट, और हमें ये भी कहने में बहुत प्राउड है कि द्वारकेश महाराज जी यहाँ पर हैं, आप सभी अग्री भी करेंगे कि भारत देश संपूर्ण विश्व में जो नेचुरल जो ट्रीटमेंट प्रोसेसेस हैं, स्पेशली आयुर्वेदिक और होम्योपैथिक और अदर जो नेचुरल ट्रीटमेंट प्रोसेसेस हैं, उसमें भारत के पास में बहुत ज़्यादा विस्तृत भंडार है. और शुरू से ही भारत पूरे देश में इस दिशा में खूब सर्वोच्च स्थान भारत देश का है. पर उसमें भी एक जो सबसे ज़्यादा गर्व लेने वाली बात है कि योगा, जिसको अब यूनाइटेड नेशंस, संयुक्त राष्ट्र संघ ने इंटरनेशनली रिकॉग्नाइज़ किया है और इंटरनेशनल योगा डे की तरह से एक दिन डेडिकेट किया जाता है. और हर साल बहुत ही लार्ज नंबर्स में लोग जो है उसमें जुड़ रहे हैं. और इस बार का जो थीम था वो भी बहुत इंटरेस्टिंग थीम था. इस बार पूरे वर्ल्ड में एक रिंग बनाई गई थी कि जिस जिस देश में सूर्योदय होगा उस देश में वहाँ पर योगा से शुरुआत होगी. तो जैसे सन का मूवमेंट हो रहा था, वैसे योगा के जो कार्यक्रम थे उसका मूवमेंट हो रहा था. और पूरे विश्व में एक योगा की रिंग बनाई गई थी. कहने का मतलब ये है कि भारत देश शुरू से ही हेल्थ, ट्रीटमेंट और प्रिवेंटिव जो मेजर्स हैं उसमें उसके पास में बहुत ज़्यादा भंडार है. और पहले भारत देश को जाना चाहता था स्पिरिचुअल ट्रीटमेंट के लिए, और बहुत सालों से, बहुत वर्षों से स्पेशली जो वेस्ट है, पाश्चात्य संस्कृति है, उसके लाखों फॉलोअर्स भारत में आकर सत्संग सुनते हैं. यहाँ के धर्म गुरुओं का जो सत्संग से उनको जीवन में पॉजिटिव एनर्जी लेते हैं. और बहुत सारे अनुयायी पूरे भारत देश में ऐसे हैं जो बाहर से आए हुए हैं और बहुत सालों से यहाँ पर स्पिरिचुअल पाथ को फॉलो कर रहे हैं. अभी मैं 8-10 दिन पहले एक यहाँ के बहुत ही प्रख्यात संस्थान में गई थी. महाराज जी आप शायद जानते होंगे, स्कॉन का यहाँ पर जो लोकल देखते हैं वो अमेरिका से हैं और लास्ट 35 साल से वो हिंदी इतना अच्छा बोलते हैं. पूरे फॉरेनर हैं, अमेरिका के हैं, पर पूरा हिंदी में बात करते हैं. और संस्कृत में उन्होंने मुझे 10 मिनट तक कंटिन्यूसली संस्कृत में बात की और इतनी सुंदर संस्कृत की भाषा में बात की कि हमें लग रहा था कि हमें इतनी कभी संस्कृत हमने इतने अच्छे से पढ़ी नहीं जितना इनको अच्छे से संस्कृत आती है. तो कहने का मतलब ये है कि भारत पूरे विश्व को विश्व गुरु की दिशा में ले जा रहा है. और स्पेशली 21st सेंचुरी जो नॉलेज की सेंचुरी है, स्किल की सेंचुरी है, टेक्नोलॉजी की सेंचुरी है, उसमें भारत देश स्पिरिचुअल पाथ सबके सामने प्रदर्शित कर रहा है. फिजिकल पाथ सबके सामने प्रदर्शित कर रहा है। और ख़ास करके मैं गुजरात को अभिनंदन देना चाहती हूँ कि मेडिकल टूरिज़्म के क्षेत्र में गुजरात जिस तरह से पूरे भारत देश में आगे उभर के आ रहा है, और हर एक क्षेत्र, डायबिटीज़ हो, कार्डियोलॉजी हो, ऑर्थोपेडिशियंस हो, या फिर कैंसर हो, या किडनी ट्रांसप्लांटेशन हो, या लिवर ट्रांसप्लांटेशन हो, हार्ट के बहुत बड़े बड़े इंस्टीट्यूट्स हैं, अच्छे इंस्टीट्यूट्स हैं। पूरा गुजरात में आपको हर एक सिटी में सेंटर ऑफ एक्सीलेंस हेल्थ के मैनेजमेंट में मिलेंगे, जहाँ पर कॉस्ट इफेक्टिव ट्रीटमेंट के लिए पूरे विश्व भर से लोग आकर यहाँ पर ट्रीटमेंट करवा रहे हैं। और काफ़ी तो ऐसे प्रख्यात हॉस्पिटल्स हैं जिनके पास में हेलीपैड्स हैं, जहाँ पे कि बाहर से फॉरेनर्स आके और बहुत ही कॉस्ट इफेक्टिव ट्रीटमेंट करवाते हैं। और जिस तरह से गुजरात के हॉस्पिटल्स में टेक्नोलॉजी का अपग्रेडेशन होता रहता है, स्किल्स का अपग्रेडेशन होता रहता है, जो नॉलेज शेयरिंग है, मेडिसिन्स में जो नए नए इनोवेशंस होते रहते हैं, वो काबिले तारीफ़ है। और गुजरात बहुत स्ट्रॉन्ग प्रेजेंस पब्लिक हेल्थ मैनेजमेंट एंड प्राइवेट हेल्थ मैनेजमेंट में बहुत स्ट्रांगली सामने उभर के आ रहा है। और अभी पूरा भारत देश, अपन ने कोविड में देखा कि भारत अकेला ऐसा देश था जिसने कि करोड़ों की संख्या में इंडिजीनियस कोविड वैक्सीन बनाकर और करोड़ों की संख्या में मास कोविड वैक्सीनेशन शुरू किया। और ना केवल भारतवासियों के लिए पर पूरे विश्व के लिए वो कोविड वैक्सीन सप्लाई करी गई। और जिस तरह का कोविड वैक्सीन अभियान लास्ट 2 इयर्स में, लास्ट 2 इयर्स भी नहीं बोलूँगी, जब सेकेंड वेव में जब शुरू हुआ था तो 1 साल के अंदर अंदर बहुत मास जुम्बिश स्वरूप में फर्स्ट और सेकेंड डोज कोविड में दिए गए थे। तो उसके कारण एक जो कोविड में अभी जो लड़ने से सफलता हासिल हुई है, उसमें कोविड वैक्सीनेशन का खूब बड़ा योगदान है। और जिस तरह की प्रिपेयर्डनेस प्राइवेट हॉस्पिटल्स और पब्लिक हॉस्पिटल्स, गवर्नमेंट हॉस्पिटल्स पूरे भारत देश में कोविड के टाइम पे जिस कैंपेन मोड में बेड्स का मैनेजमेंट हो, या डॉक्टर्स का मैनेजमेंट हो, या स्टाफ का मैनेजमेंट हो, आज आप पूरे भारत देश से आप सब यहाँ पे मेडिकल फ्रेटर्निटी उपस्थित है, मैं आप सबको बहुत सल्यूट करती हूँ और बहुत अच्छे से आपको अभिनंदन भी देती हूँ कि कोविड के टाइम पे जिस तरह से फ्रंट लाइन वर्कर्स ने, डॉक्टर्स ने, स्टाफ, हेल्थ स्टाफ ने खुद की जान की परवाह किए बिना, स्पेशली फर्स्ट वेव में जो सबसे ज़्यादा टिपिकल थी और कुछ नहीं पता था कि क्या करना है, उसमें जिस तरह से हिम्मत दिखा के सब लोगों ने काम किया। और इंडिया पूरे भारत देश में बहुत ही वेल मैनेज्ड कंट्री था, जहाँ पर गवर्नमेंट हॉस्पिटल्स और प्राइवेट हॉस्पिटल्स ने एकजुट होके पूरी ताकत लगा दी थी और बहुत अच्छे से कोविड को मैनेज किया था। तो उसके बाद से अभी लोगों में अवेयरनेस भी बहुत ज़्यादा हुई है। और न्यूट्रिशन, किस तरह का खाना खाना चाहिए, किस तरह का आपको विचार आने चाहिए, उन सब के ऊपर अब लोग ध्यान दे रहे हैं। और गवर्नमेंट ऑफ इंडिया, गवर्नमेंट ऑफ गुजरात भी अब हॉस्पिटल्स की बात नहीं कर रहे हैं, अब उससे एक स्टेप आगे चले गए। और अभी जो नया कॉन्सेप्ट आया है प्रधानमंत्री आयुष्मान हेल्थ योजना अंतर्गत, वो है हेल्थ एंड वेलनेस सेंटर। तो हेल्थ के साथ साथ पूरा जो ओवरऑल वेल बीइंग है वो बहुत ज़रूरी है। कहते हैं कि वी हैव टू टेक केयर ऑफ़ द बॉडी बिकॉज वी लिव इन एवरी सेकेंड ऑफ आवर लाइफ। तो आपके थ्रू मुझे लगता है डायबिटीज़ और स्पेशली कार्डियोलॉजी में तो बहुत ज़्यादा ज़रूरी है कि जो वे ऑफ लाइफ है उसके ऊपर ज़्यादा एम्फेसिस किया जाए, प्रिवेंशन के ऊपर ज़्यादा एम्फेसिस किया जाए। इसलिए आप लोगों का जॉब और भी ज़्यादा डिफ़िकल्ट है, बिकॉज ये ऐसी डिजीज़ेज़ हैं जिसमें कि लाइफस्टाइल डिजीज़ेज़ हैं और उनके लिए अवेयरनेस बहुत ज़्यादा करनी होती है। इतना मैं आपको अश्योर करना चाहती हूँ कि गवर्नमेंट की तरफ से बहुत सारे अवेयरनेस कैंप्स, अवेयरनेस मटेरियल्स पूरे गांव-गांव में नहीं, शहर के हर एक विस्तारों में किए जाते हैं। और आप और गवर्नमेंट यदि साथ में मिलके करेंगे तो मुझे लगता है कि ट्रीटमेंट से ज़्यादा प्रिवेंशन के ऊपर फोकस करके पूरा जो एक लाइफस्टाइल है वो यदि चेंज किया जाए, और जो पुराना लाइफस्टाइल था जब लोगों के पास में गाड़ियाँ नहीं थी तो चल के जाना अच्छा लगता था, साइकिल पे जाना अच्छा लगता था, बारिश में भीगते हुए जाना अच्छा लगता था। अब आपको 100 मीटर भी जाना है तो हम लोग स्कूटी ढूंढते हैं या कार ढूंढते हैं। पहले हर काम हम लोग खुद हाथ से करते थे हमने हमारे घरों में चक्कियाँ देखी हैं, बट हमारे बच्चे हैं उन्होंने नहीं देखी हैं। सब कुछ काम ऑटोमेटिक होता है। पहले हमारी मम्मी वगैरह कपड़े धोती थी, बैठ के धोती थी, बट अब उसकी ज़रूरत नहीं है, वॉशिंग मशीन है। तो बहुत सारे लाइफस्टाइल चेंजेस हैं, पर एट द सेम टाइम वी हैव टू फाइंड अ वे आउट कि क्या खाना है, क्या पीना है, कैसे जीना है, और वो ज़्यादा इम्पॉर्टेंट है। तो आप इस तरह से आज आके आपके फील्ड में नई नई टेक्नोलॉजी, स्किल, नॉलेज जो शेयर कर रहे हैं, उसके लिए बहुत अच्छा आपका ये कॉन्फ्रेंस आयोजित किया है। इसके लिए आपको खूब खूब अभिनंदन देती हूँ। बट साथ में हम सब मिलके, गवर्नमेंट और प्राइवेट सेक्टर मिलके वापस से हम एम्फेसिस कर रहे हैं कि प्रिवेंटिव केयर के ऊपर फोकस करके और एक वे ऑफ लाइफ एंड ए क्वालिटेटिव वे ऑफ लाइफ डेवलप किया जाए, इसके लिए भी साथ में मिलके प्रयत्न करें। और द्वारकेश महाराज जी जैसे जो धर्मगुरु हैं, महाराज जी, हम बोलना चाहते हैं कि ये जो 21st सेंचुरी है, उसमें सबसे बड़ी जो त्रासदी है वो विचारों की त्रासदी है। विचार शून्यता की त्रासदी है, अथवा तो नकारात्मक विचार हैं, और पूरा जो विश्व है वो विचारों का विश्व है। आप यदि सकारात्मक हैं तो आपको पूरा विश्व सकारात्मक दिखेगा, बट इफ़ यू हैव नेगेटिव थॉट्स तो आप हर चीज़ में नेगेटिविटी देखेंगे। बहुत फास्ट लाइफ है 21st सेंचुरी की। सिंपल प्रॉब्लम्स हैं बट लोगों को बहुत कॉम्प्लेक्स लगती हैं। उन सब सिचुएशंस के बीच में आप लोगों से जो पॉजिटिविज्म सोसाइटी को मिलता है, और उसके कारण स्पेशली जो भारत, अभी तो वो चाइना की भी पॉपुलेशन क्रॉस करने वाला है और सबसे ज़्यादा पॉपुलस कंट्री भारत होने वाला है। तो उसके लिए हमारे एक जो बहुत बड़ी जो हमारे में शक्ति है, वो आप सबके भी पॉजिटिव विचार और आप सबका जो एक बहुत अच्छा ज्ञान है, उन सबको लेके हम लोग खूब आगे बढ़ते हैं। तो स्पिरिचुअल, टेक्नोलॉजी एंड हेल्थ एंड गवर्नमेंट, यदि सब लोग मिलके साथ काम करेंगे तो भारत विश्व गुरु बनेगा, और डेफिनेटली बनेगा। थैंक यू सो मच।
Thank you, ma'am. Thank you so much. A brief point to touch upon madam's wisdom. Ma'am, as medical fraternity of Baroda, we are really waiting for the bullet train. Ek minute, ma'am. We are not seeing our patients going to Bombay now. We are seeing... Yes. Yeah, please, ma'am.
I take proud in bullet train, क्योंकि गुजरात में जब बुलेट ट्रेन का लैंड एक्विजिशन शुरू हुआ तो बहुत सारा विरोध शुरू हुआ और हाई कोर्ट में बहुत सारे लिटिगेशंस चले गए, और इसलिए कोई भी डिस्ट्रिक्ट बुलेट ट्रेन का लैंड एक्विजिशन नहीं कर पा रहा था। व्हेन आई वाज कलेक्टर वडोदरा, हम लोगों ने उसको स्ट्रेटेजाइज किया, और प्रमुख स्वामी का एक गांव है चाणसद गांव, वहाँ पर हम लोगों ने एनआरआईज़ को बुला के उनको समझा के उनकी ज़मीनों को संपादन करना शुरू किया, और उसको नेशनल और स्टेट लेवल के पब्लिसिटी करना शुरू किया। और उन लोगों ने फिर अपने आसपास के गांवों को समझा कर बहुत सारा लैंड एक्विजिशन करवाया, और आई प्राउडली से कि वडोदरा वाज द फर्स्ट डिस्ट्रिक्ट विच कंप्लीटेड 100% लैंड एक्विजिशन फॉर वडोदरा। तो हम लोग इसीलिए करवा रहे थे कि आप लोग बाहर के सब लोगों को यहाँ पे लेके आएँ, और वडोदरा जो है वो फार्मा में हब है, फार्मास्यूटिकल्स में हब है, पर आने वाले सालों में हम जिस तरह से यहाँ पे डेवलपमेंट देख रहे हैं, वैसे मेडिकल के क्षेत्र में भी ये बहुत बड़ा सेंटर बन के उभरेगा, ये मैं पक्का कहती हूँ। लास्ट मेरी फैमिली में मिक्स्ड हैं, हम लोग ब्यूरोक्रेट्स भी हैं, आई एम एन इंजीनियर, बट मेरी फैमिली में डॉक्टर्स बहुत हैं। माई सिस्टर इज़ अ डॉक्टर, हर हस्बैंड इज़ अ डॉक्टर, माई हस्बैंड इज़ अ डॉक्टर। तो और मेरा ब्रदर है, उसकी पूरी फैमिली में वहाँ पे जो है सिस्टर इन लॉ वगैरह वो सब डॉक्टर्स हैं। आई नो हाउ डिफ़िकल्ट अ डॉक्टर्स जॉब इज़, और आई मस्ट अप्रिशिएट कि उन सब डिफ़िकल्ट सिचुएशन में भी आप लोग बहुत अच्छा काम करते हैं, और ऑल सेड एंड डन, डॉक्टर्स आर द नीड ऑफ द आवर। हाँ, थैंक यू।
We are just inching to the closing. Maharaj, I just want to inform you that today we had a session on Know Your Subconscious Mind. And it was an intensive deliberation by a fantastic speaker from Goa. And if you realize, Adhyatam, spiritual and science, they melt down to that. And he conducted that workshop in a pure scientific, medical way. It was very nice. So thank you all. May I request Team IDCM to please honor all our dignitaries with a memento. परम पूज्य गोस्वामी श्री द्वारकेश लाल जी महाराज श्री जी, मैडम शालिनी अग्रवाल, IAS कमिश्नर, वडोदरा म्युनिसिपल कॉर्पोरेशन, डॉक्टर DP खेतान सर, पास्ट प्रेसिडेंट CCDSI, डॉक्टर मितेश शाह, प्रेसिडेंट IMA वडोदरा, कन्वीनर BJP डॉक्टर सेल सेंट्रल वडोदरा, सीनेट एंड सिंडिकेट मेंबर MS यूनिवर्सिटी वडोदरा, डॉक्टर अभिराम कुलश्रेष्ठ सर, डायरेक्टर जनरल, नेशनल इंस्टीट्यूट ऑफ एजुकेशन एंड रिसर्च, न्यू दिल्ली, डॉक्टर शैलेश त्रिवेदी सर, सीनियर फिजिशियन, कंसल्टेंट डायबिटोलॉजिस्ट, आनंद हॉस्पिटल वडोदरा, डॉक्टर विजय पटनी, प्रेसिडेंट डायबिटीज रिसर्च एंड वेलफेयर एसोसिएशन, डॉक्टर धीरेन पटेल, प्रेसिडेंट एसोसिएशन ऑफ फिजिशियंस ऑफ इंडिया गुजरात चैप्टर, डॉक्टर NK सिंह सर, हेड CME इंडिया, ग्रुप लीड रिसर्चर, academician and national faculty, diabetes and cardiometabolic diseases. With this, we conclude our inauguration ceremony and book release. Thank you one and all. We are truly honored and blessed.
much.
Just checking. Hello, everyone. Hello, everyone. We are going to start our last session. हाँ, डॉक्टर आलोक प्रपन्ना है, डॉक्टर कैजर, डॉक्टर कैजर, मैं बाहर से देख के आई, हाँ, देख के आई। Hello, everyone. We are going to start our last session, and I invite Dr. Alok Prapanna, Dr. Rakesh B. Shah, and Dr. Kaiser to the stage to preside over the meeting. Thank you, sir. Now I invite our first speaker of this session, Dr. Shailesh Trivedi from Baroda. Thank you, sir.
आकर सेटलेस लाइन बना नेक्स्ट मंडे
અને આ શું છે? અચ્છા, એટલે આ બે ચાલશે. તો હું અહીંયા આગળ જ વાત કરીશ. અને આ ચાલશે ને? આ બરાબર ચાલશે? પછી હું વચ્ચે મને કે આની જરૂર નથી, હું વચ્ચે જઈને જ વાંધો નથી.
Everybody knows Dr. Shailesh Trivedi. A very good CV you can see on the screen here. And he was our senior and one of the senior most and most efficient physician of Baroda. And I invite him for the first topic, time to concentrate on comprehensive care in diabetes. Shailesh.
Thank you, Chairpersons. Respected Dr. Khetan sir, Dr. Singh sir, N.K. Singh sir, respected Dr. Khetan sir, Dr. N.K. Singh sir, Patni sir, my colleagues, Shailesh bhai. Before I start, I'll just take half a minute to give all credits, and my words would, fail. In fact, they feel short for the praise what this team has done, headed by Dr. Akash Singh and Dr. Kamaldeep Chawla and Madam, Anuradha Madam. They have done for the first time at Baroda level a national conference. So that is a credit for Baroda, credit for all of us. And we are proud that we have distinguished faculties like Dr. Singh Sahib, Dr. Patni Sahib with us. And in the morning, we had Dr. from Mumbai, everyone, they came and they did wonderful talks in the cardiology. Well, today's topic, as you know all, time to concentrate on comprehensive care of diabetes. I put the red word in the comprehensive because we do take care of diabetes. But do we really take complete care, or do we take fragmented care, or do we offer fragmented care, or sometimes there is a compliance from the patient? Where? Or is there a policymaker problem? We do not know. So this topic needs to be viewed from 3 points. One, from the healthcare provider, from the patient's perspective, and from the policymakers. In that reference, I'm going to give you a bird's eye view from the sky, how the city looks like. Probably I may not give what details we were discussing about the SGLT2 inhibitors, but this is what the summary of the entire, this is a prologue before I start the topic. Well, ADA has already defined that it's a complex and chronic illness requiring continuous medical care with multifactorial risk reduction strategies beyond glycemic control, so not only glucose. And care is, even though standardized, there are various bodies, Australia, Canada, UK, NHS, our own RSSDI body, they have slightly variation as per the geographical location, as per the ethnic changes, as per the lifestyle habits of the people. So this is how it is. And there is a systematic care is not given by you or me. It is not a solo effort. Like these people, what they have done, it's a team effort. So it's a multidisciplinary team approach in a patient when you deal with the diabetes patient, which includes, the most important is diabetes educator. Remember, next to you is diabetes educator, then nutritionist, and food specialist when the occasion arises. But when I examine a patient, now this in the morning, yesterday in the evening, Dr. Sabu was quoting that they are going to start a campaign about the food care, and this year they are going to be on the, why, we must concentrate on the food care. I have been doing for years together. How do? I do not examine the radial pulse. I examine the dorsalis pedis. And when I examine the dorsalis pedis in a diabetes patient, not all, I see the skin, I see the loss of hair and what it is. So this is what it is. Food specialist, yes. Ophthalmologist, his role definitely is important, and sometimes type 1 diabetes psychotherapist, behavioral specialist, and family and social support is most important. Remember, diabetes is not a disease of like you and me in solo, but it's a disease where the entire family is involved in the care, whether it is type 1 or type 2. Like this balloon, like the earth balloon, earth is gradually expanding from 2000 to 2045 as far as the number of patients are concerned, 151 to 629 million in 2041. So this is a diabetes burden which is increasing, almost 4 times in another 22 years. But then diabetes does not come alone. It comes with its friends, particularly obesity, overweight, that almost from 64 million at the present to 120 millions in 245, again with hypertension from 15 to 27, and with dyslipidemia from 82 to 120 million. So we have to look after not only diabetes, these friends as well. Why most of the time, I don't know, have you ever talked? I have started talking like this to my patients, that how do the patients of diabetes die? I ask them very honestly, आपको मालूम है कैसे मर जाते हैं diabetes के patients? But they look at us and they're like, ज़्यादातर 40 से 60% पेशेंट लोगों को हार्ट अटैक आता है, तो वो हमारा फर्ज बनता है, आपका भी फर्ज बनता है. तो we have to see that well-informed patient and proactive team headed by a healthcare provider, that makes a hell of a difference. That makes a great difference. So if you see, CV deaths almost accounts for 66%, 66.3, and non-CV deaths are 33.7. So this is, it may not look good in the first visit, but subsequently when you become a little more friendly, you can discuss about, we are not dealing only with the diabetes. We are going to take care of your entire life. This is again another complication. In one of the studies, it was, total prevalence was, composite prevalence was 62.3, but by and large, the consensus is that, diabetic nephropathy is 34.4. This is the Indian study 2003 by Money, but this is what it is. Diabetic nephropathy, can it be prevented? Or if it occurs, can it be reduced in the progression? Or suppose creatinine is high, can it be still brought it down to lower level? Yes. Those things will come a little later. This peripheral neuropathy is another complication. It is a microvascular complication. Remember, both 90%. 90% of the patients, they suffer from this during their entire lifetime of diabetic patients, whether it's a journey is 20 years, 30 years. And all peripheral neuropathy, those who have diabetes, they have 90% of them, unless proved otherwise, after excluding, it is diabetes. So it is late to appear, usually after 15 years, but it is a very painful neuropathy. And patients, they sometimes tell you that it's, sir, raat ko neend nahi aati hai. It's sleepless nights. This is another friend of diabetes, which is very progressing like, again, a epidemic is about to burst. Non-alcoholic fatty liver disease. The general consensus is that 37.3% of the diabetes are suffering from the non-alcoholic steatohepatitis. This is where the India and South Asia is concerned. Almost 67.1% is there of the South Asia, but this is the general consensus. And of this, they progress to advanced fibrosis in 70%. And again, it is a risk. Remember this, when it is an advanced case of NAFLD, it can be associated with hypoglycemia as well. And once it reaches that, cirrhosis, and unfortunately, few patients that develop HCC, hepatocellular carcinoma. The biggest complication, what I have been talking, is the pre-diabetic conditions also, they also suffer from the same complications, which probably they are not aware of it, but we must make them comfortable that, look, please take care. You are 6%. Sir, border पर है sugar, sir, हम दवाई नहीं लेंगे तो चलेगा, sir. हम exercise करेंगे. They never do exercise. They never follow lifestyle. So here, this is what the 161,000 patient study was done by Jung and others, that cardiovascular disease amounted to 13%, CHD 10%, coronary heart disease, stroke in 6% and 13%. So in pre-diabetes also they have a same spectrum what the diabetic patients have. So remember that it is not pre-diabetes, they are immune from these complications which usually occur after 15-20 years. Right? Sometimes I saw a patient directly with retinopathy few days back only. His HbA1c was 5.9 and he was having diabetes. That's what. CV risk associated with fasting glucose was 5.5 mol, so multiplied by 18, so it comes to 99. Well, it's a common man people. It is the disease for common people and celebrities together, whether it is Kamala Hassan or whether it's these are all heroines, all celebrities. But the highest prevalence of diabetes is found in Chandigarh, which is overall urban and rural, it is 13.6, and prevalence of pre-diabetes is 14.6% in pre-diabetes. Rest, where do we stand? Gujarat. Madam was talking that Gujarat is heading for a big bonanza. Gujarat is overall 7.1 in diabetes and 10.2% in this. I don't know, Jharkhand. Yeah, Jharkhand is 5.3. Good. And pre-diabetics is 10.2. This is the suggested, not extrapolated, but the observational studies. This is from patient's perspective. It's a costly disease. Diabetes, nothing is cheap in this life, whether you go for an Apple phone or whether we are here, whether the lunch is there or anything. It's a costly. Average expenditure for the patient is around 4,500. This was way back in 2013, if I'm not mistaken. 2013, that is by our, right now, who is our PM office, Jitendra Singh from Jammu. That study was 4,500. Now remember, our prevalence is 8%. So 4,500 rupees multiplied by 8, it comes to staggering 36,000 crores. That is in 2013. Now 2020 is almost 1.9 times. So it is surmounting. What is the cost of complication? Medical cost is there, it amounts to 40%. Medical cost of complication, it amounts to 50%. And non-medical cost, like cost of transportation, work loss days, or cost experienced by the caregivers during the hospital, it amounts to 10%. Other cost, when complications happen, yes, it's a hell of a job. I gathered this data from my colleagues who are in the city. Hemodialysis in private practice or a trust. 12,000 is usually the trust, 16,000 is in the private practice. So per month, they spend hemodialysis 12,000 to 16,000 plus 2,000 rupees of the drugs. So it comes to, almost 18,000. Multiplied by 10, it comes to 1.92 lakhs. A patient who is having dialysis, he is spending 2 lakhs extra. I'm not considering the transportation costs, relations who are transporting, Then, what about the renal replacement therapy? In Nadiad, one of the best institute, 6.5 lakhs. In Vailalamin, it is 1 lakh less. I don't know about the Jharkhand, but it must be around the same, around 5 lakhs, if I'm not mistaken. Then stroke, it depends upon the location, whether it's hemorrhagic, non-hemorrhagic. It comes to 30,000 to 3 lakhs, depending upon whether it requires ICU. And if he's a breadwinner, imagine the situation when a residual morbidity is there, and suppose unfortunately it's a right-sided stroke. He's aphasic, and he can't walk. The whole life is gone. So, and PTCA, in Gujarat, average cost is 1.75 lakhs to 3 lakhs plus drugs cost, and that amounts to around 2,000 per month, that is lifelong. And CABG, 1.75 to 3. So patient's point of view, if you think diabetes is okay, 1.9, what we have considered, but then these complications are also there. Now this is what I think we must, all of us, concentrate. In pre-diabetes, before pre-diabetes happens, before that, the inflammation of the pancreas and genetic environment with a family background, these patients are likely to have pre-diabetic when they are when age is more than 45, past history of gestational diabetes or PCOS, or taking steroids for a long time, or HIV medications, or antipsychotic drugs sometimes. All antipsychotic drugs, they come except allopurinol and alperonate. Most of the antipsychotic drugs, they cause hyperglycemia. Here, when it is there, almost 50% of the pancreas, the cells, beta cell functions, they are almost gone, loss of beta cell function before the diagnosis. And remember, 11% of the pre-diabetic patients, they get converted into over-diabetes per year. And 40 to 50% of the patients, they converted every 5 to 10 years. So by 10 years, almost 100%. So we have to concentrate on pre-diabetes group of patients very, very thoroughly. This is how the diagnosis is. I don't think all of you are a learned, distinguished crowd. So, FPG and HbA1c 5.7 to 6.4, HbA fasting 100 and 225. Approximately 50% of the function is lost. And this is another parameter which, makes you concerned. Here, pre-diabetes patients, if they have obesity, it can also lead to, microvascular damage risk is increased. And that is each 5 point, instead of suppose 25, his BMI is 30. So 5-point high BMI at the time of diabetes, diagnosis was associated with a 21% risk, higher risk of microvascular complications. This is in pre-diabetes. So same thing applies to diabetes as well. So obese person, more chances of developing of microvascular complications. These are the standard laid down criteria by ADA, and all of us probably follow. Almost 99% of us follow. Sometimes there is a problem from the patient's point of view. I see my prescription 2019, and now they have an excuse. They said, Corona tha, sir, kya kare? 2 saal nahi aaye. But otherwise also they find some excuse. So all parameters, whatever it needs to be done, A1C every 3 months, if well controlled, 6 months. USCR every year, initial at the point of diagnosis every year, then potassium, lipid panel, LFT, thyroid, vitamin B12 at the time of diagnosis and annually. Now this, again, when we treat diabetes, ultimate goal is what? We want to reduce the HbA1c. And when you decrease the HbA1c, it helps you a lot. This is what it is. When every 1% reduction of the HbA1c, there is diabetes-related death is reduced by 21%, myocardial infarction 14%, microvascular complaint 37%. This is a UKPDS data. Microvascular complaint 37%, amputation or death by 43%. And this is the crux of the story. Glucose-lowering agents in 2000, they were mainly aimed of improving HbA1c. And by 2008, again glucose-lowering agent, but they were glucose-lowering, they were improved HbA1c, but there were definitely increased CV risk and the weight gain and hypoglycemia. That was an era of sulfonylurea and metformin and other things. And then came 2015 era. And at that time, there was improved HbA1c, improved patient CV and renal outcome. These were the first reports in 2015. That was a trial called LEADER, GLP-1, liraglutide. And then we have wonderful molecules, SGLT2 inhibitors. That is 2020. The arrow is now changed from blue to red on this direction. So it improves HbA1c, but at the same time it improves patients' CV and renal outcome. But then it is not pertaining to one SGLT2. Remember this. It is a class effect. And for empagliflozin, renal data is yet to come. But Credence and DAPA-CKD, they are favoring that it reduces the complications by almost 46%. This is a glucose-lowering efficacy of sulfonylurea. Why am I inclined to use sulfonylurea in the first drug? No. Just to, insulin is unconquered. When opportunity, when need is there, insulin does deserve a place, remember. So sulfonylurea is usually started along with metformin, and it reduces HbA1c by 1. But it has its own side effects. But still, you use smart sulfonylurea, that is glimepiride and glyclazide. Metformin, unconquered king, still a first drug of choice. GLP-1 RA, changing the trend of the diabetes mellitus. Glitazones, thiazolonil. Again, remember this is urinary bladder malignancy controversy, it has changed a little bit, black shade over the leaf. Otherwise, it's a good molecule. It decreases the intimal carotid intimal thickness. So CIMT is reduced, so chances of developing stroke is less when you develop this. And again, in a study, in pre-diabetes, metformin reduced HbA1 pre-diabetes by how much? 33%. This, when you use pioglitazone, the HbA1c, the patient was pre-diabetes, did not go to diabetic stage by almost 76%. But the best thing is lifestyle modification, weight loss, exercise, and additional of a pill. Combination therapy, yes, SGLT2 inhibitor change. Glenide, like a same as younger brother of sulfonylurea, DPP-4 inhibitor, a good drug for elderly people, which can be given, it's a neutral, CV neutral and a good drug. It can be given to the elderly people with less chances of hypoglycemia. And AGI, highly underutilized drug. We must utilize unless there are side effects. Oral semaglutide, yes, sir was discussing. It has changed the entire, he was talking just a few minutes back. It has changed, one of the patients lost around 5 kg. And it is going to be a game changer, believe me. Like SGLT2 inhibitor, it is going to be a game changer. The action is very simple. There is only 1% of the semaglutide is absorbed. Remember, but that is effective for glucose reduction, HbA1c reduction, almost in a given favorable condition, 0.8 to 1.5%. And when these are the studies, if you see the dose or higher the side, the highest reduction is 1.7, 1.3, 1.2, 1.3. So these are the pioneer studies. And when they were combined, still better. So this drug, except the cost, it's going to be a game changer. Complication in the diabetes, again I mentioned about this. The EMPA and CANA, it's a class effect as far as the declatremia or DAPA-HF or DAPA-CKD. Microvascular complications in diabetes, when a patient all of you must be getting fundoscopy done yesterday, one of the, Dr. Ramchandani, he showed a beautiful equipment costing hardly 30 to 40,000 rupees, which all of us can have it. And it can easily capture the photograph and it can give you the detailed exit fundus examination details. Of course, you have to get it reported by a qualified ophthalmic surgeon. But otherwise, once it is diagnosed, if it is NPDR, don't worry, control HbA1c. But if it is NPDR, severe NPDR, don't be hankering with your patient that your patient, no. You refer him to the ophthalmic surgeon. He is the right man. Again, the follow-up schedule is there. Leave it to the ophthalmic surgeon when to call and what. Only thing is severe NPDR, they are called every 6 months. Moderate NPDR or severe NPDR every 3 months. Proliferative diabetic retinopathy every 3 months, otherwise every 1 year. Diabetic foot, as I mentioned, examine the pulse, and remember, you are a good physician as well. So, your glycemia, just don't control sugars. Look for the infection, look for the systemic evaluation in detail, because that can be hidden, associated comorbid conditions must be there, which you must try to evaluate. So, evaluate this. Nephropathy, again I discussed about this. Both the molecules are there, whether CANA or DAPA. DAPA is very cheap, good. In one of the Ahmedabad-based companies giving us less than 5 rupees, dapagliflozin. Otherwise, rest of them hovering around 11 to 14 or 15 or something like that. So we are very comfortable with that molecule. Good molecule, almost 46% reduction. But it is not that. You can use credit if your patient cost is not a problem. Go for CANA also. And EMPA data are yet to come. But EMPA-REX study did show the beneficial effects in the nephrology complications also. NFLD, most ignored complication. How do you diagnose? That is most important. A patient who complains of dyspeptic symptoms. सर पेट खाना खाता हूँ, पेट भारी हो जाता है और डकारें आती है. ओके ओके ओके, just try to see whether his liver is alive. No, okay, not alive. Get his SGPT, SGOT. OT is more sensitive than PT. What we have been taught is that PT is more and O is for cardiac. No, OT is more sensitive. SGOT, SGPT, and get USG done. CT is more or MRI, but USG reveals almost sensitivity is almost 99%. So if these two are favoring NFLD, if without involvement of the enzymes, just good control of diabetes. Otherwise, drugs are there. What we have been practicing, what I have been practicing is I give vitamin E 400 milligram 2 times a day, pioglitazone 15 milligrams a day, and saroglitazar 4 milligram at night. That is a fairly good. This ursodeoxycholic acid and all, these are all marketing tricks. Well, it's a two sides of a same coin, whether NFLD or type 2, both of them, they have either it gets converted into type 2 and type 2 again it aggravates the NFLD. So I will not go into the pathophysiology of this. Management of NFLD, that I have already discussed. Well, it has a plethora of, spectrum of type 2. If you have a newly diagnosed, get metformin or sulfonylurea. If you have long duration, where diabetes drugs are a failure, think of DPP-4 inhibitors. Uncontrolled diabetes, you can have additional compound like DPP-4 or SGLT2. Hypoglycemia risk is always to be considered. So both are in opposite. In addition, insulin does deserve a praise. Independent of HbA1c. Remember, SGLT2 inhibitor is a drug of choice and it acts without, and it gives benefits without involvement of HbA1c as well. As sir was talking about the cardiac failure with preserved ejection fraction, still SGLT2 inhibitor drug of choice. So spectrum of CVD, we have a combination and plethora. Hypertension, use ACE or ARB with cilnidipine. Dyslipidemia, statins, fenofibrate. Obesity, lifestyle modification. Nothing, not much in the all chemical, pharmacological pills. Smoking, lifestyle modification, and de-addiction center. Previous MI, SGLT2 inhibitor. High CV risk, SGLT2 inhibitor or GLP-1RA. Heart failure without type 2 DM, yes, now it is a little different. But there also SGLT2 inhibitor does deserve a place. Heart failure with diabetes, again, SGLT2 inhibitor. So SGLT2 inhibitor, there was a once during your young days probably, I'm a compliant boy. I am a compliant boy. I am a SGLT2 boy. I must have more than 20,000 patients right now on SGLT2 inhibitors. Let me be very honest. And as sir was talking, I hardly see any side effects, less than 3% or 4%. About the nephrology, again the same thing. Summary, nothing to read about in between the words. Well, this is the 36 languages. Namaskar, astu, and thank you.
Thank you. Thank you. Thank you very much, sir. The comprehensive knowledge for the diabetes in short.
It was a bird's eye view.
Thank you.
Thank you, sir. Great lecture. Question answer will be taken at the end. Okay.
नहीं, इसमें कुछ पूछना जैसा नहीं है.
Okay, okay.
Everybody knows.
Now I would like to invite our next speaker, Dr. Ajay Tiwari from Lucknow.
नहीं sir, नमस्कार. Sorry.
Dr. Ajay Tiwari, MD, FRCP. He is a fellow diabetes of India. He has done PG deep in diabetes, deep in nutrition diabetes, fellowship in diabetes CMC Vellore, LESO certificate for obesity and management, director and consultant diabetologist, J Clinic and Diabetes Care Center, Lucknow. He is a former faculty, Iraz Medical College, Lucknow, Secretary, RSSDI UP Chapter, President, Indian Podiatry Association, UP Chapter, Vice President, Lucknow Diabetes Study Society, Founder and President, Health Initiative and Diabetes Action Foundation, an NGO dedicated to permeate knowledge of diabetes amongst masses.
Thank you, chairpersons. And at the onset, I'd like to thank Dr. Akash Singh and Dr. Kamaldeep for giving me this opportunity to address this august audience. So, sir has already presented a bird eye view of diabetes management. So now my work will be slightly easy, and I will be focusing on a very important topic, that is diabetes in young. How to differentiate, what are the features, and what are the diagnoses. So there are many gray areas and there are many overlaps. So I'll try to simplify the things, but the oversimplification makes it all the more complex. So please bear with me. So I'll walk you through all this. So as regards to prevalence, as sir was saying, that all studies, whatever IDF Atlas is telling us, is basically based on some observational studies. That is not a concrete data from our country. So we cannot say that this figure, that is 230,000 type 1 diabetics in India. So this is basically a projection. It is not a true data. And this has come from the IDF Atlas 2021. So we have got some studies in India which have shown that the incidence of diabetes in students was to the tune of around 1.47. So that includes type 1, type 2, and the in between, the syndromes and other things. So this has come from the Indian Journal of Medical Research, and what they have said, that diabetes in young has been classically defined as onset of diabetes less than 35 years of age. So this cutoff is also very debatable. So different people have different cutoffs for this, but this is usually accepted. And as per the Indian study, most common etiologies for diabetes mellitus in young are type 2 diabetes, that amounts to around 40% of the patients. Type 1 diabetes mellitus, that amounts to another 40% of the patients. And this is very typical of a few areas in India, that is the fibrocalculous pancreatic diabetes, that is the FCPD, and this is localized. And once we are taking a history, we must understand that the patient has come from these endemic areas or not. So we have to understand that. And Modi amounts for around 2%. So this data also looks to be less, because the newer studies have shown that whatever we are diagnosing as type 2 diabetes, maybe many of those patients, say some studies have shown that around 2 to 5% of those patients would be Modi. And still we are on the nascent stage as regards to the genetic studies, genomic studies for Modi. And then we got a very typical flatbush diabetes, and then we got mitochondrial diabetes around another 1%. So type 1 diabetes, if we talk about young patients, the first and foremost thing which comes to mind is type 1 diabetes. So individuals with first degree relative with type 1 diabetes have an approximately 15-fold increased relative risk of type 1 diabetes. However, at least 85% of children who develop type 1 diabetes do not have a family history of type 1 diabetes. So this is basically, I'm building the block, what I'm going to bring out further on. And the prevalence of type 1 diabetes in the general population by age of 20 years is to the tune of 0.3%. And this may vary from country to country. Especially in Scandinavian countries, we have got a higher incidence of type 1 diabetes. So coming to the presentation of type 1 diabetes, so emergency presentation, the august audience already knows about this, but we can have some non-specific presentations like recent onset of aneurysms in a previously toilet-trained child. So these things have to be elicited, and which may be misdiagnosed as a urinary tract infection. Then perineal candidiasis, especially in prepubertal girls. So these histories are to be elicited. Chronic weight loss or failure to gain weight in a growing child, irritability and decreasing school performance. So that is also one thing which has to be taken into account, and recurrent skin infections. So what we are seeing in an emergency department, that is a different thing, but we can have atypical symptoms also. And these things should force our pediatric friends to rather elicit the entire thing. So we all know about the stages of type 1 diabetes. Stage 1, we have got multiple islet antibodies, normal blood glucose, and this is pre-symptomatic. Stage 2 is multiple islet antibodies, raised blood sugar, but it is still pre-symptomatic. And stage 3 is islet and autoimmunity, raised blood glucose symptomatic, and stage 4 is long-standing diabetes. So this is the pictorial demonstration of what I was elucidating. So this is very important that to begin with, once we start the insulin, so the patients may go into a partial remission or honeymoon phase. So this is very important, and this should be told to the to the parents that this could happen, and they are very happy that the child has already recovered out of this. So this is a temporary phenomenon, and this is because that the insulin requirements decrease transiently following initiation of insulin treatment. This reflects partial beta cell recovery with increased insulin secretion and improved peripheral insulin sensitivity. But this is a passing phase. And then as we proceed, then we have chronic phase or lifelong dependence on insulin. So that is what we see on a clinical basis. Then very important thing is diabetes autoantibody testing. So why it is important to test for antibodies, and this penetration of antibody testing is very, very low in our clinical setups, because diabetes autoantibody testing should be considered in all pediatric patients. Because in otherwise typical type 2 diabetic patients, pre-pubertal children are unlikely to have type 2 diabetes even if obese. So if antibody test is positive, so it is very unlikely that he will have, but there can be an overlap, but unlikely to have this thing. Then antibodies will indicate the diagnosis of type 1 diabetes. We all know about this. Antibodies will indicate the need to consider the presence of other associated autoimmune disorders. So they are very important once we are talking about the pediatric or young age diabetes. Then coming to a word about mitochondrial diabetes. So it is associated with sensorineural deafness. So any child or a young man presenting with sensorineural deafness and diabetes, the thought should go towards mitochondrial diabetes. And the mitochondrial diabetes may present with variable phenotypes ranging from acute onset with or without ketoacidosis to a more gradual onset resembling type 2 diabetes. So that could be very confusing. And it usually presents in the young adults. So, but our thought process should be that if there is deafness and it is sensorineural deafness, then we should think about mitochondrial diabetes. And this term was used, and it was told that in our set of patients, 5% of the patients have flat bush diabetes. So this flat bush diabetes, how does this term came from? And this came because this was a sporadic. Large number of patients were reported from Brooklyn, New York, neighborhood of Flatbush. So they were basically Afro-Americans who had this thing. And these patients presented with diabetic ketoacidosis. And these patients ultimately experienced a clinical course resembling type 2 diabetes. So a typical type 2 diabetes patient presenting with ketoacidosis. So this is something which is a reverse of LADA, what we see in adult age, that is more than 35 years. And then a lot of terms were elucidated for this. So basically this particular chart gives us the entire picture. So either there could be autoimmunity or the beta cell function. So when we have a flatbush diabetes mellitus, we have got no autoimmunity, but we have got positive beta cell function that we get from the C-peptide levels. Then the presentation is like this: severe hyperglycemia, and there is unprovoked diabetic ketoacidosis. So this clinches the diagnosis for a patient with having normal C-peptide levels, typical presentation of type 2 diabetes, but unprovoked decay, then we should suspect the flatbush diabetes. So features suggesting the diagnosis of type 2 diabetes rather than type 1 diabetes at diagnosis. So we all know that overweight or obesity, age greater than 10 years, strong family history of type 2 diabetes, acanthosis nigricans, high risk of racial or ethnic groups, Indians we are also predisposed, and undetectable islet antibodies. So this is debatable. It can be also in type 2 diabetic patients. When to suspect a diagnosis of type 2 diabetes in children may not be correct. So that is very important. We have to look for these things. Young people, type 2 diabetes often present around puberty. So typically a type 2 diabetes patient will present around puberty, and there is, so this is very important that we have to understand that usually the presentation of type 2 diabetes will be around puberty. But if there is absence of severe obesity, lack of the signs of insulin resistance like acanthosis nigricans or other markers of metabolic syndrome, there is a strong family history of 3 generations of diabetes, one parent, and other first degree relatives, unusual distribution of fat such as central fat with thin or muscular extremities, our mind should click that it is not a typical presentation of type 2 diabetes. So features in children initially thought to have type 1 diabetes that suggest a possible diagnosis of monogenic diabetes, that is the MODY. Except for age of diagnosis less than 6 months, none of these are pathognomic and should be considered together rather than in isolation. So usually type 1 diabetes doesn't start before the age of 6 months. So that is called neonatal diabetes mellitus, that presents in the first 6 months, and that is a monogenic form of diabetes. And the family history of diabetes in one parent and other first degree relatives of that affected parent, absence of islet autoantibodies, especially if measured at diagnosis, and preserved beta cell function that we get from the C-peptide levels. So then this is the gray area. So there could be gray areas because there could be lot of things which could be overlapping. So with obesity is now a pandemic. Before diabetes, we have a pandemic of obesity. So as many as 30% of the newly diagnosed type 1 diabetes or patients with monogenic diabetes may be obese. So this is to be taken into consideration. A significant number of pediatric patients ultimately diagnosed with type 2 diabetes mellitus may demonstrate ketonuria or ketoacidosis at diagnosis. So that should also be taken into consideration. Type 2 DM is common in general adult population with a positive family history for diabetes in 15% or greater in minority populations. So these are the gray areas, and that's why I wanted to discuss with you. And measurement of insulin or C-peptide is not recommended as a routine test. And there is a considerable overlap in insulin or C-peptide measurements between type 1 and type 2 diabetes patients. So early on, in the usual start of the first phase of the type 1 diabetes, we will have a significant amount of C-peptide levels already there. So there is still an overlap. And in addition, the insulin resistance of obesity may raise residual C-peptide levels in obese adolescents with type 1 diabetes mellitus. So all these things have to be taken into consideration. Then insulin resistance is present in both type 2 diabetes and type 1 diabetes patients, though the pathophysiology is different, and measurement of diabetes autoantibodies is the most rigorous approach to identification of type 2 diabetes. And with the amount of and the tests that are being done at our centers, I think it is still very debatable, and we don't get good readings as regards to the usual antibodies that we are giving to the labs. Then coming to MODY, I think this is something which is usually overlooked, and this is in heterozygous monogenic mutations in one of the 6 different genes, autosomal dominant inheritance, onset of diabetes early in life, childhood, adolescence, or young adulthood, and primary defect is in the insulin secretion. So these are which is the most common one. So it presents with the glucosuria, and then we have got HNF1 beta that is associated with renal malformations and genitourinary tract anomalies. So these are some clinching points which can point that this could be the specific thing. So these are the different ones. We know about 14 possible genetic mutations associated with MODY till date, and the testing for MODY is also becoming easier because many of private labs have come into this forum. So if you have a GCK mutation, so the most important things you have to see is the fasting hyperglycemia. So this is a very slight rise in fasting blood glucose levels, somewhere around 99, 100 mg%, not more than that. And the OGTT, the increment of 2-hour fasting glucose is small, and the HbA1c never exceeds 7.5%. So this GCK could be a problem only during pregnancy. So there is where most of the GCK is picked up also. Then familial diabetes due to HNF1 alpha MODY and HNF4 MODY. So the most important, this is the most common one, monogenic diabetes, and it is in family, and the basic important points as regards to this is that it is the increment in blood glucose is around to the tune of 80 mg per dl. So if you are doing a fasting sugar and a postprandial sugars, the postprandial sugars, the increment is very, very large. And at a very low level of sugar, we are having glucosuria also. So young onset of diabetes typically before 25 years of age, at least one family member is associated with that. Three generations we can have non-insulin dependent outside the normal honeymoon period. If not developing ketoacidosis in the absence of insulin, good glycemic control on less than the usual replacement dose of insulin or detectable C-peptide levels measured when on insulin with glucose more than 8 millimole per liter. So these are the clinching points which will pick up that this is not a case of type 1 diabetes, it is a case of H1F alpha. And we have a family history of diabetes, at least 2 generations. And this may be, so you will not know that the parents had MODY. They will be obviously be labeled as a type 1 or type 2 diabetes. So you just have to have the history that there is a history of 2 generations of diabetes. And especially ask about whether the parents became diabetic at an earlier age. So that will give you a preview that it could be MODY. So why it is important to know about pregnancy, and this is very important that we have to understand. And now coming to a very typical presentation which is restricted to some particular states of the country, that is the FCPD, that is the fibrocalculous pancreatic diabetes, is one of the unique and rare varieties of diabetes mellitus secondary to chronic calcific pancreatitis, resulting in inflammatory changes, and this can affect both the exocrine and the endocrine portions of the pancreas. So typically when you will do these are the diagnostic criteria, patient should be from a tropical country, diabetes should be present, evidence of chronic pancreatitis must be present on CT scan or an X-ray, and recurrent abdominal pain since childhood, and steatorrhea. So this will be, this you can elicit that if there is a steatorrhea, fatty stools are there, and if you do an X-ray, you can pick up these type of calcifications of pancreas. So another case, these are not my cases, I have already taken from the book. And so finally, once we combine everything that I have been telling you now, so this is the pictorial description of what I told to you. If there is a family history of diabetes mellitus, if it is positive and 3 generations positive, ketonuria negative, C-peptide fair, responsible to sulfonylureas, no obesity acanthosis, you should suspect monogenic diabetes, 3 generations history, family history of diabetes mellitus negative, ketonuria negative, C-peptide good, response to metformin, obesity, acanthosis, you should think of early type 2 diabetes mellitus. And the family history of diabetes is negative, ketonuria positive, obviously we are going to have type 1 diabetes, autoantibodies negative, then we can think of idiopathic type 2 diabetes mellitus, autoantibodies positive, autoimmune type 1 diabetes. And if ketonuria is negative, C-peptide poor, abdominal X-ray shows calcifications, pancreatic calculi present, then we should think of FCPD. So this is a chart of the entire spectrum of the diabetes in young, how it presents. So everything has been told. So this was just to summarize the talk. And thank you very much for your patient hearing.
Thank you, doctor, for a very informative and excellent talk.
Thank you, doctor. Excellent talk. So we will take the question answer session after the last. Okay. I would like to invite our next speaker, Dr. Parag Rana from Baroda.
Welcome, Dr. Parag Rana.
Thank you, sir. I don't need
welcome,
thanks. You can skip it.
Introduction, dynamic diabetician.
So essentially, today, my talk will be divided into 3 parts. One is what I learned new at ADA New Orleans. 2 things which I was not so much aware of it. One was glycemia risk index, which was new for me. And second is how do I actually work a workflow in my patient who walks into my OPD? How do I manage my diabetic patients with NAFLD, in general NAFLD fundamentally? We knew NAFLD since long, but not really, I was not clear. After this New Orleans session, my vision became very clear, so I thought to share with you. Third part would be some revision of the time in range. which we all know, but I believe that revision won't matter because we all knew, but we would revise that also. So as I told you, two things I learned at New Orleans ADA. One is regarding the glycemia risk index. It's a research tool, but then it's going to come in practice in few years, in couple of years soon. The ACC released their guidelines on May 12, 2022, which were also part of the New Orleans Symposium. So that one thing I thought to share with you. This is the revision. Basically, time in range refers to the percentage of the time person spends in the blood glucose levels with the target range. We all know it is 70 to 180 milligram per deciliter. 70% of the time they need to manage their sugars into that range. Percentage of time above range and below range. So more than 180 and less than 70. That's what we call it as time above range and time below range. Why we required time in range? Why we required CGM? You know, HbA1c would evaluate only one single HbA1c levels, whereas your time in range would evaluate the continuous glucose levels. HbA1c would compare your levels of 3 months apart, you can compare, whereas the time in range, it would compare the fluctuations for any given amount of time. HbA1c testing does not capture your hypo or hyperglycemic levels occurring in the same day, whereas your time in range would capture all glucose levels for the given time frame and identifies time within a safe range. And lastly, it is less likely to capture impact of acute intervention. You did some insulin doses changes, you won't come to know in HbA1c. Whereas in this time in range, you will be able to capture the impact of the acute interventions. So probably it's time to move on from HbA1c to TIR. TIR goes beyond HbA1c in representing the blood glucose levels because it captures variation, the highs, the lows, and in range values that characterize the life with diabetes. Worldwide, we have 4 devices of CGM. One is the Dexcom, second is the Eversense, third is the Abbott Freestyle, and fourth is the Medtronic. In India, we have 2 devices available. One is Abbott Freestyle and Medtronic Guardian, glucose management indicator, and how it is different. Science is still not very clear about it, but then I will tell you some things about that in next slide. Glycemic variability, target is less than 36%. So these are the standardized CGM metrics. This is how we interpret and this is how we tell to the patients. Why this happens in practice? Because only 19% of the estimated and measured HbA1c values are matched. 50%, 51% differed by 0.3% or more, 28% differed by 0.5% or more, 19% differed by 0.6% or more, 12% differed by 0.7% or more. Now the question is, what do we do? Because patients in front of us, what do we explain? So what I generally follow this is what generally I see. If the A1C and GMI, if it is more or less stable, difference between HbA1c and GMI is stable, and if your A1C is more than glucose management indicator, then there is a risk of hypoglycemia with therapy intensification. So this is the only thing which I look when I look into AGP report for this GMI. And if the A1C is less than GMI, if the A1C is less than the glucose management indicator, it means that more intensive glucose control can be targeted based on the HbA1c reading with less risk of adverse hypoglycemia. I found this to be very important in managing these patients. And if it is too much significant, I ignore that, because then in that case you have to find out that there is some intercurrent illness or drug treatment, affect glycation rates, investigate it. I just ignore that, forget it. Now this is a glycemia risk index. A has not been printed. Glycemia risk index, what is that? Now the question was that people started to understand that in time in range, we are looking for hypo and hyperglycemia, but we did not look into very high and high, very low and low hyper and hypoglycemia. So these were the places where people thought that some fine tuning of time in range is required. So people started to devise a matrix which is being researched currently that combines the 7 of your CGM metrics, which I have just discussed, including TIR, into a numeric score which is from 0 to 100, and that numeric score, as we'll discuss further, will help us in adjusting. It's a fine-tuning tool that would help in adjusting our insulin doses in a much better fashion. So this is a glycemia risk index of hypo and hyperglycemia for CGM validated by the clinical ratings. So essentially, this is very important. It incorporates time in very low and low hypoglycemia, in very high and high hyperglycemia, because that differentiation was not there in TIR. And time, along with time in range to yield a percentile number from 0 to 100. Now, this number is ultimately mashed in a grid. There is a ready-made format available, and there is a formula available. So in the formula, you have to put down entire stuff, and then you get a figure. This is a percentile figure, which is put in a grid. Ready-made sheets are available. And then on the grid, you put TIR as well as this. I will come to that later. So this number gives providers a quick way to assess the glucose management with a low number indicating better glycemic control and a high number indicating worse glycemic control. See, in TIR, we said we want it to be 70 to 180. Now, lower your number, you are better off, because this means that you have low variations of hyper and low variations of hypo. Hypo and hyper are going to be there. Flat, narrow, and gold range. That flat, narrow, and range is difficult to achieve in the clinical practice. Some variations would be there, but then to a great extent, you can achieve that. So, when they talked of glycemia risk index, they took into account these things. We talked of hypo and hyperglycemia. Now, so now we are talking of less than 70, less than 54, more than 180, more than 250. So these time in range, time spent in severe hypoglycemia, time spent in hypoglycemia, time spent in hyperglycemia and severe hyperglycemia. So essentially glycemia, this GRI is all about the find very high, very low. You just put all the values together and then you get a figure. And glucose variability and your average glucose. Now this formula is pretty complex. I need not go into details of it. It's available online. But fundamentally, when you put this is the formula. When you put this formula is equal to 3 into hypo component plus 1.6 into hyper component. So how do you revise the hypo? Why this very low is important? Why this very high is important? Because that comes as a figure into that. So when you talk of hypo component, there is another formula where very low plus 0.8 into low. So that is how you deliberate and you try to minimize those hypo and hyperglycemic variations, and then it is classified into 5 zones, percentile zones. And as you can see in this figure, the final chart happens, and this final chart would actually tell. Now this, you can see there are 5 zones into this. Sorry. 5 zones. Now this last green zone, if you can see, it is written as GRI 10 and TRI 91%. And you see the first zone, GRI 90 and TRI 46%. So TIR is 46, GRI is 90 and TRI is 91 and GRI is 10. So lower the GRI, you have better control. So that is why, remember this is a very important concept, that the difference between GRI and TIR is that GRI is higher when the glycemia is worse and TIR is higher when the glycemia is better. Both are on the 0 to 100. So you have to achieve somewhere in between fundamentally. If the pattern of glycemia is poor, then the grid portrayal of the GRI indicates whether the problem is too much hypoglycemia, too much hyperglycemia, or both. So you may be happy with 70 of TI, 76% of TIR, but then no, you need to look into it. That's what people are thinking. Still in the research phase, but maybe it will come gradually. Now, I will be talking very fast on this diabetes and NFLD. What I learned was that fundamentally, this is the slide which I would rush through because you have seen this. Any diabetic patient walking into our cabin is, type 2 diabetes has got 55% prevalence of diabetes, the NFLD among type 2 diabetes patients. Overall global prevalence of NASH among type 2 diabetic patients is 37.3%. And 17% of the biopsy diabetics have advanced fibrosis. So this we all know that whenever you have type 2 diabetes, It increases the risk of steatohepatitis. It increases the risk of cirrhosis. It increases the risk of hepatocellular carcinoma. And NFLD would worsens the insulin resistance by increasing the risk of atherogenic dyslipidemia, increase the risk of type 2 diabetes, and increase the risk of cardiovascular disease. We all know NFLD, somebody who doesn't take so much of alcohol. What do we mean by so much of alcohol? So essentially, you have accumulation of fat in the liver in the absence of recent or ongoing intake of alcohol. 20 gram per day is the reasonable amount for the cutoff limit for alcohol. Now, what does 10 gram of alcohol mean? 10 gram of alcohol means 240 ml of beer, 100 ml of wine, and 30 ml of whiskey. Double to that is the amount which they are talking of anyway. So, whenever the fat goes into the liver, at first stage your non-alcoholic fatty liver is a spectrum. When the fat deposits into that, it deposits into that, what happens is that you enter into stage of inflammation. Inflammation causes early NASH, then liver heals by fibrosis. That's why you have fibrotic F2, F3, and then you have cirrhosis. This is all we know very well. This is natural history. Now, this is the only slide as a carry home message. This is what the most important part of the entire lecture, because this is what we are going to practice in day to day. So any patient of type 2 diabetes walking in your cabin, somebody coming with raised transaminases in your cabin, somebody coming with report of your grade 1 fatty liver in your cabin, how do you manage? Lot of scores, we had read lot of things on NFLD, this score, that score. Forget everything. You just need to remember 3 things. One is a FIB-4 index. Second is the FibroScan score. And third is the ELF levels. If you know these 3 things, the story gets over. And the job becomes very easy for us to navigate the patient throughout this jungle of this NFLD. So how do we do that? The moment we talk of this FIB-4 index, what is FIB-4 index? Very simple. FIB-4 is basically, you need to know the patient's age, you need to know the AST levels, you need to know the ALT levels and the platelet count. Only one score to be remembered from today onwards. These are the AACC 2022 May 12th released guidelines. So very recent, nothing more than that. Now, when the FIB-4 index, when you put these things into calculator, ready-made calculators are available. When you put them, you get a figure, 0.91, 1.2, 1.3. So remember the figure. The cutoff line is 1.3. If the figure comes 1.3, forget your diabetic patient to be screened for further NF. You don't need to screen. If it is less than 1.3, he has got a very low risk. Forget the story. If his value of the FIB-4 score, which needs your SGOT, SGPT, age and platelets, only these parameters available as a ready-made calculator on net. So, if the score is 1.3 to 2.67, then you are dealing with the intermediate risk. Then you need to order second test. Which second test are we talking of? We are talking of FibroScan, which is called as liver stiffness measurement by elastography, which could be FibroScan or MR elastography. But when we talk of this LSM, the values measured in the FibroScan is by KPA. So, when you ask for FibroScan, few things you should know. If your patient is obese, ask your FibroScan operator to use a bigger prof, number 1. Number 2, if your patient is obese and if your city has got MRE, which we don't have, in Bombay Hiranandani, they have just installed. MRE installation costs 75 lakh rupees. If you have it, you are lucky. Then in that case, you can go for the MRE, which is the most sensitive marker for this NFLD. And ELF has generated a lot of interest in US. In fact, they are telling that forget everything, go for ELF. What is ELF? I will come to that. ELF is a blood test. This blood test is enhanced liver fibrosis test. That measures 3 molecules involved in liver matrix metabolism to give a score reflecting the liver fibrosis. What are these 3 markers? They are the direct markers of fibrosis, hyaluronic acid, procollagen 3 amino terminal peptide, and tissue inhibitor of matrix metalloproteinase TIMP1. Now this is available with Dr. Lal's path lab in 4,500 rupees. So this test you can very much, and it's a very subject, so you won't have, in FibroScan, there is operator dependent test. You have obese, there will be issues. So those issues won't be there. Now, the liver stiffness measure, so as I said, 3 things to be remembered. First we did FIB-4, 1.3 1.3 to 2.67 is your intermediate. More than 2.67, it is high risk. Send them for liver biopsies. Stage it F1 to F4. Forget the story. Refer to hepatologist. Story is over. But if your patient has got a liver stiffness measurement is less than 8, he is low risk. If the liver stiffness measurement is 8 to 12 kPa, it is intermediate risk. And if it is high risk, if it is more than 12 kPa. So essentially, the take-home message is very clear. 3 tests, 3 figures to be remembered when you interpret. FIB4, 1.3, 1.3 to 2.67, more than 2.67. First part. Next cutoff is fibroscan. Fibroscan less than 8 kPa, 8 to 12 and more than 12, story over. And if you can afford this ELF test, if you can manage for this ELF test, and then this figure is 7.7, less than low risk, 7.7 to 9.8 and more than 9.8. This only 3 things you need to remember for this NAFLD and diabetes, because there is nothing else. So this has been extremely simplified, and this, once you understand this, then it becomes very easy to navigate in the day-to-day practice. MRI is another technique. This MRI proton density fraction measurement is also another thing. These new tests going fast for NASH, nothing much. And last slide of the lecture, diabetes management in NAFLD. This we all know. Need not, I won't discuss everything. Generally, what is, we just need to remember low risk, intermediate risk and high risk. Your FIB4 index, your fibroscan levels and fibroscan report and your ELF levels. 3 things you need to remember, then you divide it. General goal we all know. We need to optimize the glycemic control using preferred agents that reverse steatosis wherever possible. We all know. We need to prefer GLP-1 RA and SGLT2 inhibitors in CVD, prefer SGLT2 in CKD and heart failure. These all are routine. Dietary recommendations, we all know, nothing great. Glycemic reduction by emphasis on whole food carbohydrates, vegetable, legumes, fruit versus sugar and processed carbohydrates. Target of HbA1c, less than 6.5 for persons without concomitant serious illness. We don't want this to progress, so that's why. And more than 6.5, patients who has got a risk otherwise. In advanced cirrhosis, we all know, caution, we manage accordingly. Preferred medications for pharmacotherapy in low risk would be pioglitazone, GLP-1R and SGLT2. These are the 2022 May 12 released guidelines of AACC. And strongly considered agents in intermediate risk, so pioglitazone, GLP-1R. In fact, the study of semaglutide is going on, 2020 is going to get over. For this NASH, for this study, they have not for NASH, it reverses. Significant improvement. We all have put the patients on pioglitazone, saroglitazone, liver enzymes have come down. Day in, day out, we have been seeing that. These are the proof of the pudding. And strongly considered agents in high risk, pioglitazone, GLP. So this individually we manage, nothing much to be done. And last recommendations in the slide they are telling us about is metformin, sulfonylureas, DP4, acarbose and insulin. May continue but limited benefit in liver histology in NAFLD. You may continue in intermediate risk and high risk, though we know we all use insulin. I think that is all I wanted to convey for today's lecture. Thank you.
Thank you, Parag, for accurately elaborating the accuracy we need beyond HbA1c as well as NAFLD.
आपका रह गया है ना, देखिए मेरा हो चुका है पहले से। अच्छा, आपका हो गया है?
4-5 बार तो मोमेंट तो सुबह ही हो गया। 4-5 बार तो हो चुका है। कितना फेलिसिटेट
नहीं, अभी देखिए ना, आपका बचा हुआ है ये।
मेरा हो चुका है ना ये।
अच्छा,
सुबह ही हो गया है।
कैसे? अभी ये तो हम चले गए थे ना इनॉग्रेशन में।
किया ना अभी। हाँ,
नहीं, फिर से होगा आपका। हाँ,
अभी मोमेंटर रहने दो। अभी जो जिनको नहीं मिला उनको तिवारी सर को, डॉक्टर पराग राणा।
अच्छा, इनको देते। अच्छा, हेलो। Thank you everyone for such a nice presentation. So let's start felicitation program. So I would like to invite Dr. Alok Prapanna to felicitate Dr. Shailesh Trivedi. Dr. Shailesh Trivedi.
Dr. Shailesh? Okay. Okay. So I would like to invite Dr. Alok Prapanna to felicitate Dr. Ajay Tiwari. Thank you, Dr. Prapanna. Thank you, Dr. Ajay. Now, I request Dr. Rakesh B. Shah to felicitate our next speaker, Dr. Parag Rana. बस हो गया ऊपर का भी देंगे किसी का प्रताप जेठ निकल गए और ये तो आए शेवाल है डॉक्टर शेवाल
Trivedi.
Okay. I invite Dr. Kaiser to felicitate Dr. Sheval. Thank you, Dr. Sheval. Thank you, Dr. Kaiser. So, okay. I would like to invite Dr. Akash Singh to felicitate Dr. Rakesh B. Shah. Thank you, Dr. Akash. Thank you, Dr. Shah. Now, I would like to invite Dr. Dishant to felicitate Dr. Kaiser. I request Dr. Dishant to felicitate Dr. Alok Prapanna. Thank you, Dr. Alok. Thank you, Dr. Kaiser. Thank you, Dr. Dishant. Thanks everyone for your patient listening. And I thank you on behalf of IDCM organization to all our esteemed faculties and our chairpersons for being part of this organization. Thank you.
Thank you all to joining us over here. And I request all of you to join for the gala dinner here only at 8 p.m. Thank you.